People is arriving. Sorry for the delay. It's a short delay, but we are going to start in three or 4 minutes, okay?
Hola. 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 Sí, aquí estoy yo, que lo he visto.
¿Y yo?
Tú estás ahí, creo, ¿no?
Estoy allá.
Vale.
¿Y los de la Ciudad de Nico? ¿Dónde están?
No lo sé.
No están, no bajan.
Hi, good morning, everyone. Welcome to the 7th ICO-Symposium on Tobacco Control. I'm Dr. Cristina Martinez. I have the privilege to be the head of the Tobacco Control Unit at the Catalan Institute of Oncology. And I would like to start this symposium by welcoming our distinguished authorities, Dr. Gullón and Dr. Fernandez, Public Health Secretaries of Spain and Catalonia, respectively. Unfortunately, our director, Dr. Brunet, is not here with us because his father passed away yesterday, so we are sorry that he's not able to be here, but he has gave me his regards and also welcoming messages for all of you. I would also like to offer a special welcoming to all of you attending this symposium, both in person and online, because this symposium is streamed online, who have set aside this day in order to join us. So it's my honor to be here presenting this symposium, surrounded by colleagues and partners who have shared a commitment to advance in the fight of tobacco epidemic. This symposium is the result of the dedicated work and enthusiasm of every member of the Tobacco Control Unit, and we have worked fiercely and tirelessly to prepare the program we hope that you will find inspiring and thought-provoking. This year, our focus is on taking decisive action on tobacco control, and the program has been designed to review the current state of the tobacco epidemic and the policies that have been proven to be effective. We firmly believe that now is the perfect moment to act. We know that there are challenges, and we know that what things need to be implemented, but we need to implement them. It is necessary to require effort and introduce policies at the national, regional, and organizational level. Over the course of the day, we will engage in 5 different sessions. We will have a review of the results of the WHO convention framework. After 20 years of passing this framework, we will discuss the strategies to promote smoke-free policies in those places and also in non-regulated places. We will learn about the latest scientific evidence on nicotine and tobacco product regulation. We will explore how to implement evidence-based interventions into practice. And we will hear the insights from young researchers on the future of tobacco control research. The symposium has been prepared, as I have mentioned, with a lot of enthusiasm and significant effort from several members of the Tobacco Control Unit, including Clara Mercader, Clara Fabregas, Ana Mar Lopez, and also my colleague Olena Tigova, who will help us to transition smoothly from one session to another session, in order to ensure that the moderators are kept to the schedule. I'll also like to encourage you to full advantage of this symposium, not only because we have a very outstanding program, also because it's an opportunity to you to networking and reconnect with old colleagues and forge new connections with new ones. Thus, before the lunch, that is the time for the networking, we have also the time for a photo to commemorate this day and create lasting memories. Finally, I wish you to have a very productive and inspiring day. I'm confident that the discussions and collaborations initiated here will drive meaningful progress in the tobacco control. And thank you very much. I hope that you enjoyed the session and the symposium. And I want to give the floor to the Secretary of Public Health in Spain, Dr. Guyon.
Thank you, Cristina. Thank you, Esteba. It's a pleasure always being with you, and thank you, Angela, for being here with us in this first table to welcome to this meeting. For me, it is a real pleasure to come here to the Institut Catalan of Oncologia, as this is the place where before I was in the Ministry of Health in Spain. This was the place where I should go if I wanted to know something about tobacco, because they are the ones with the better connections with the best evidence, and Cristina, Esteve, and all the people that work here have been always an inspiration for doing research that can be applied to better policies to reduce the harms of tobacco. So thank you very much, and thank you very much to all the people that have come here to this meeting, as they are always important. So taking action, using evidence, and doing policy. So here the different worlds of research and action, and we are very happy to be in the same place, because we have the things clear of what we can do, but we need this strong collaboration always to get the steps forward. I would say that for me, as the General Director of Public Health in the Ministry of Health, have been a really interesting year in terms of tobacco control. Here, the part of my team of the tobacco control unit in the ministry, and they have worked so much this year. We were able to approve a new plan of tobacco control in Spain. So in the next years, we will see some different actions to reduce the number of people starting to smoke. Also, actions to help people to quit smoking, actions to protect the non-smokers and the environment, and actions to implement more research and better research, and also to create a network of people that want to fight against tobacco. Here, and this is part of this network that we are creating, and that is so important for doing policies. I think it is very difficult to imagine how important these type of collaborations are for us when we are trying to do policies. This plan includes different types of actions that we can do in the healthcare system, educational, etc. But all the focuses are always in the legislation part. So at this moment, we have a new legislation that we want to pass in the first months of 2025, where we are trying to get this new evidence of tobacco products with e-cigarettes, with nicotine pouches, and with also with e-cigarettes with nicotine and without nicotine. So all the new products, well, this kind of new, but they're in the market for quite a long, but all the regulation for these products that at least at the national level they were not regulated before. So we have this opportunity to move forward in that direction, and hopefully we will see next year also a new law on smoke-free places on tobacco in Spain. That it has happened since 2005 in the first place, and then 2010 that we have no legislation to change the smoke-free places in Spain. So we are very happy that we have this opportunity to work in that. And being here, where we are discussing today the evidence of these kind of policies, it will be safe. It's going to be a safe place for us for talking and see how to move forward in the future. Things that we are not doing, we are not considering. Things that we are considering. That's always a pleasure to learn from all the people that in this kind of environment with research, WHO, people from different administrations, regional, at the state level, etc., can learn from each other. So I hope that we have a really wonderful meeting, and I'm here until the end to learn about everything. So thank you very much for being here.
Thank you very much, Dr. Gullón. I give the floor to Dr. Fernandez.
Thank you, Dr. Martinez. Thank you very much, Cristina. For me, it's a very special occasion, sincerely speaking, because the changes I have suffered in my job. Usually, I was introducing this symposium and inviting some people to provide thoughtful words and so from the government. And now, for me, it's a bit rare, let's say, because I have been invited as Secretary of Public Health, shifting my role. But I'm even more happy than before. It is this symposium. I believe it's sorry. It's an evidence that things can improve, and that research, action, policies, usual care, health providers can act together to form one objective, in this case, tobacco control. It's not only a thing of making people quitting, it's not only a thing of health promotion and making kids to try them not to start smoking. It's not only a thing about publicity, or it's not only a thing about WHO guidelines. It's not only a thing about many other things, because tobacco control is very complex. It's multifactorial, and from the different fields in which we are involved, we can work together for tobacco control. Also, being in this side of the table, let's say, gives me the opportunity to be more conscious about the magnitude of this small event. So we started. Now I have two, or I used to have another hat. Now I will be talking with one hat or with the new hat, mixing a bit. We started more than 10 years, in fact, in 2012, with this activity as one of our collaborations with WHO, and with the idea of bringing to Barcelona something of the international scene in tobacco control, with a twofold objective, implicating researchers, public health practitioners, GPs, etc., and other people in Barcelona and in Catalonia, and making them together with people from international, with other countries, with WHO. Also, making the tobacco control unit of the Catalan Institute of Oncology the catalyst of all this. And I believe that after 12 years, the reality, and now I'm living from the other side, is that we are achieving the different objectives. The symposium started with a more Spanish vision, because at that time we were very worried about the recent legislation in our country that had been followed by other countries in the world. And everybody, or almost everybody, was talking about the Spanish model that was promoted for the tobacco industry. And a lot of things have changed since then. We have had different topics, or the symposium has had different topics. We were also very pioneers on talking about electronic cigarettes. Also, we have reflected here about the challenges ahead, the Framework Convention on Tobacco Control, and also how, 8 years ago, how can we bridge the gap between research and policies. So, and the pandemic arrived. At that time, we were very concentrated with the end game, and also past year we were talking about how to continue our work from tobacco control to tobacco end game. And I was very happy knowing that this year the topic or the general aim of the symposium is taking decisive action in tobacco control. And if you see, no, it's not here, or at least in the publicity or in the leaflet and so on, decisive action is in bold. So I believe that it's time to take decisive actions. This doesn't mean that we haven't done actions, and very good actions till now. But one of the dangers in tobacco control, not only for the public, but also for researchers, policymakers, and so on, is to think that we have arrived to a comfort area in which we have done a lot for tobacco control, and because we have, and we can objectively see how we have progressed, the indicators are very well. Not only the prevalence of smokers, that in Spain is not extremely good at present, but many other indicators. We don't see publicity in the media. We have a lot of things. Prices are increasing. So more or less, all the countries are following the power measures. The last report from WHO was also encouraging. If you want to see the encouraging part of the book, this is like seeing the bottle, but with the report. But we can fall in a self-compliant about we have achieved a lot, we have done very well, don't worry, we are progressing. We have to be worried because we need to progress even more. And this is very important. And I believe that the topic of this symposium, taking decisive action in tobacco control, is more than ever needed today. Pedro was my colleague, Dr. Pedro Gullón, the General Director of Public Health in Spain. Well, he's very happy because the government of Spain, and we are also very happy, because our government is promoting new legislation that will progress during, well, next year. And I believe this is very important. But as I was mentioning at the beginning, new legislation or legislation is not enough. We have to work together to build the consistent evidence to promote legislation. But in tobacco control, there are many fields that go beyond legislation. This is clear. We cannot regulate what about smoke-free spaces in some places. We have to promote, health promotion in this case is very, very important, linking tobacco control with other policies within the governments. So let's take decisive actions in tobacco control, or I should say for tobacco control. As I said previously, I'm very happy to be representing the government of Catalonia here. There is a commitment from our Department of Health in tobacco control and in the promotion of other healthy lifestyles and promoting them together. That this is also a very important thing, and linking them with other health conditions, social determinants of health, and of course commercial determinants of health. I believe that this symposium will be another step, and being here sharing all these things from many places, because I can see a lot, I can see people now, and I know that other people is arriving because they are in the program, and also mixing our powerful people here in Barcelona and in Catalonia with other people coming from other points of Spain being represented here, and with our international colleagues, not only from WHO and attending, thank you also, because of the cooperation between WHO and the Catalan Institute of Oncology, but also other colleagues from other parts of the world. I believe that we are here more than 4 continents right now. And I'm very happy for this. So nothing more, because I like to speak, you know, sorry. But, well, I'm also a bit, affected by the fact of being introducing this symposium that I love very much. Thank you very much.
Thank you very much, Dr. Esteva, for giving a flashback about the history of the symposium and also giving some context about the situation in Spain. Thank you both for your words, and also I want to welcome and introduce my colleague who also has been coordinating this, the agenda of this symposium, my colleague, Dr. Angela Chibao from the WHO, who is going to give also some welcoming words for all of you.
Thank you, Christina. Dear Dr. Guillaume, dear Fernandez, dear colleagues, ladies and gentlemen, it's a great pleasure and honor for me to be here and to open the 7th symposium on tobacco control. For me, it's the 3rd one that I'm participating, starting with the first that we started online in 2000, and now moving to the offline hybrid in the last time, and in person this time. This biennial event brings, as Fernandez mentioned, advocates, different experts from all the countries, just to discuss critical topics and share the mission to combat the tobacco control. I extend my also hardest thanks to the Catalan Institute of Oncology, one of the very active WHO collaborating center, for organizing this event. And I also would like to thanks to bring the gratitude to all the experts in tobacco control, participants, partners, for your dedication, perseverance, and hard work, really hard work. Next year, we mark a significant milestone, the 20 years from the entering into force of the WHO Framework Convention on Tobacco Control, which was adopted in 2003. And in parallel, we also looked ahead to UN high-level meeting on the NCD, which is just 39 weeks ahead. And this raised, I think, a question, where we stand on implementing the WHO FCTC and reducing tobacco-related deaths, disease, and addiction. And are we on track as a region, but also as each the selective country, to achieving the target that we established for 2025 and the target for 2030? On the positive note, as Fernando mentioned, yes, some countries, they have the declining trends. And overall, yes, we have a decline. And many countries are strengthening legislation. Even some countries are quite leading in this area. But at the same time, the situation is not so good in all the countries. We have significant challenges. Progress of the most cost-effective measures, as you mentioned, the tobacco taxation, the enforcement of the smoke-free policies is quite weak. And alarmingly, only 20% of countries in our region have a comprehensive cessation services. With 25% of adults in our region still using tobacco, we face one of the highest prevalence globally. And if we will not reduce at the region level, by 2030 we'll be at the first line. We'll be the region with the highest prevalence. The situation is alarming, particularly with women, with 18% using tobacco, exceptionally high figure globally. Is only region with such high level of the use among the women. Moreover, as everyone mentioned, the landscape is evolving rapidly of different products, the tobacco, but also nicotine products. New products are flooding the market, and many countries lack adequate regulations. Many. Aggressive marketing has driven the surge of the electronic e-cigarettes, particularly among youth, with the prevalence in some of the countries that among the 16 years are achieving the 40%. 40% in some countries. Another pressing challenge is the tobacco industry itself. It's a force to evade regulation, influence policy, and market. Harmful products continue to threaten our progress. Compounding these challenges, we are navigating in the era of the perma-crisis, characterized by the emergencies, climate crises, wars, political instability in many countries, and immense pressure on the health sector. This also influences the tobacco control issues as well. Addressing these multi-faced issues requires the energy, expertise, and innovation public health professionals like you. Despite of these obstacles, we must not waver in our vision of the European region free from tobacco-related morbidity, mortality, and addiction. In these challenging times, with limited resources, we must rely more than ever on each other's experience and lessons learned. By fostering collaboration and mutual support, we can overcome obstacles and devise creative solutions that bring us closer to our shared goal. Thank you very much, all of you, for your dedication, efforts toward achieving the tobacco-free future in Europe. Together, we can make this vision a reality. Thank you.
Thank you very much, Angela, for your words. Thank you very much, Dr. Fernandez and Dr. Gullón. And thank you because they are not only for the opening, they are all the day with us. They are also going to do the closing. That means that we have them very committed to our symposium and also for the purpose of this topic today, the tobacco control. So thank you both for being here all the day. It means a lot to all of us. And thank you. We open then the symposium, and let's move to the next table. Thank you very much. So yes, well, our opening session is going to be hybrid. We are going to have two speakers, Marita Heffel and also our colleague Coral Gardner, who is here in person. I don't know whether the online streaming is working. Yes, it's working. So I'm going to do the presentation of both of them. So, dear fellows, I'm pleased to open the symposium with this opening talk with two distinguished experts who have made remarkable contributions to global tobacco control. They are Marita Heffler, who is online, and Professor Coral Gardner, who is here with us today, and both serve as editors of our flagship journal, Tobacco Control. I'm going to introduce them, okay? Very briefly, because they have a very long curriculum. Dr. Marita Heffler is an associate professor at the Mises School of Health Research. Her work spans areas such as social media, phasing out commercial cigarette sales, monitoring tobacco industry activities, and promoting smoke-free policies in prisons. She brings particular expertise in qualitative research and public health program evaluation. She is online. Hi, Marita, are you there?
I am. Can you hear me?
Yeah, we can hear you. We cannot see you, but we can hear you. Okay, probably later we are going to see you. Okay, so I'm going to introduce our second speaker, who is Professor Coral Gardner. She is with us today. Thank you, Coral, for being here. She is also from Australia. I have not mentioned that Dr. Heffler is from Australia. She's there. So we really appreciate that she's at this time of the day awake for doing the talk. But we have the lucky also to have Coral Gardner here, who is also from Australia. She's the director of the Center for Research Excellence on Achieving the Tobacco Endgame, and she's a leader in tobacco control policy and electronic nicotine delivery systems. Her research contributions extend across interdisciplinary approaches to ending the tobacco epidemic, from evaluating international tobacco control policies to exploring innovative strategies for achieving the tobacco endgame. Together, they are going to give the talk, and they will share their insights on the pivotal role of research in driving global tobacco control efforts. Please join me in warmly welcoming them to our symposium.
Okay, so thanks so much for the invitation to join you today. I know both Marita and I are very honoured to be here presenting amongst so many international colleagues and friends too, both in the room and online. So this is a hybrid presentation with Professor Heffler in Darwin, Australia, and we're hoping that the technology is going to work for us. So Marita's going to be changing the slides as we go. Okay, so first I'd like to acknowledge that I come from the lands of the Gimoy Wallabara Yidi peoples, that's unceded lands, and I now live and work in Meanjin, which is also known as Brisbane in Australia, and that's the land of the Turrbal and Yagara peoples. So I like to pay my respects to their ancestors and descendants who continue cultural and spiritual connection to that country. For those who don't know me, my disciplinary background is environmental health and epidemiology, and I've been in the tobacco control field for quite a while now. My first introduction was as an enforcement person in the regulatory space when the first tobacco control laws came into my state in Queensland, Australia. So I've had that experience of being a frontline worker as well in tobacco control. And I've been in the tobacco control policy research space since I finished my PhD in 2006. So now I've had the real pleasure of leading a research centre on tobacco endgame policies, and that's been the last 4 years, and that's funded by the National Health and Medical Research Council in Australia. Yeah, and I guess what I'm hoping to achieve today is also to emphasise the multidisciplinary nature of the work that we do. And we have a really large team, not only in Brisbane, but also throughout Australia and also internationally. So that's my background. I've also had the pleasure of being on the editorial board for tobacco control since 2012 was when I joined as a senior editor, and then also the Australasian editor since 2018. And actually next year I'll be taking over the chair of the editorial advisory board, so I'm really honoured to be taking that position from next year. So I'll now hand over to Marita to introduce herself.
Thanks so much, Coral. Can I just check that our first slide is showing?
Yes.
Of course, go.
Great. Okay. I just wanted to add my thanks also to ICO for hosting us today. I'm really sorry I can't be there in person. I was actually there 2 years ago and it was a fantastic program. So I'm really sad to not be there in person amongst so many friends and colleagues. I also acknowledge that in Australia, First Nations peoples have never ceded sovereignty over their land, which was stolen as part of British colonisation. And today I'm presenting from the lands of the Larrakia people, which is also known as Darwin. I acknowledge their ongoing custodianship and connection to the lands and waterways and pay my respects to elders past and present. A little bit about me for those who don't know me. I started working on tobacco control initiatives about 20 years ago in service delivery and training roles. And I joined Tobacco Control as the news editor in 2012, became a senior editor at the journal in 2021, and then was appointed as editor-in-chief in January of this year. Obviously, I love punishment. In my own research, I've worked on a range of different topics, and I'm affiliated with the Centre of Research Excellence in Achieving the Tobacco Endgame that Coral is a director of. I currently lead a large project working with communities in remote areas of Australia to co-design strategies to reduce availability of commercial tobacco, and I'm involved in various projects to generate evidence for the tobacco endgame. As you can see, we both have a strong interest in the tobacco endgame, so our presentation will feature that quite heavily, but we will talk about tobacco control research more generally. Just before we proceed, a quick note about competing interests, because we forgot to put a slide up about that. Both Coral and I do not accept and have never accepted or sought funding from the tobacco industry or related industries such as the e-cigarette industry, nor from front groups or others funded by them such as the Foundation for Smoke-Free World or Global Action to End Smoking as it's now known. Neither of our universities and the Tobacco Control Journal and the CRE all of them have policies against accepting tobacco industry funding, and neither of us have ever received funding from the pharmaceutical industry. I'll hand back to Coral to just give an overview of the presentation.
Okay, so this is just a brief rundown on what we're going to cover in this talk. So we're going to discuss key trends and gaps in tobacco control research as we see it, and also discuss what makes research publication of a research publication of high value, particularly to the evidence base and to policy making, and also how we match research to the right outlet, the right journal. And we're going to present 2 case studies. So Marita's going to present on tobacco plain packaging, and I'll present a case study on the commercial tobacco endgame research program that I'm leading. So Marita will cover the first half of the talk and provide some of these examples, and then hand over to me for that final example. So back to you, Marita.
Thanks. I wanted to just give a bit of an overview, looking very non-systematically at submissions to tobacco control in the last 2 years or so. We have our sort of constants that have been submitted to the journal on an ongoing basis over the years around things like trajectories of product use, social marketing, and tobacco industry activities. But we're increasingly seeing publications around endgame strategies. These include tobacco-free generation, smoke-free generation, and we're expecting to see more on the nicotine-free generation, which is emerging as an approach in the US state of Massachusetts that's really pioneering implementation of this type of policy. We also see some publications around very low nicotine cigarettes, in other words, reducing nicotine to non-addictive levels, changes to retailing, incentivising retailers to stop selling cigarettes, banning or restricting where tobacco products can be sold. With increasing interest and momentum in the endgame, we're seeing a lot more research around stakeholder views of endgame strategies, and of course the role of non-combustible tobacco products and what that might be in the endgame, as well as industry responses to the endgame. We're seeing increasingly sophisticated modelling studies which project how different policies will change prevalence in the near and short term, as well as predicting economic impacts. And of course, as has already been noted and mentioned by previous speakers, there's a lot around new nicotine products, which includes the health impacts, including multi-product use, the use of descriptors in marketing, and particularly the emerging issue of non-tobacco descriptors, marketing practices, including novel avenues for supply, particularly social media, what potential regulatory frameworks might look like, analysis of the normative influence of key health agencies such as the US Food and Drug Administration, and the role of new nicotine products in promoting uptake of smoking, reducing smoking, and achieving the end game. In terms of the gaps which I've listed here, synthetic nicotine and nicotine analogues seem to be very quickly emerging. Equipping retailers for the end game is another area of focus, and the economics of the end game, and particularly needing to see more about reducing government dependence on tax revenue. So in terms of thinking about what is a useful contribution, obviously keeping epidemiological evidence current is really important, and sometimes these studies are somewhat marginal in terms of knowledge contribution, but they help us to constantly refine our understanding of the magnitude and nature of health harms. Of course, we need a focus on cessation treatment as well. It's important to ensure people who smoke are offered the best and most effective treatments, and that those treatments are accessible. Surveillance of tobacco use prevalence and smoking pathways, which helps us to determine where efforts and resources should be directed. Of course, tobacco industry monitoring is important, which includes lobbying and advocacy by the industry, marketing strategies of different products, and how the tobacco industry works with front groups and others to advance its interests and distort science. And of course, we need to see advances in policy, and I'll talk a little bit more about this in some of the coming slides, but around monitoring loopholes, new approaches to policy and impact evaluation are all important. As I'm the Editor-in-Chief of Tobacco Control, I can't really go through this presentation without also talking about what our priorities are. Now, thinking back to the previous slide, epidemiological studies are typically of interest to tobacco control only if they're significantly breaking new ground. For example, large studies from previously understudied countries or regions, significant changes in our understanding of the magnitude of product harms and the use and impact of new products. So really important that it's about significant advances in our understanding rather than that marginal change that I talked about in the previous slide. A study confirming or refining knowledge about, for example, cancer or cardiovascular risks of smoking would be better suited to an epidemiology-focused journal than tobacco control. Similarly, cessation studies are typically not of high interest to tobacco control, as our focus is not on clinical treatments, although we may be more interested in studies that examine accessibility of services. Tobacco control has a normative and policy focus. We're not simply about publishing the science, but about evidence that can inform policy. And similarly, our global audience determines what we will publish. So our priorities look a little bit different to local journals. We do publish small-scale studies, but there needs to be wider applicability. So, for example, a study about the attitudes and knowledge of a small population group, the knowledge and attitudes they have about smoking would likely be rejected, whereas a case study of tobacco industry interference in a policy initiative would be of interest and offers lessons for other jurisdictions. We would be unlikely to publish a national study of prevalence or attitudes towards cigarette smoking, but we might publish some of the first national studies of the prevalence and attitudes towards a new product. We're interested in papers that push tobacco control policies in new directions or provide new angles to existing policies. And the journal has been closely associated with the Framework Convention on Tobacco Control throughout its history. We're always interested in papers that can take FCT measures in new directions. Similarly, we are always interested in documenting the activities of the tobacco industry, whether that's marketing tactics, lobbying strategies, collaboration with other groups, co-opting public health narratives, or examination of historical activities, which can help inform our understanding of contemporary strategies. Reviews and evidence syntheses are always welcome, and Coral will talk a little bit more about that. Finally, methodological rigour is essential, particularly for research papers and reviews. The methodology should match the research question and study design. We do publish all types of methodologies, and we aim to have reviewers who are specialists in those types of study designs. Author teams need to include experts in those methodologies. So, for example, we wouldn't expect to see a qualitative paper state that it did statistical analysis. And it's worth noting that we have a range of paper types. So if your study is not a full research paper, look at those other options. For example, Industry Watch, Ad Watch, and Advocacy in Action. I'm now going to talk a little bit about the case of plain packaging. We know that introduction of any new tobacco control policy takes a combination of advocacy and evidence, as well as policymaker champions, and usually some luck. The case of plain packaging provides a good demonstration of the evolving contribution of research. I've put together a brief timeline here of the introduction of plain packaging. As most of you will know, Australia was the first country to introduce this measure in 2012, although it was an idea that had been around since the 1980s, and Canada attempted to introduce it in the mid-1990s. This is a similar pattern to graphic health warnings, which were first implemented by Iceland in 1985, but repealed. And today, many people think of Canada as being the first country to have implemented graphic health warnings in 2001. Research about initiatives that did not get implemented, as well as those that did, is extremely important for moving the tobacco control field forward. There are few truly new ideas. In Australia, plain packaging was first put forward as a possible policy measure in October 2008 when a preventative health task force was established by the Australian government and recommended it in a draft report. That report was released for consultation, and then in November 2008, the Framework Convention on Tobacco Control Guidelines for Advertising and Packaging recommended plain packaging. In September 2009, the then Australian Health Minister released the final report of the Preventative Health Task Force recommending plain packs, and in April 2010, the intention to legislate the policy was announced. In 2011, there was a protracted legislative process, we started to see challenges taking shape from the tobacco industry and some governments. In December 2011, the policy became law and it was fully implemented by December 2012. For the next several years, there were a series of legal challenges, all of which were unsuccessful, and from 2017, other countries rapidly started to implement the policy. So what did we need in terms of research evidence and how has that changed? Before implementation, what we needed was experimental evidence of its likely effectiveness with people who smoke and evidence to counter the tobacco industry's scare tactics and likely legal challenges. The government needed to see that there was public support for these measures and also lessons learned from previous attempts to introduce the policy elsewhere, noting the Canadian attempt to introduce it in 1994, which was blown out of the water by the tobacco industry and its scare tactics. After implementation, it was important to have evidence of its impact on smoking uptake and prevalence, as well as public support after implementation. And of course, we know that public support typically increases for any tobacco control measure after it's implemented. We also needed understanding of how it withstood legal challenges and policy factors that helped it succeed or were barriers to implementation. What do we need now? Given that many countries have implemented plain packaging, there is still a need for country-specific evaluations of impact. Often these will not generate new insights, but what they do is add to the weight of evidence. And such evaluations may also help lay the groundwork for other tobacco control policies in the country where they were done. These types of studies are more likely to be of interest to journals with a national focus. At this stage, tobacco control would be unlikely to publish an evaluation of plain packaging legislation unless the findings were significantly different from the experience of other countries. We also need to understand how the industry responds in different places. How it responds now, does it look different from the first case? This includes the marketing strategies that they use and exploitation of policy loopholes, the lobbying and the legal challenges. And we also need to understand how the policy can be expanded and adjusted. For example, Canada standardised stick sizes, and that's something that would be of interest to tobacco control. Also of interest are reviews and evidence syntheses of the cumulative impact of plain packaging across different countries. We know that the impact in isolation of plain packaging is relatively marginal, but as with many policies, when it's put together with a whole suite of policies, we gain a better picture of the overall number of preventable deaths averted. And I've just put here some examples of research that fit the timeline shown on the previous slide. The first paper on the left is a historical count of Canada's attempt and the political interference that derailed it, authored by the fantastic Cynthia Callard and Physicians for a Smoke-Free Canada. Moving across the top, we see a research paper that reported on experimental research of likely impacts of plain packs, which was published in September 2008, just as the policy was starting to be recommended in Australia. The next, on the right-hand side, is a review by the University of Stirling of the evidence that existed to date at that time. And the two studies at the bottom the middle study shows the changes in support for the policy among people who smoke, showing an increase from 28% prior to implementation to 49% after implementation. And the two studies at the bottom of the slide collate evidence and lessons learned, along with recommendations for how the policy can be improved as it is adopted by more countries. I'll hand back now to Coral to talk about the case study of tobacco endgame research.
Okay, thank you. So when we were setting up the Tobacco Endgame Centre of Research Excellence, we started by considering what frameworks there were for generating and also translating research evidence into policy and practice. And we selected the Knowledge to Action framework as giving us a framework to work towards for our program of research. So you can see here, this is part of that Knowledge to Action framework is the knowledge creation funnel. And you can see that you start with knowledge inquiry, original research studies, but also syntheses are very important here, and they're often of more value to policymaking, where you actually get the whole breadth of the research and bring it together. So we started off with looking first across all the evidence syntheses that were available for tobacco endgame research, and we published this review of evidence syntheses in the journal Tobacco Control. So from there, we were able to identify where the gaps were and where we should focus our efforts and generate further evidence syntheses, but also planning our original research program. Thanks, Marita. Next slide. So in addition to that review that was on the previous slide, these are some other examples of evidence syntheses that we've conducted. So you can see that there's one that's looking at priority populations. So that's really important because populations with high smoking prevalence, they're the ones that are going to be most impacted by tobacco control, tobacco endgame policies, but also those that will benefit the most, right? So understanding what research had been done for those specific populations is very important. The next study up there on public support was conducted by colleagues, led by colleagues in South Korea. And so that sort of brought together the global evidence on how the public think about and support these types of policies. And also we did some policy-specific reviews. So this one here was on the policy of restricting supply of tobacco products to pharmacies, a bit of a controversial policy, but one that has been discussed and looked at in different countries like Iceland and so on. Okay, thanks, Marita. Next slide. So in the next few slides, I've tried to kind of outline the types of research areas that may be particularly valuable for new policies, such as tobacco endgame approaches, but also recognising that these are quite challenging where they haven't been implemented anywhere before. So thinking through about what type of evidence we can use and what evidence we can generate. So first, obviously projecting the likely health impacts of a policy is going to be very important to policymakers, because ultimately that's the whole point, is to let them know what we think is going to be the benefit of implementing a policy. And the first step of that is obviously working out what we think the impact on our smoking prevalence will be. And so from there, you're looking for that evidence from if a policy has been implemented somewhere else. Obviously that's the first step, but sometimes it's a new policy, it hasn't been implemented anywhere, so we have to draw on other evidence. So things like consumer surveys, where we ask people about what they think they will do if a policy was implemented, that kind of anticipated response. But also we use expert knowledge elicitation, where we get a panel of experts who've got experience in different policy implementation and get their best guesses on what they think is going to happen. So it's drawing together all that evidence and putting that into a model is where we can make that more real for policymakers in terms of thinking through how the policy might work and what the outcomes will be. Sometimes it's important to also look at specific populations in addition to the overall population too. So we often do that with epidemiological modelling, where we build that model with all those different inputs. So the evidence for each of those different factors is obviously important on its own, but when you bring it together in a model, I feel like that's where it really comes to life in terms of if you're going to implement this. It's also important to think about the economic costs and benefits. That's really important for policy making, obviously. And as a health researcher, we're often thinking about the healthcare costs, but governments also have a wider remit. So thinking more broadly about the economic costs on business, but also on government revenue can also be important. And you can, generate all of this, these estimates within a model. One of the things that we did with the Smoke-Free Aotearoa Smoke-Free Action Plan was to try and estimate the impact on households. And I think that's also quite an important step to do, to show the benefits for individuals and households from not spending money on tobacco and how that helps the household budgets. And also thinking through about the impact on government budgets. Okay, thanks, Marita. Next slide. So these are a couple of the examples that of the modelling studies we did. So the first one was estimating the impacts of the Smoke-Free Aotearoa Action Plan group of policies. So that was tobacco-free generation, reducing the number of retailers that could sell tobacco, and also denicotinisation of cigarettes in New Zealand. And so this policy modelling paper was very important for the government in New Zealand to support them successfully bringing in the legislation and getting that through Parliament. Unfortunately, you will probably be aware that it was repealed when a new government came in, so that was very unfortunate, but it was an absolute pleasure being part of this research. When the repeal happened, we did also put forward this other paper here on the economic effects, and that was to try and make a case for why they shouldn't go ahead with the repeal when the new government came in. Unfortunately, we weren't successful there either, but we were able to demonstrate that it would have a modest impact on government revenue, and that could be offset with other tax policies, and also that bringing in these policies would have a very good benefit for households from decreasing their expenditure on tobacco. Okay, next slide. Okay, so on this slide I wanted to also highlight the multidisciplinary angle of tobacco control policy research. So one of the things we need to keep in mind is obviously any new policy is likely to get challenged by the industry, and so we need to be thinking about what we can, like anticipating ahead what the likely legal arguments are going to be and what the possible defences are. And so collaborating with law researchers is absolutely essential in this space. And that can be through looking at case studies of previous attempts to implement a policy, what were the arguments, how were they defended, and also looking at international law and looking at other treaties. And so I know Marita and Laurent are working on that for tobacco endgame policies currently. So that's really important research too. Also looking at industry document research, so again looking at that evidence for counteracting the tobacco industry arguments. Obviously political feasibility is really important, and policymakers are going to want to know what the public think about these sorts of policies, but also other key stakeholders too, so health and medical groups and so on, and also what sort of industry arguments are going to come up. One of the things we always see is arguments about illicit trade, unintended impacts and so on. So we shouldn't ignore those factors, and we should actually generate the evidence to show that these aren't barriers to implementing tobacco endgame policies and how we can manage these effects. Also looking at, again, specific populations and how they may perceive these different policies, and whether these policies are going to be seen as unfair for particular groups, and what we can do about doing that. So this is kind of like a web of the different research that we're doing in this space to try and understand how we can best support governments to implement policies that are going to bring about the end of the tobacco epidemic. Next slide. Okay, so this is just an example of some of the research that we've published on this. So we've looked at media studies where we've looked at how these policies are presented in the media and how they're discussed. We've looked at support for endgame policies by directly surveying the public, people who smoke particularly. Also, we've looked at different stakeholders, like, for example, this other paper here is looking at community pharmacies' perspectives on that policy of restricting supply to pharmacies. So obviously, knowing what the people who would be implementing and actually doing, most important to implementing that policy, think about it is absolutely vital. We've also done things like policy scans to understand the range of policies out there where we can draw on for generating that evidence for new policies. And of course, we've also done some research on looking at how the tobacco industry try to interfere in policy making. Okay, thanks, Marita. Okay, and so, we've just gone to the end. So that was, so quickly. Okay, so obviously these are our references. If you want a copy of the slides, we're very happy to provide those. There's two slides of references. And that's our presentation. So I just want to thank you so much for your attention today. I hope it's generated some ideas and some of that sort of programmatic thinking about what sort of research is needed in the space. And we hope that we see lots of great publications coming through tobacco control.
So thank you very much. Applause for them. We are on a schedule, but because they are here, I want to ask you whether you have any questions. Please raise your hand, also present yourself. We have the great opportunity of have 2 editors of tobacco control, and also that they have give us a lot of information, and we take notes about the priorities of tobacco control, what you are going to publish, because it's also an opportunity to ask what kind of research it needs to be done in order to better understand the interference on the industry and how policy can be moved on the policy level. So do you have any question? Okay, please use the micro and say your name, where you come from.
Thank you very much. Laurent Hubert with ASH, Action on Smoking and Health. And so I have a question. You mentioned the modeling study in New Zealand and how important it was. And within the European context, with a very ambitious target of a 5% prevalence or below within the European Beat Cancer Plan, do you have already studies or modeling done for Europe, whether it will be able to achieve the 5% or below target with tobacco control policies as business as usual, or do you already have, or are you looking for more publications in this area? Would that be helpful to you?
Yeah, so I do think that the team that are leading the modelling are based at the University of Melbourne. Tony Blakely leads that team. And I do believe that he is doing some work maybe in other countries as well. I know they have created a Canadian model, and I suspect that they're also doing some in Europe as well. We're working on the team's working on at the moment, modelling for actually one state in Australia is looking at bringing in the tobacco-free generation policy. So again, doing that modelling on a local context is obviously very important for policymakers to have that local context and estimates for their state or country. So yeah, that's a really important point.
So if we don't have any other questions, we move to the next table and session. And please, we are going to thank Coral and Marita with this applause.
Espera, ¿dónde está? ¿Lo has copiado aquí? No, es que no. No. Ah, no está copiado aquí. Good morning, everyone. My name is Solena Tigova, and together with the rest of Tobacco Control Unit, we will take care about you today. I will help Cristina to try to keep track on time and how the sessions flows. You've seen that we have very packed agenda. We have a big objective to keep with it. We are in Spain, it's difficult here, but we'll do our best. Just to remind you that at the end of the session, we are more than open to receive the questions. We also have Laura following online sessions, so if there are any questions for those who are joining online, you can post in the comments, and we will also read them so the panelists can address and respond to those questions as well. And we are moving to the next session. It's the first of their opening session about where we stand after 20 years of WHO FCTC. And it's my honor to present the moderator of the session, Cornel Radu. Many of you know him. He's Secretary General of the European Network for Tobacco Prevention and Cessation based in Belgium. And yeah, we are good with all the presentations. Just to remind you briefly that if you are doing any social media post or anything, please use the hashtag that you can see there below. And to you, Cornel.
Thank you, Elena, and thank you very much to all our Catalan friends for this excellent symposia. In fact, I remember the first edition in 2012. And I will not keep the floor long, but I'm happy to share this panel with some friends that we attended, in fact, the WHO FCTC meeting in 2003 when the convention was adopted, and then in 2005 entered into force, and now after 20 more years we have the chance to speak about this. It's part of our life, in fact. Yeah, but first of all, I have the pleasure to give the floor to Sarah Hitchman. I hope that she is with us online. She's representing today the WHO FCTC Secretariat. So, Sarah, the floor is yours.
Hi, sorry, I think my video is frozen.
It's okay? It's working?
Can you see my video? Sorry, I can't see myself, but okay. But can you hear me?
Yes, we can hear you very well, but your slides are not on the screen yet.
Okay. Let me just see. Sorry about that. Okay, I'll get the slides up now.
So now you can share your screen because you're on the screen.
Sorry, I'm just having a connection problem. Give me 1 minute. Okay. Okay, sorry, thank you for the patience there. So first, thanks so much for the kind introduction. For those of you who may or may not know me, my name is Sarah Hitchman, and I've been asked to speak today on behalf of the Convention Secretariat. Some of you might know me more from my academic career. Before joining the Secretariat, I worked at King's College London, University of Zurich. I spent some time at University of California, San Francisco, and I did my PhD at University of Waterloo in Ontario, Canada, where my focus was on the International Tobacco Control Project.
Sarah, if you can put your slides on the full screen.
So first, a little bit of a brief background. So a lot of you are familiar with the FCTC, but for those of you who are not, the FCTC is the first international health treaty negotiated under the auspices of the WHO. It was developed in response to the globalization of the tobacco epidemic, and it's an evidence-based treaty that reaffirms the right of all people to the highest standard of health. It first entered into force in 2005, meaning that next year in 2025, we'll be celebrating the 20th anniversary of the entry into force. There are currently 183 parties to the treaty. The FCTC contains sets of tobacco control measures under its articles, including articles to reduce the demand for tobacco products, which is Article 8, protection from exposure to tobacco smoke, and Article 11, packaging and labeling of tobacco products. In addition to these articles to reduce the demand for tobacco products, there is also a set of articles to reduce the supply for tobacco products, such as Article 15 on illicit trade in tobacco products, and Article 16 covering sales to and by minors. Together, the articles of the FCTC aim to reduce continually and substantially the prevalence of tobacco use and secondhand smoke exposure.
Sarah, if possible, please put your slides on full screen.
Oh, sorry, I can see it on full screen on mine. Sorry, I've got the wrong screen showing here. Sorry about that. I'm sorry, I'm working at home and I've got 3 screens right now. Moment. Okay. It's all right. I'm going to stop
just
sharing.
Just press full screen now.
Yeah. Is it? It's not full screen now, is it? Okay. Let me stop sharing and I'll put up the right one. Okay, there we go. Sorry about that. Is it working now?
Now it's perfect. Thank you very much.
Okay. Sorry about that. Thank you. Okay, so now what about some of the achievements of the FCTC, which is what we were kind of aiming to talk about today. One key achievement of the FCTC is how it has served as a framework and catalyst for action. And so what do we mean by this? At the international level, the FCTC has served as a catalyst by keeping tobacco control on the global agenda and by fostering international cooperation. Tobacco control is recognized as an accelerator for sustainable development, and under the Sustainable Development Goals, Target 3.A calls for strengthening of the implementation of the FCTC in all countries as appropriate. The positive interaction between the FCTC implementation and other sustainable development goals has allowed tobacco control to gain traction, such as the role of reducing tobacco growing in food security and in sustainable agriculture. Strengthening the implementation of the FCTC is also recognized as an overarching action to tackle non-communicable diseases, and FCTC measures have been identified as best buys in non-communicable disease prevention, such as increasing excise taxes and prices on tobacco products. The FCTC has also provided a foundation for stronger collaboration among UN agencies on tobacco control. For example, the FCTC, as part of the UN Interagency Task Force on Prevention and Control of Non-Communicable Diseases, has engaged in collaborations on tobacco control with the United Nations Office on Drugs and Crime, the United Nations Development Program, and the United Nations Environment Program. Another key achievement of the FCTC is that it has provided a framework for national action. The FCTC represents a milestone by ensuring that tobacco control is not only a health matter, but parties are legally bound to implement the treaty's provisions, making tobacco control the responsibility of the whole of government. The FCTC guidelines, along with the policy options and recommendations, aim to assist parties in meeting their legal obligations under the Convention, giving them a framework for action. The Convention Secretariat also offers further technical advice and support to all parties, with a focus on supporting low and middle income countries. The FCTC 2030 project was created in 2016 as the FCTC's umbrella workstream support low and middle income countries with implementation. And so it's worth highlighting a little bit more about the 2030 project, given its important work in accelerating implementation. In 2016, the government of the United Kingdom initiated the FCTC 2030 project to support low and middle income countries with implementation. They were soon joined by the governments of Australia and Norway. Together, the project is enabling support to countries eligible to receive official development assistance to further their work in tobacco control and implementation. The FCTC 2030 project has helped more than 30 priority countries to develop, strengthen, and implement tobacco control policies, along with other activities to support implementation. So next, I'd like to highlight some of the findings of an impact assessment of the FCTC. So what did the impact assessment of the FCTC find? Overall, the impact assessment found that the FCTC has provided a roadmap for policies and a catalyst for stronger tobacco control. It has helped strengthen policies in countries where they were in place before ratification, and has also played an important role in countries where effective tobacco control measures were not previously in place. It has also contributed to reductions in smoking prevalence among parties that have implemented FCT policies at the highest levels or higher levels. It has served as an important support for governments in legal defenses against the tobacco industry, and it has also increased awareness of tobacco industry interference, prompted action to resist it, and influenced the global operations of the industry. So unfortunately, it's not all good news, and it's helpful if we can also look at changes in tobacco prevalence over the last 20 years. When we look at changes in tobacco prevalence, we find that global tobacco use has been steadily falling since the FCTC entered into force, with prevalence expected to fall to 18% by 2030. A study found that among 170 countries that ratified the FCTC, that ratification was associated with 24 million fewer people, young people smoking, and 2 million more people quitting over a decade. Reflecting this steady fall in global tobacco prevalence, the 2024 progress on the Sustainable Development Goals found that there had been moderate progress in meeting the target, but that acceleration was needed. So where does it leave us? It's also worth keeping in mind when we look at prevalence that even as tobacco use prevalence falls, we should keep our eyes on the number of tobacco users and how this might be changing in different parts of the world along with population growth. This study is a bit using older data, but this study between 1990 and 2019 found that the number of smokers was increasing. And the number of smokers was particularly increasing in certain regions of the world, such as the African region. And if we can see in some regions, it was decreasing, such as those in blue and light blue, such as some parts of the European and the Americas. The good news is that when we actually look at more recent data, so data between 2000 and 2022, and this is data from the WHO prevalence report, that we see that the number of total tobacco users, so not smokers, has fallen from 1.36 billion to 1.24 billion. And again, however, there are regional differences. So similar to this map, the number of tobacco users continues to grow in some regions of the world. So the African region and the Eastern Mediterranean region, even as it falls in others. And this can, of course, have implications for delivery of services, such as smoking cessation, as we heard from Angela, but even these services are not adequate already. So this brings us to something a lot of us have already talked about today, and that's the challenges ahead. Any treaty is only strong as the enactment of its obligations at the country level. The overview of the tobacco control situation around the world shows considerable disparity, both in the implementation and enforcement of FCTC measures. Unfortunately, the heaviest burden of the tobacco epidemic continues to be carried unequally by people left unprotected by strong tobacco control measures. And this is just simply too much of humanity. And so action remains urgently needed to accelerate FCTC implementation. Thank you very much. That's the end of the presentation.
Thank you, Sarah. Questions? I don't see any question in the room. I just want to mention the fact that last week we had the observers meeting with the Secretariat. INSP is an observer organization to the COP and MOP. And we were informed that during next year, a lot of actions and events will be dedicated to the 20th anniversary of the entry in force. And also just to remind all of you that next year in November, we will have the COP and the MOP meetings in Geneva, but more details will come in time. This is just, let's say, an update to the Secretariat presentation. And now we move to our big problem, the tobacco industry interference, and I kindly ask Dr. Armando Peruga to come here to take the floor. Armando, it's your time. I will not spend time to long introductions of the speakers because the short bios are available on the event webpage, so please check the event webpage and you will see all the details about the speakers. So Armando, wow, Star Wars.
This is my entrance. In fact, my name is Armando Skywalker Peruga. No, so let me get this. First, it's a pleasure to be here with so many old friends, old referring to the length of the friendship, not to their age. First, I want to declare that I have not received ever payments from any commercial companies, pharmaceutical, tobacco, even porno. With this body, nobody has paid anything. Nor do I have any investment in this industry, so just to be clear. And I want to talk, I was in charge of talking about a little bit the old, the new activities from the tobacco industry, and that should be worrying us from public health. And I've titled this "The Old, the New, and the Borrowed Blue." It's for those who are not very well versed in English, this is a saying in that going to a wedding, you should wear something old, you should wear something new, and you should wear also, you have something that is borrowed and blue. I don't know if someone is saying yes, maybe this is also here in Catalonia. So I'll explain what is the old, what is the new, and what is the borrowed blue in this phrase. Let me start with the old. We are accustomed to talk about the old versions of the activities of the interference of the tobacco industry, and they are really short-term moves. And they've been classified many times as maneuvering to hijack political and legislative process, exaggerating their economic importance, fabricating support through front groups, third parties, intimidating governments with the threat or even litigation. And Australia knows a lot about that. And it's an expensive matter. Just to say, for example, I know that Uruguay, that went through a similar process for a similar issue, they spent several $1 million that and the case of Australia is also very expensive. So not every country is in a condition to face this. Discrediting proven science and manipulating public opinion to gain. And I don't know if it is now that we are becoming more aware or more research, I'm not sure, but we are becoming more aware of the new long-term moves of the industry, which is, in my view, relatively new. I mean, it's an insistence on the past issues, but with a new face to it. And the same guys that swear in the United States Congress that these are the CEOs of the 7 major companies at the time in United States, in which they swear that nicotine was not addictive, they're saying to you, we've changed. We are now part of the solution. And the solution leads, in my view, and I will try to document through this presentation very briefly, that it tends to normalize corporations and tobacco industry as essential policy partners. This is not only something that applies to tobacco industry, but obviously is something that is most interesting for us. It marginalizes public health community, and it shifts responsibility from government action to individual behavior. I want to show you an ad that produced the Department of California under the leadership of Dr. Dilip Bal in the 90s. And I think it was very courageous, and it's called Crocodile Tears. Let's see if we can hear what they say. Can we hear a little bit higher? Let me start again. Let me just Well, at the time, I think in this early 90s, it was very courageous for a Department of Health, a government entity, to have this type of advertising. And as you can see, they point to a very key issue is that despite all they do, they keep selling cigarettes. And this has made reflect to the tobacco industry. And now they say, and I put here an advertisement in the UK, This is a 2018 advertisement from Philip Morris saying that our New Year resolution, we're trying to give up cigarettes, okay? The question that was a problem in the 90s, they're trying to walk around that. And Philip Morris, the ad says, is known for cigarettes. Every year many smokers give them. Now it's our turn, thank God, finally. And as you can see, immediately they say in a small print, but many will continue to smoke. Not our fault. That's why we want to replace cigarettes with products such as e-cigarettes and heated tobacco. And that's the borrowed blue in my statement. It's basically they want to promote a harm reduction with the so-called reduced risk products. They commit to transform their own industry sector towards the production of less harmful products. And in the meantime, they promise to promote compliance with current anti-smoking regulation and expand, only as a matter of new policy, expand smoke-free spaces to protect minors, where minors are present. So the question that is really the tobacco industry promoting harm reduction. Are there really reduced risk products? Is the tobacco industry transforming? Is the the tobacco industry really promoting compliance with regulation? I will address some of these questions very quickly since we don't have much time. If I have like 6 minutes left. And the key to it is the concept of harm reduction, which is a borrowed, that's a concept from public health. In our public health discipline, it should benefit everyone in the population. Nevertheless, the tobacco industry says that it reduces the exposure to certain toxins or toxicants through product switching, and that reduces the sum of that is population harm reduction, and they forget two things that are important for us, whether these new products actually move part of the non-smokers to nicotine addiction and to cigarette use. And second, we know that in practice, those smokers that use these new products tend to be dual users for a very, very long period, in which we know that the probability of harm even is higher than among those who only smoke conventional cigarettes. In our public health view of harm reduction, it applies only to chronic, very ingrained behaviors that are not modifiable in the short term by usual means. And obviously the tobacco industry is saying that this is the case with tobacco because we have a very hardcore people that now they cannot quit smoking or reduce smoking through the usual policies, taxes, smoke-free environments and all that. And we all know through research that this is not true. Probably, I made some calculation from Spain. The prevalence in Spain of current smoking is about 25%. Those who could be considered hardcore is about 1/5 of that. So there's a lot of room to improve with the usual policies. And also, people, you know, they have the right to choose behaviors that they harm their health, but there needs to be some conditions. And they need to be very well informed about all that. They cannot pass the cost of their decision to others. And most important, they have to be free from commercial pressure. The freedom obviously has to be that nobody in the industry that is selling these products that are killing hundreds of millions, 100 million people during the past century, is not selling the product that's supposed to solve this problem. In Western Europe, the percentage of the market controlled by tobacco industry of both combustibles and non-combustible products is about 98% of that market. So how can you guarantee that the decision of using this product is going to be without any commercial pressure? I'll be quick about the second question is the TI producing reduced risks? And they have come up very clearly saying that the FDA, the US FDA, has approved their product as reduced risk, which is not true. The FDA denied risk of modification status for ICOs, for example, for Philip Morris, saying that it has not demonstrated that the product will significantly reduce harm and the risk of tobacco-related disease. They only recognize that the exposure is lower than conventional cigarettes, but that doesn't mean that it transforms immediately in a reduced harm. These are the advertisements from the decision of the FDA. It talks about reduced exposure, and the advertisement from Philip Morris in which they say it's a modified risk product, which is not true. Although they dance around very carefully the language so they don't technically lie, but in practice they convey the false impression. And one final question that I wanted to ask is the tobacco industry transforming? And I put here a graph from an article from Megan from the group of the Bath University. Ann Gilmore directs this group, and she's also an author in this paper. What they took the aspirational target that the PMI, Philip Morris, which has been the most adamant about this quitting cigarettes. There are other companies that don't do that, but and they tried to see if the target would be really achieved just as an effort on the part of the tobacco industry to really change their producing mode, or is it just a projection in time due to the work and the effort everyone to try to reduce the sale of tobaccos, and so of cigarettes, sorry. And here they plotted the shipments basically in black, and also the sales, just to show that they're concordant. And they projected, as you can see, until the year 2016, they made this transformational announcement. And in 2018, they set a target of about 150 billion sticks a year of sales worldwide. And you can see that it has been decreasing until the year 2020, in which there's a stall. And they produce a projection in several ways. And what you can see is that just by continuing the sales as before the announcement, they will reach this sale. So it's not really an aspirational goal. It's just a reality of what is happening right before that announcement. So, as I said, to begin to conclude, is the TI promoting harm reduction? Well, I think it's a mutilated version that is borrowed from public health, that is not really a public, a population harm reduction. It's rather an individual harm reduction for some people that may not have a benefit for the whole population. And is the TI producing reduced risk? Reduced exposure, perhaps, but reduced risk, certainly not. At least no no agency has approved that as a reduced risk. Is the TI transforming? Not really. It's doing business as usual. And I haven't had the chance to go into this promoting compliance, but certainly not. And there's many examples in Europe and all over the world about that. Now that I'm looking at Olena, there's a very example of Ukraine in which there were a discussion about tax increase, and the tobacco industry came very strong and denouncing names in public. So and they were saying that they were really doing that for their own benefit to get money from international donors and not really for the sake of the Ukrainian people. At the key of the harm reduction is the stop selling cigarettes if they really are serious, and they have elaborated some discourse about that. They say that they cannot immediately stop because they have a duty to the investors, which means that they are prioritizing profits over public health. They're not here for public health. They also say that consumers who smoke would switch to competitive brands if they stop selling cigarettes. Again, this is an argument of prioritizing profits over public health. And also, it's a way to blame others, say, no, I cannot do it while the other companies don't give up cigarettes too. So it's not in my control. So it's not in your control why you are announcing this idea of stop selling cigarettes. And then the third argument is that this is a very self-serving argument, is that they would lose, if they stop selling cigarettes, they would lose access to the people they aim to help. So somehow the argument goes, I'm going to keep killing you in order to help you. There's something that doesn't work there. It also means that smokers are incapable of making informed choice without Philip Morris. It's also, Philip Morris thinks that they have some kind of proprietary right to help smokers, not others, and that the continued sale of cigarettes is a necessary evil. And to conclude, is the blame game, blaming others for continued cigarette sales. Say it's not my fault. We're looking for someone else to be responsible, and whose fault is that? Smokers in the first place, because they don't want to. They want to continue smoking. They say the tobacco industry. I would give up on smoking, but these guys want my product. Also is, and this is the, I have here a quote from André Calantzopoulos, who was not anymore, but he was the chief executive officer of Philip Morris International in 2019, in which they say, as CEO, I often ask why we don't stop selling cigarettes. Perhaps this is the wrong question. The right question might be, when will people stop buying cigarettes? And it's also the fault of other companies because they want to steal our smokers. And they blame you too, the public health issue, because you don't want to help them sell their new products. So I promise this is the final one. Their true aim with this harm reduction narrative is not public health, is profit. And the harm reduction narrative allows the tobacco industry to normalize corporations as essential policy partners, to marginalize the public health, to shift the responsibility from government action to individual behavior. This attempt in itself is not new. What is new is their current efforts represent an unprecedented level of intrusion into public health. What is new is that they're reshaping the conversation around tobacco and nicotine, co-opting public health language about harm reduction in a deliberate attempt to manipulate public perception, influence policy decisions, and ultimately, and this is the most important thing, protect their profit in a changing landscape. By understanding this rhetoric, we can better challenge their narrative and advocate for effective public health measures. Thank you very much.
Thank you, Armando, for your inspiring presentation, as always. So, questions from the room? No? So, very clear. It's a question? No? No. Okay. Then we go to the next speaker, Laurent Hubert from HUS, and he will show us the connection between WHO, FCTC, and other United Nations treaties. And this is a very important topic because we cannot implement FCTC without connecting the treaty with other international treaties. Please, Laurent.
Good. Thank you very much, Cornel. When and I think a few of you have already mentioned that. Esteve mentioned it earlier this morning. It's all about, it goes beyond public health. And when some of our biggest challenges when it comes to tobacco control implementation at the country level, in addition to tobacco industry interference, is lack of whole government engagement. And we see that in country after country. I've talked to French parliamentarians. Asked them about the Framework Convention on Tobacco Control. They never heard about it. Even like maybe, I think it was last month, we had a meeting with the Committee on the Elimination of Discrimination Against Women. That's the committee that monitors and promotes the implementation of the Convention on the Elimination of All Forms of Discrimination Against Women. And those are all lawyers. So this is a group of 23 experts, mostly international law experts. And I asked them, how many of you are familiar with the FCTC? Only 2 raised their hand. So a problem we're having is that even though we have an evidence-based treaty, and it's done a tremendous amount of change over the years in tobacco control, there's still a lack of a whole of government engagement when we address tobacco. So I'll present a few examples for potential integration and engagement that are coming up in the context of development with the UN Development Agenda, and also around the environmental movement and human rights. I will not talk about anything about health or the high-level meeting on NCDs, given that that's already fairly well covered. So let's start first with development. We're extremely fortunate, as you all know, and it's been mentioned earlier, to have target 3A in the UN Sustainable Development Agenda. We're extremely fortunate. However, still not a lot of progress in this area. And despite having UNDP, having developed a document a few years ago reaffirming that the FCTC is an accelerator for the SDGs. But we have an opportunity this year. There had been a 3rd international conference on financing for development, the Addis Ababa conference. And probably some of you are aware that there was an outcome document that was released which recognized tobacco taxes as a tool to not only decrease smoking, but also secure funding for development. But I want to point out that this, in 25, in Spain, in Sevilla, in June to early July, there will be the 4th International Conference on Financing for Development. So that is an opportunity for us not to miss. We have to make sure that whether it's the FCTC Secretariat, WHO, or us as civil society, we engage in this process and we make sure that there's a follow-up to the last Addis Ababa paper. And unfortunately, this will be after the WHO, because the last time, I remember we did a lot of advocacy around the World Health Assembly, which took place before the Addis Ababa conference. So there will be some work to be done there, but that would be an opportunity not to miss, given that funding from tobacco control could be critical to support development agendas, as well as help decreasing smoking, but also making the point also of, I think, I don't know if it was you, Coral, or if Marita mentioned that we have to also be careful to not give the message that tobacco tax funding should be an ad infinitum surplus funding for development. So we have to be careful with that message. So that's on development. Then let's move on to on human rights treaties. You may have noticed that the last conference of the parties for the FCTC in Panama last February adopted a decision on the contribution of the FCTC to the human rights agenda. And in this decision, adopted by the COP, they do call on governments to address or mention the FCTC and tobacco control when dealing with human rights mechanisms. And most of our governments have ratified human rights treaties. And there was also the Panama Declaration, which also does the same thing, calls on governments to address tobacco when they report back to their treaty obligations to human rights treaty bodies. But I want to point out that it is not new. Now, the human rights treaties have started to address tobacco, and it's been already for a number of years. For example, the Committee on the Economic, Social, and Cultural, the committee that monitors the implementation of the International Covenant on Economic, Social, and Cultural Rights, a very important human rights treaty that has been ratified by most of our countries. They develop what are called general comments. It'll be a little bit like the guidelines that we have for the FCTC. And there was the General Comment 14, which was adopted in 2000. And this basically, it's an authoritative interpretation on what governments should do to address the right to health article under this treaty. And in this general recommendation, this committee made it very clear that governments have an obligation to take steps to reduce the use of tobacco, and they also say that our governments fail to protect their citizens' right to health if they do not take steps to discourage the marketing and the promotion of tobacco products. So that was an important decision in 2000. And the same committee, associated with the International Covenant on Economic, Cultural, and Social and Cultural Rights, as two other general recommendations, one on working with corporations, in which they mentioned the tobacco industry and the marketing of tobacco products as an example of misappropriate behavior from industries. And also then they have another one, which is General Comment 25, which is on scientific, the science and economic, social, and cultural rights. And in which also they give the example of the tobacco industry as the best practice, like the poster child of a corporation that misuses science to manipulate policy. Then the Convention on the Rights of the Child, another human rights treaty, which most of our countries have ratified. General Comment 15, again, a document developed by the committee that monitors and promotes the Convention on the Rights of the Child. In the General Comment on the Right to Health, they also call on governments to ratify and put into place the FCTC. And the Human Rights Council, which is the largest body within the UN system that monitors the implementation of human rights obligations by countries, in 2017 adopted a resolution in the context of the 2030 Agenda, the UN 2030 Development Agenda, and they call on countries to implement to make progress towards all the SDG targets, including the FCTC. And an important one that I'm not sure everyone is aware of, and also attached to the Human Rights Council, there are mandate holders, and there's the Special Rapporteur on the Right to Health. And just this last July, there was, in the context of a harm reduction for sustainable peace and development, so the Special Rapporteur on the Right to Health, Taling Mofokeng, she released this report in which there's a whole section on tobacco and how the tobacco industry manipulates the harm reduction debate. And I think that's quite important because we within public health, we say, we are very concerned by this manipulation by the tobacco industry, but it's very, very helpful when we then have a mandate holder that doesn't come from our field, comes from the human rights environment, that reaffirms that the tobacco industry is manipulating the harm reduction debate for its own interests. Still staying now in the context of human rights treaties, a very important element that we have with human rights treaties, and all of our countries within the European Union have ratified those treaties, is they have a much more robust implementation review mechanism than what we have with the FCTC. With the FCTC, we don't have it. We have a process by which governments kind of do a self-check-in, and we're doing very well, of course, we're implementing all the measures, blah, blah, blah. With human rights treaties, there's a much more robust process where civil society, other UN agencies can engage in that process and can give a real true picture of what's going on at the local level. And I want to start by saying that first, there was already in 2009, in the recommendations that we're giving to parties, that was a report that was presented to the UN General Assembly. It was saying that it would be good, and there's under Article 12 of the International Covenant on Economic, Social, and Cultural Rights, which is the Right to Health article, but it states that government should provide information to the measures taken to ensure and prevent the abuse of tobacco, among others. And not many do that, and it's important to do that. And the reason why is because, as I mentioned, there's a much more robust reporting mechanism that can be used, and one where you can engage in this process. Because governments have to report back about every year to the treaties they've ratified. So whether it's the Convention on the Rights of the Child, the CEDAW, the Protection to Protect Women, the Convention on against People with Disabilities, the Convention on Racial Discrimination, and so on and so forth. So this provides an opportunity to really integrate tobacco control and the FCTC in the women's rights agenda, children's agenda, disabilities agenda, and so on and so forth. Something we do not know. We have a tendency to shine by our absence. And when we do, it does make a difference. There's been some papers published that show that when a committee does make a mention of tobacco, it increases chances for action. For example, we had a few years ago worked with Unfair Tobacco in Germany, submitted a report to the, when Germany was due to report on their obligations towards the Convention on the Rights of the Child. So they, working with Unfair Tobacco, we submitted a report, and as a result of this whole process, then the committee made a recommendation to Germany that needed to improve education on the effects of tobacco use and secondhand smoke, needed to regulate the market of tobacco to children, and hold the tobacco company accountable for infringing on children's rights in the supply chain. So those are kind of powerful tools that we can use, and they come outside of the health system. Similarly, for example, in Argentina, Argentina, which has still not ratified the FCTC, but the committee had, and this is basically, this is the result of civil society submitting reports to those treaty bodies. And in this case, the committee was concerned about the widespread use of tobacco among women and was asking countries to, Argentina to ratify the treaty. Did the same thing for other countries. Liechtenstein, for example, was concerned about the increase of tobacco use in Liechtenstein and Luxembourg, and the committee was asking on those countries to also disaggregate data and have data for women and men. Because as you stated earlier, for example, for women, we have in Europe a big concern with the increase of smoking in women, and the report we published, the WHO Europe report, which the European region will not achieve its target for women. So this is within the human rights bodies. So again, all of you countries have ratified those treaties, so I encourage you as academics, civil society, and when you do all this excellent work at country level in terms of industry interference, prevalence data, et cetera, that's information that can very easily be adapted and inputted in reports that go to human rights treaty bodies. Now, moving on to the next segment of potential area of engagement, and is in the environmental movement. How can we take advantage of environmental platforms, environmental mechanisms that take place, and also because governments are more aware of those processes. You're probably aware that in Panama also this last February, there was a decision on Article 18. Article 18 is the article that addresses the environmental impact of tobacco in the FCTC. And there was a decision on Article 18 which recognizes, this decision basically recognizes the impact of tobacco on the environment. It calls on countries to even use litigation to address the environmental impact of tobacco. And it also calls for stronger engagement with international environmental treaties, including, among others, the negotiations for a UN treaty to end plastic pollution. This is a treaty that started about 3 years ago. The last round of negotiations ended just last week. It was supposed to end this last week. It hasn't yet. There will be another session in 25. Governments were not able to agree to reach consensus. A lot of industry interference, by the way, not just tobacco, but fossil fuel industry and plastic industry. But this is an opportunity for us, and it's already made a difference. The tobacco control community has been able to very successfully advocate and make the point that cigarette filters, which are made out of plastic, cellulose acetate, are one of the most discarded plastics around, and they're included as of now in the list of plastics that would be phased out or banned as this process moves forward. And also one of the things we want to make sure that this coherence with the FCTC. So we need to take advantage of those type of treaty negotiations that take place. So there will be another round of negotiations, and we need to ensure that we continue engaging in this. And there's a global alliance called the Stop Tobacco Pollution Alliance. If you're interested in this, you can let me know, and you can engage in this process. But we, I also want to make a point, and it ties also to this whole of government engagement. The High Commissioner, the Office of the High Commissioner for Human Rights, and from his office, there was when the first round of negotiations started for this plastic treaty, there was a document that was sent to the first round of negotiations on key human rights considerations and negotiations to develop a plastic treaty. And the High Commissioners made this very, very strong point that clear boundaries of conflict of interest need to be set up in the plastics treaty. And they mentioned the FCTC as a best practice, given that is one of the only treaties that we have that addresses a consumer product where there is a conflict of interest measure. Because if you follow, for example, the Framework Convention on Climate Change or the Plastic Treaty or others, you will have noticed that those treaties are not going anywhere because of the very, very strong presence of fossil fuel industries which are, and parties which are totally captured by corporate interest and does not allow for progress towards those treaties. So in this context, we do have a strong precedent in the FCTC and something that's worth exporting to environmental treaties. But we need to go beyond just the plastic treaty because, for example, the cigarette filters, even if the industry, which is already trying to do that, move to other type of filters that would not be plastics, but there's even more evidence on the toxicity of the filters than there is even on the microplastics element or of the plastic pollution associated with it. So it's be absolutely critical that we use environmental treaties that address toxic pollutants, and to make sure that tobacco is also addressed within those treaties. And that's an opportunity for us to engage on those. So for example, in April and May of 25 next year. Same with, we keep on saying that one of the items that we see littered all over in beaches all over the world is cigarette filters. And every year, it was in 24, this year was in Barcelona. There was a UN conference. 25 is in Nice, in France, again, fairly close to here. But we tend to be absent in a lot of those meetings. And it's absolutely critical that that we present. And because when we go to those places, what we start seeing is then the environmental community becomes the champion for banning and for addressing cigarette filters. And it's much more powerful if you get environmental leaders to make that message versus it comes from us. So I think that would be another critical one to attend and engage in. And then same with the UN Convention to Combat Desertification, which is taking place earlier, it was last week. And those are the same negotiators that were at the plastic treaty meeting. Again, another opportunity to address, if 3 to 5% of global deforestation is due to tobacco, a product that does absolutely nothing for development. That's not an insignificant amount. So that should be the low-hanging fruit when it comes to desertification, addressing tobacco. But I'm sure that no one is talking about tobacco in those meetings. So that would be another area of engagement. It's very important that we continue working on the FCTC, high-level meeting on NCDs, but we need to go beyond that and use those other environmental platforms and mechanisms. And same with the Framework Convention on Climate Change. It's a very, very painful process, treaty negotiations that are moving very slowly, as you know, and maybe to some extent we could argue not as successful as we've been with the FCTC. But however, we need to engage, given that is over more than 80 tons of CO2 emissions are due to tobacco products. So again, not insignificant, and that again should be a low-hanging fruit, because when it comes to development and environmental issues and human rights issues, tobacco control should be the low-hanging fruits for governments to address. And that's it. Thank you very much.
Thank you, Laurent. Thank you for your personal involvement in connecting FCTC to other treaties and, of course, to your team, to HUS. Questions from the room? there. Olena, there. Please also introduce yourself. Yeah?
Hi, my name is Ana Chavez, and I'm a foreign species, invader species. I'm working on a series of public announcements to be shown in cinemas, trying to reach general audiences and help them link environmental impact with personal choices. My question, Laurent, has to do with the comments you made about raising an issue to these committees. Civil society, those of us on the outside of science and medicine, can maybe raise an issue. But could you please help me understand the context of the consequences? Once you raise the issue and you get a mention, what in fact would happen, for example, in Spain, where we have a huge child poverty rate, but we're still considered an upper middle class country. So what happens when you actually get through and pierce the veil, civil society captures their attention, and then we still have the new law in Spain that has a lot of holes in it. Great progress, but things we want.
So, so if you have the various committees, so various human rights treaties that Spain has ratified or any country, then the committee does make recommendations to the country. And then, as you saw in one of the slides, there is a process. So there's ongoing discussions and negotiations that do take place between the country and the committee. So it can be a powerful tool and a powerful tool for advocacy. Now, it's not maybe legally binding to some extent, but it can be used for in litigation. So, for example, in the context of in the United States doesn't ratify many human rights treaties, but it has ratified the Convention Against Racial Discrimination. And so we, in the context of the menthol case, for example, the United States has not implemented a menthol ban on tobacco products, a menthol flavor ban. And so we used, to some extent, so what we did is we submitted a report when the United States was due to report to the Human Rights Council. It was when it was due to report to the Convention Against Racial Discrimination. And we at the same time, we launched litigation, also using human rights, including in the litigation human rights arguments in it. Does that make sense?
Can you see something like that being helpful in Spain, where the people who know the most working on the inside have worked so long and so hard, and they know the subject best?
I think it would be, and I think also it's to some extent also it does put better pressure on the country, and because we don't have that with the FCTC, we don't have a reporting process and implementation review mechanism whether it's civil society and academia and others can engage in this process with human rights treaty bodies. It could to some extent serve as a further accountability mechanism, another implementation outside of the FCTC, but a process that we can use to shine light on what Spain has done that is good, because a lot of good things have been done, and where there's challenges, and what should be done to overcome those challenges. Like, for example, el decreto real, the royal decree, for example, for the cleanup of cigarette filters, which, with good intentions, some of you may be familiar with this. This is a decree that's been released, I think, in October of this year. But unfortunately, it puts the onus of cleaning up of cigarette filters on the producer, the tobacco industry. And what the industry does is basically uses for corporate social responsibility, et cetera, et cetera. So done with good intentions from the environmental, what would be the Ministerio de Transición Ecológica, the Ministry of Ecological Transition, et cetera, but it was unfortunately a mistake by putting the industry in charge of cleaning up cigarette filters. So using those human rights treaty bodies could be a way to highlight when this is done, when something has been done in a way that should not be done, and so on and so forth.
Thank you, Laurent. Other questions? Yeah, please, Christina.
So I think it's a great opportunity to include tobacco control in several treaties. You have mentioned that these treaties provide a better way to be monitored or to be evaluated. What mechanisms do they have? I mean, could you explain a bit?
Yes, so I'm sorry, I wasn't very clear then on this. So all of those treaties, so whether it's they have a generally between every 4 or 5 years, countries have to report back. So they have to submit a report back to the treaty body. And it's a process, and maybe I could put the slide back so you can. So maybe that can help. So where countries countries have an obligation to report. And what's the big difference with I don't have a pointer, but with the big difference that we have with the Framework Convention on Tobacco Control, where governments do report back at every COP, there's a progress report that goes back, but there's no engagement by civil society, independent bodies. In this context, there is a process. There is a process which allows for you can see this, so for input from UN systems and other bodies. So you can then submit written reports. You can make interventions. For example, in the context of the Convention on the Rights of the Child, we're able to have children go and make a presentation to the committee. For example, in the context of, as an example, Luxembourg and Liechtenstein, very small countries, are due to report. And the person in the committee, the expert committee member, came to us and said, well, I'm interested in tobacco. So what we did is we worked with the Luxembourg NGOs, the Cancer Society in Luxembourg, and they're putting together a very good report because they're due to report to the Convention against the SIDA, the Convention against all discrimination against women. They're going to be reporting in 25. So then what we're doing, we'll have an official submission that will go along with a state report that will address the real situation in tobacco for women in Luxembourg. And then it's part of basically then the official process. It stays, basically gets totally included then, and the country has to then report back. The country has to then say, oh, well, indeed we have a problem, we're going to do this to address the issue of tobacco use among women and so on and so forth. So those processes are going on. So for Spain is reports to all the treaties has ratified, and most of the European countries have to do that. And that is the problem we have in tobacco control, is we don't use that. So for example, other movements use it all the time, whether it's the HIV/AIDS movement, even in food and nutrition they use it. But we haven't been using it as much. And that would be something that we should do almost systematically. Use those mechanisms we've done it in Spain, but we did it once with the Universal Periodic Review, but we didn't do it, we didn't maximize on this. But if we integrate it within our work plans in the tobacco control NGOs and institutions, to do that systematically, then I think it would make a big difference, because that is one of the reporting systems that has one of the UN treaty mechanisms that have strong reporting systems. I don't know, did I answer your question?
Thank you again. I think it's time to go back to the keywords mentioned by Esteve at the beginning of the meeting, to decisive actions. And I kindly invite Lilia Olef here from Smoke-Free Partnership to tell us what decisive actions we need in Europe for a tobacco-free Europe by 2040. So, Lilia, please.
Yes, now it's on. Good morning, everyone. So I represent Smoke-Free Partnership. It's a coalition of over 55 European organizations. We do receive funding from the European Commission for now. Let's see what the future holds for us. So first, I wanted to show you the latest data from the 2023 Eurobarometer. Although Eurobarometer only captures European Union countries, doesn't capture the whole Europe. At the same time, it does allow us to track, same methodology is used, so we can see what's happened over the last 3 years, because the previous Eurobarometer was conducted in 2020, and the one before in 2017. And we see that between 2017 and 2020, there was a 3% point decrease of tobacco use. And this was actually happening after the Tobacco Products Directive entered into force. So we saw a drop of 3 percentage points. So what's happened between 2020 and 2023? So for all respondents, the drop was only 1% from 25% to 24%. And what happened for young people between 15 and 24 years old? There is an increase in smoking prevalence from 20% to 22%. And smoking in Eurobarometer, they are referring to traditional tobacco products, those that are smoked, so heated tobacco products, electronic cigarettes, and nicotine pouches were captured under different questions, and you can see what's happening for young people, prevalence among young people. Electronic cigarettes increase from 4 to 6%, heated tobacco products remain stable at 2%, nicotine pouches, for young people, it reached 1%, but of course we know that it's mostly, the use is mostly prevalent in Nordic countries, but actually we are hearing from partners from Austria, Germany, that there they are also seeing more and more of these products. And when you look at the map, what's happening in terms of the tobacco use in the EU, the various colors, so the dark blue represents the highest prevalence, and then blue still quite high, and red lower. And it's quite, we don't want to say diverse, but even EU, despite it's sort of having more common rules and practices applied, we see so many variations. And being in Spain right now is also quite important because although, yes, the plan is not perfect, but just 2 years ago, no one knew that finally Spain would move ahead with the new government. And what we are seeing consistently through Europe, that every time the new government comes, there is an opportunity and a threat. And it's extremely precious and important to be in the room with like-minded people, but we have to do more in being in the room with people who don't know what we are talking about, who are not exposed to tobacco control or various treaties that incorporate public health objectives and end goals. And specifically decision makers who are new or other stakeholders who've never before actually came across in details tobacco control and what we do, and the devil is quite often in the details because they might be confused with the new products debate. So actually the title of my presentation was a question mark at the end and not a full stop. We know what happens at the EU level can have a detrimental, negative impact on the whole Europe and world, and vice versa. So one of the recent examples, a country that's been mentioned already, Ukraine. Ukraine was the only country in Europe who had same excise rates on heated tobacco products and cigarettes since 2021. Every year the tobacco industry tried to overturn that change, and this year they managed to, after trying for 3-4 years, and they managed to infiltrate and find the mechanism to reduce the excise, which means that now excise on cigarettes will be higher than on heated tobacco products. And for the industry, it was all about the precedent, setting a precedent that they don't want to see that. And one of the key arguments that was used by the tobacco lobbyists, pro-industry decision makers, saying that EU doesn't have the same rates. Even the proposal that is not yet released, but even that one, the draft proposal, it didn't call for harmonization. So EU was used, again, the non-EU country, EU example, to lower the rates. And on the other hand, in Poland, they finally passed a substantial increase, excise increase on various tobacco products, and it will be an increase over the 3 years, reaching almost 64% of specific excise combined. And this happened after the new government came in place, and the Ministry of Finance and the leadership of the Ministry of Finance, they knew that this is an opportunity for Poland, because Poland was one of those countries that were not increasing taxes on tobacco at all. And Poland is one of the EU member states who can drive the change at the EU level. So it goes both ways. But let me also start with another good news that is slightly bittersweet. So here I would like to show you the current state of tobacco control at the EU level. So what's been adopted and what's still in the pipeline. So on the 3rd of December, which was last week, the Council, which consists of government representatives of every single EU country, they've adopted Council recommendation on smoke and aerosol-free environments. In the bubble, it was a big deal, and what was happening before was a big deal, but this is the first file that is part of the Europe's Beating Cancer Plan that actually set that objective of tobacco-free Europe, tobacco-free generation by 2040. So this is the first one that was finally adopted. And more to go, so Tobacco Tax Directive delayed since 2022, revision of that directive, Tobacco Products Directive 2 years behind the schedule. Tobacco Advertising Directive, which is from 2003, is sort of supposed to be revised, but it remains to be seen what happens. And there are other objectives that we should have in mind, and also the EU has, such as cross-border shopping issues, and of course Article 5.3, which is still part of the bigger scope of the rules that the EU has, but even with this new parliament, that European Parliament that we have now, some of the MEPs have been around for very, very long, but the majority are rather new. And those that work in ENVI committee, that's the committee that deals with tobacco control and public health matters overall, and also environmental issues. Some of them were exposed to industry, bombarding them with emails, letters, asking for the meeting, harassing, finding common friends, and trying to get those meetings. And hearing from people who've never been exposed to something like that when they were members of other committees, for example, Committee on Liberty. So this is a very important reminder and the reality check of how industry lobbies. And this is something that we should be using to our advantage, because once decision makers were exposed to that, for them, tobacco industry interference are not empty words once they witness it themselves, and that's when they become our allies. So a few more words about the Council recommendation on smoke-free environment. What was important for us is to observe the politics in the room. Because as with any matter, yes, there is the Europe's Beating Cancer Plan, there is a general awareness on that tobacco kills, there is obligations, international obligations, EU obligations. At the same time, as we just said, the tobacco industry is just not sitting around and waiting for us to do our job and take them out of business. We've actually observed that there were some countries that had to abstain from the vote, which was only Greece and Germany. Only 2 countries. They didn't vote against, they abstained, which means that politically it wouldn't look good to vote against. So the maximum that they could do, but it was a very hectic weekend before the vote, and I will get into that. We weren't even sure whether more countries might abstain because of the domino effect. There were several countries who've expressed criticism that there was no impact assessment, lack of scientific evidence, mostly referring to aerosols from electronic cigarettes and heated tobacco products. So those countries were Italy, Czechia, and Slovakia. And then other countries who took the floor and spoke and were supportive, but with a varying degree of enthusiasm, were France, Latvia, Slovenia, Estonia, Spain, Poland, the Netherlands, Ireland, Portugal, and Romania. This was a very reassuring council meeting, because countries who are the champions, they knew that they had to take the floor, and they knew that they had to speak up, and they did it. And of course, there were others, but this is a reminder to us that the job that you do, and sometimes it feels like you're just pushing that stone and you don't see the progress. It comes sometimes not in the shape and form that we expect, but one win at a time, and one small win at a time, and appreciating that. And here also I would like to demonstrate to you the quotes that were published at the website of the European Commission right after the country recommendation was adopted. Actually, that meeting was the first official meeting at which the new health commissioner, in his capacity of being approved the health commissioner, Varhili, he participated. So the first meeting and the country recommendation on smoke-free environment was adopted among other files. But also I would like to bring your attention to a quote that was put along the quote from the health commissioner, from Teresa Ribera, that I believe you are familiar with. Would be curious to hear your thoughts and opinion. But the fact that she's basically the second in terms of importance and power person in the commission after the president of the commission, Ursula von der Leyen. And where the current Spanish government stands and what was done at the national level, but also the position, how it changed before COP and after COP, we are looking for opportunities, and this is one of the opportunities to have an ally, not just someone who is rather hesitant, referring to the current president, Ursula von der Leyen, because that was decision of her commission to delay the revision of the files, other files that I've mentioned. What happened in the parliament just 3 days before the vote on Thursday, everyone was confident, civil society, decision makers, that the parliament, of course, would adopt a resolution stating their support for ambitious recommendations on smoke and aerosol-free environments. And over the night, and during the vote, we actually saw that that didn't happen. That was an enormous reality check for us. Again, that's why we were very worried about the vote in the council. But what we understand that it's not just necessarily that the majority of MEPs couldn't come to a joint vision on whether electronic cigarettes and heated tobacco products should be included in the scope of a recommendation which is non-binding for the member states. Imagine Parliament adopting a resolution that says that smoking should remain prohibited, but you can vape and use ICOS and GLO in public places. That would be unbelievable, unimaginable. The political part of it, that we saw how groups voted, and it became political, about certain groups not wanting to support and vote for the resolution of that specific group. And this is something for us to be aware and to prepare for the revision of the Tobacco Products Directive, because that directive, their parliament will not be just issuing a resolution jointly with Council. They will be revising and working in trialogue, so the parliament will be able to change the text. Here it wasn't the case, they were just adopting a resolution. And also I would like to to show to you a quote from one of the German MEPs, who is the coordinator for the biggest group in the parliament, EPP, who said that he's also a doctor, and he doesn't know any scientific evidence that when somebody uses e-cigarettes in outside restaurants, any third person has any risk, so that needs to be clarified. Whereas there is scientific evidence, which article sent it to me, it was in response to another MEP saying that. We'll not be delving into the details, but Peter Lies, he's the spokesperson on health matters in the EPP. He's been a member of parliament slightly less than I've been alive. So since 1994, extremely experienced and influential MEP. So knowing whom we are dealing with, where they stand, is one of the goals to bring us to those decisive actions and to the tobacco-free Europe. here I wanted to demonstrate to the delay of the revision of the Tobacco Tax Directive. It's actually happening even according to the official implementation roadmaps of the Commission. Same for the Tobacco Products Directive. The original intention of the outgoing Commission was to adopt the revised Tobacco Products Directive in 2024. And as I said, there are many opportunities when we are at the beginning of the mandate. One of them is that tobacco files are specifically mentioned in the mission letter of the new Health Commissioner, which is important. And other opportunities are the countries that will be holding the presidency in the Council. So now it was Hungary, and it was them who've championed smoke-free environments recommendation. Then we've got Poland, and I just told you that they've increased taxes, so that might be a very good opportunity for the revision of the Tobacco Tax Directive. Then we've got Denmark, also optimistic, and then Cyprus, probably not, Ireland, Lithuania, and our last chance to adopt the revised Tobacco Products Directive and hopefully advertising is under Latvian presidency, also because then it's election time. So we don't have that much time. And also if here you look at the lens of how long it takes to revise a directive at the EU level, well, at least 17 months, but for tobacco products, there most likely it will be second hearing, so 32 months. And this is a realistic scenario. We're talking about average. And Tobacco Products Directive remains one of the most lobbied files back at the time. So some of the key takeaways that I encourage you to reflect on when we understand the importance of going outside of the bubble. Understanding our audience, and one size does not fit all. If you are in the room with people who work on international law, it's one language. If you are in the room with environmental advocates, it's another language. If you are in a room with members of the parliament who are brand new to this whole bubble, different language. We are all faced with the fact that we are operating in a post-truth and low-trust landscape. So someone who is not supportive of you, they are not necessarily not supportive, but there is so much information coming various ways, and we have to know that the industry is good at what they do, right? So they did manage to create a narrative that misled some decision makers or stakeholders. And also, let's not forget that rational thought is value-based. So it's all decision makers who is one of the target audience. They are people, as we are. And although history doesn't repeat itself, but it reveals patterns. And the pattern is that the revision of the Tobacco Products Directive will not be easy. Here is a reminder of that it took a commissioner to resign to achieve the revision of the tobacco product. It was more complex, of course, but the tobacco industry is doing their work. Here at the bottom, you can see direct industry spending, dependencies on consultancies, staff. It keeps increasing and it will keep increasing. Thank you.
Thank you, Lilia, for your presentation. Just 2 comments before giving the audience the possibility to address questions to you. First comment is addressed to ECO team. Thank you for your work in TACSH project and in the joint action 1 and 2. You lead the work packages on smoke-free areas, so you have a big contribution to the new recommendation on smoke-free and aerosol-free areas, because your work was really used in preparing this recommendation. And my second comment is on the European Commission work in the past 5 years. It's a shame. No work in tobacco control. They played the tobacco industry game. Everything was delayed with at least 5 years. So they have huge debts for us, for the public health community, and we look forward to see if they will really do something in the next 5 years. So now, floor is yours for questions to Lilia.
Hi, Lilia. Thank you for your amazing presentation. I'm Ayaka. I'm doing PhD student. I'm doing PhD here at ICO. And could I see the first slide of your presentation? about the Eurobarometer statistics. I am so sorry because it's a quite minor point, because my entire topic of my doctoral thesis is about Eurobarometer. And then the first changes in smoking prevalence in the EU, the middle of the graph, I'm sure you got this information from the 2023 official reports, but the official report is somehow a little bit wrong, because 2020 it was 23% of the current smokers. And if you go to the official report 2020 Eurobarometer, it says 23% of the European Union people who currently smoke. So it's not 25%. So my interpretation of the results, overall prevalence of smoking increased compared to 2020, and then also consumption of new products has also increased. So it's very minor points, but this is information.
Thank you. Yeah, I think with removing the UK and recalculating the whole data, I don't know how, but I will talk to you after just to, thank you.
Other questions?
I don't know if Sarah is on the line, because we had one online question to Sarah Hitchman.
Okay.
I don't know
Sarah?
if Sarah, are you still online?
Yeah, hi, sorry,
Super.
I'm here.
So
Hi.
we have a question from Alex Nedelchev. He's asking, well, thank you for your presentation. You concluded by emphasizing that implementation is the key challenge and that further actions is required to improve it. So in your opinion, what are the 3 or 5 key actions that should be prioritized? Thank you.
I think we can look to the some of the NCD best buys as some signs of what policies could be implemented, because the NCD best buys look at some of the most cost-effective policies for implementation. So the key would be to highlight those and to we'd have to convince us. A few people made this comment about the need for these whole government approaches. So getting the whole government involved and motivated, and really making the investment case for tobacco control. Going to Armando's presentation, I mean, we continually hear that the biggest barrier for implementing tobacco control policies is the tobacco industry. And when we ask countries, this is the #1 barrier. So it's working together and continuing to monitor and counter the tobacco industry will be another important one. And also the importance of data and monitoring and keeping track of what's going on is also, I think, incredibly important. So I think those are kind of, in my view, kind of looking back. I mean, there isn't an official view, but that would be kind of what I think, or what I've seen today is really important. Thank you.
Thank you, Alex, for question. Thank you, Sarah, for answer. I think it's time to end this session, or we have more questions?
Do you want to ask? Ana?
Sí. Yeah. Question? Okay, please.
Hola. Olena me traduce. Estamos muy preocupados sobre todo por el término reducción de daños y el lavado de cara, ¿ves? El lavado de cara que pretende hacer la industria tabaquera con este término. Tanto la intervención de Armando como la de el siguiente, espérate, ¿cómo se llama desde aquí? Uber. Vale. Habéis comentado esto, el parañ, el engaño que pretende la industria con este término, reducción de daños. Y aquí precisamente se está llevando a cabo una campaña de recogida de firmas para intentar que la industria no haga un convenio para eliminar las colillas, puesto que ellos están haciendo un convenio para intentar eliminar las colillas, o sea, como que ellos, vaya, no sé el término en inglés, pero me da la sensación de que es como poner al lobo al cuidado de las ovejas.
I'm not trained translator. I'll do my best. So the question is about harm reduction, and particularly the case here in Spain. There is a convention to liaise You want to translate? But do people who don't have out, they don't have, yeah. So people, do you want to translate it by? I don't get. Anyway, question is about harm reduction, and there is some actions in Spain related and liaising with the tobacco industry on cigarette butts collection and everything. And what basically question is, how do we work on that, not working together with tobacco industry? And I think that's more refers to Armando's and Laurent's presentation. So I don't know if you can improve my translation and respond.
I think the question was focused mostly on this agreement to collect the cigarette butts under the agreement, which it's my understanding also it comes from a European Union agreement. So I don't know if maybe you can...
Well, and there's the recent royal decree, El Decreto Real, which also puts the onus of cleaning cigarette butts on the tobacco industry. So, ¿entiendes en inglés, no? También si hablo en inglés lo entiendes, ¿no? No. Ah, vale. Igual tendrías que coger auriculares igual para... because, bueno, pues... lo tiene, vale, muy bien. Pues, yeah, so the problem in Spain is that there is, because she brought up two topics especially that are important. One is obviously the co-opting of the harm reduction debate, or the terminology by the industry and manipulating it, because what they're not promoting harm reduction. Harm reduction is the concept of harm reduction in addiction is a very legitimate concept, the same way that surgery to treating cancer. But the industry is co-opting it, and this is why I pointed out, for example, to the report from the special rapporteur on the right to health, which, because then she makes that point that the tobacco industry is manipulating that terminology basically for its own purposes and more for marketing than it is for real harm reduction. And then in terms of, you're totally right, it's really problematic if the industry is in charge of the cleanup of cigarette filters. And we've seen that in France, in Belgium, where there is, within the European, there is a number of the Green Deal, there's a number of measures that encourage and have governments ensure that there's the cleanup of cigarette filters takes place. But in France, for example, what they did, they created an eco-organism called Alcom, and this was totally subsidized by Philip Morris, by Japan Tobacco International, et cetera, et cetera. And then they use it for corporate social responsibility, and they do promotion of their image, and a little bit like the video that you had from California from the 90s. We're like, oh, we're good, we do this, we're like into I don't know what the crocodile was saying, we're into public service and and it's manipulation. So yes, we have to be very careful with both of those.
In fact, this mess was created by the European Commission because the Single-Use Plastic Directive was in the hands of DG Envy. And after they adopted this directive, we went to them and we tell them, look, but this is not good because Article 5.3 is not taking into account. And they said, yeah, but FCTC is related to public health. Then we went to DG Sante together with SFP, and we told them, look, it's a problem with sub-directive. And they said, yeah, but it was not in our yard, it was in DG Envy. So this is a clear example of bad implementation of FCTC even at the EU level inside the European Commission. And now we have to deal with the results.
I think we have one last question online and maybe some, yeah? But let's try to be very quick with our questions and response.
So we have a question for Dr. Armando Peruga. And if the tobacco industry is so effective in interfering, is it partly due to the lack of accountability among public officials And if yes, in your view, what are the 3 main actions national governments should take to deliver a systemic solution?
Well, a complex issue to respond, but I would say that they're relatively effective, and we have a duty to respond at the global level, meaning not only by governments but also the civil society. Having said that, it is a pity that some government officials, especially I'm thinking of the president of Extremadura, recently, a few days ago, were very keen on thanking the tobacco industry for everything they've done for Extremadura, which is a problem of just undermining the FCTC. The 3 things that I think that there's one thing that has to be done first is to inform through the appropriate mechanisms in Spain about the Article 5.3 of the treaty of the FCTC, because I think that if they were aware that what they say really, that the president of Extremadura really said was against an international treaty, they would have probably phrased it in a different way. That doesn't mean that we will remove the collusion between certain politicians and the tobacco industry, but at least we will offer the opportunity for the civil society to intervene in these situations. So I don't know if that responds to the questions or not, but it's an issue of political will that needs to be addressed very strongly at the national level and the regional levels in Spain.
Thank you, Armando. I think we really have to close this session. We are only 15 minutes late. Sorry for this. And thank you again for your presentation and your answers. And okay, good luck to the next speakers.
We don't have a coffee break, but you can use this few seconds to stretch, to move, to say hi to people around you. But don't go out. And that's what we want to work on this next session that will be moderated by our researcher at the Catalan Institute of Oncology at our Tobacco Control Unit, Dr. Montse Balvé. So, Montse, the floor is yours.
No. So, good morning to everyone, both those that are here in person and online. I'll be chairing this second session on another very important topic that is regarding the regulation of tobacco products, with a special attention to the newest ones like heated tobacco products or other products with nicotine or synthetic nicotine. Because sometimes the appearance of these products on the market happens so quickly that sometimes we are unable to keep up with these new developments and respond promptly. Our research and regulation always take longer. This product represents a significant obstacle and a serious threat to the progress of the tobacco control, and regulation is one of our most powerful tools to manage this issue. And to talk about this topic, we have here 3 excellent speakers. And at the end of the 3 speeches, we will have some time for discussion and questions. So now allow me to introduce the first speaker. That is Ghazi Zaatari. Dr. Zaatari is a tenured professor and chair of the Department of Pathology and Laboratory Medicine at the American University of Beirut. He is the secretary of the International Academy of Pathology, vice president of the Arab Board of Pathology, and member of the High Council of the Arab Board of Health Specializations. He's also the chair of WHO Study Group on Tobacco Product Regulation, member of the Executive Committee of the Tobacco Laboratory Network, and director of the WHO FCTC Knowledge Hub on Water Pipe Tobacco Smoking. Today, he's going to delve into synthetic nicotine and regulatory considerations concerning it. Professor Zaatari, thank you very much for being here. We're looking forward to your talk. The floor is all yours.
Thank you for this very kind invitation, and it's a pleasure for me to be in this beautiful city of Barcelona, let alone to talk about a topic that's very dear to my heart, that is, tobacco control. Before I proceed, I hope I'm going to shift your paradigm. We have been talking all this morning about tobacco, but the hard core of the issue is nicotine, and that's what the emphasis should be. And also, being in a cancer center, I felt I want to share with you some statistics on cancer. I'm a pathologist. I diagnose cancer every single day, and much of it has to do with tobacco and tobacco use. And tobacco use continues to be in the form of smoked tobacco products, the most widely used tobacco product. Let's look at the global picture. There are 20 million people that come down with cancer each year, divided between men and women. So you can see they're divided. Almost equal numbers, 10 million each. And here we're talking about only cancer without talking about the cardiovascular complications. And if I list to you the top 18 forms of cancer, you see that those that I circled in red, their etiology is directly related to tobacco. So you can see the magnitude of causing disease when it comes to cancer, sitting here in a cancer center in Barcelona. But the shift of the car now is about nicotine. And nicotine comes in the different types. The most common type is the one that comes from extracted and derived from tobacco leaves. Tobacco leaves are very rich in nicotine. And people smoke tobacco not for the tobacco, but they smoke it because of the nicotine. And the industry over the years have succeeded in manufacturing and synthesizing it. So today we have the synthetic nicotine. And later on they modified it, they acted with acid, and they turned it into a salt. And then finally now we have the analogs, things that look like nicotine but have effect like nicotine. So you see your task here is going to be very complicated. Nicotine is alkaloid, it's very bitter. And it is coming in from the tobacco leaves. Most commonly what we use are the Nicotiana tabacum and Nicotiana rustica. These are the two most commonly used tobacco forms. These are the plants. But the nicotine itself has an insecticidal effect. It is teratogenic. It is neurotoxin. And it also has an anxiolytic effect. That's why when people smoke it, they get a bit relaxed. And it comes in two major what we call racemeric forms, the S form and the R form. And in tobacco leaves, the S form is by far is the dominant, talking about up to 90% in the tobacco compared to 1% to the R isomer. So both have different effect, while in general, the S form is 7 to 15 times more toxic and potent, and I'll come more to give you details to explain what do I mean by this. See, these are the two forms. If there are this of you who are scientists in the group or chemists, the molecule have this S configuration, and these are the binding different molecules that will give it the characteristic for each of these two isomers. Now we're coming about the effect. If I talk about the two effects, if you look about the toxicity, and we define this by taking a group of rats and expose them to the nicotine and see how many of them will die, 50% of them. If I do this for the S isomer, a dose of about 0.33 milligram per kilogram is enough to kill 50% of them. While if I take it for the R isomer, it is 6.15 milligram. Consequently, what I'm saying is that the S form is 18 times more toxic than the R isomer. In other words, also, if you look at the pharmacological effect, that is, if I look at the administration to increase the number of these nicotine receptors or binding sites, the S form is more potent by 10 times when I compare to the R form. And if you look at the tobacco industry-sponsored research, if you look at the degradation, the R isomer is more potent in this degradation as compared to S form. And similarly for the behavioral effect, if you look at the discrimination between the two, you can see that when you look at the behavior, the S-nicotine was 4 to 5 times more potent than the R-nicotine in conditional taste aversion studies that are done in experimental animals. And if you look at the metabolism, again, they have different forms of metabolism. S form, oxidative, while that of R form, it has also methylated metabolites in combination to the oxidative effects. And finally, if you look at the psychophysical studies, that is, look about the odor or the irritant sensation, S form is has a burning sensation and more detected by the olfactory perceptions when compared to the R form. So you see there are differences where their molecule is very similar, but their effect is very different. And that's something we need to know. So there are knowledge gaps, and the reason for this today, because some of the synthetic nicotine has a 50-50 mixture of R and S. So we don't know the effect of this when people use it. And I'll come to explain to you the different manufacturing that exists today in the market. Second, we don't know about the long-term effect. When studies are done, it's done over a short period of time. When we talk about population, we need to have the long-term effect, something we don't know. And then thirdly, in none of these studies we have effect on the inhalation and ingestion. So this is something information that is still missing in this comparison between the two. So synthesizing nicotine is not new. It has been known since 1904. And the industry has known about it and considered using it back in the 60s, almost like 60 years ago. But over time, one of the inhibiting factor was the cost of it to synthesize it. That's why it was not popular. It was easier to extract it from the tobacco leaves than to do it in the lab. And today, there are 5 major manufacturers to this product. There's the Next Generation Lab, which is in the United States. There is Contraf Nicotex Tobacco, which is in Germany. There is a company in the UK, Xenoprima Life Sciences. And the fourth is in China, the Hangsen International Group that is producing Motivo. I'll come back. And there's a legal fight between the last two about the right to this product. And then Enjoy in the USA, and I'm sure you know about Enjoy, its product with the. So these are marketed under a variety of names, like tobacco-free nicotine, imitation nicotine, nicotine substitutes, nicotine analogs. And I'm mentioning these to you for those in the regulation, for those in your audience are regulators, to be aware of this terminology so they won't be misled by the industry. These are the companies, this is what they produce. What I want to mention to you here is to highlight the one at the top. What they produce in the market, it is not a pure, it is synthetic, but it is a combination 50-50 of the S and the R. And that's what I said, we don't know about the long-term effects of these. While the others have that ability, but most of what they produce in the market is primarily the S synthetic nicotine. Why this is important? Because we'll come back to see this is in the products that we're seeing in the market, and I'll share some of this information with you. This, for example, is one of these that is producing by the Chinese, and it's called Motivo. It is widely used, and it is sold as unflavored and flavored. So you have this recipe, you can choose whatever you want. And they sell it to these other manufacturers of the products that my colleagues will be talking about later this morning, how this is being used by the others in order to manufacture nicotine products. Forget tobacco now. They want to sell you nicotine. And we learn about the chemistry of it. We have been much more knowledgeable. When people are smoking the cigarette, they add alkylating compounds to free that nicotine. We have this free nicotine that will be fastly absorbed in your body. Well, but they discovered something better. If I add acid, it makes it more tolerable. The user is more accepting it. It is not as harsh. And guess what? We can get a higher concentration of nicotine. See? So they've been successful in doing this. So what we take this nicotine, we synthesize it, we add acid to it, and make it a salt. So now this is where the magic of it. And there are three most commonly used acids for this purpose. There is the lactic acid, benzoic acid, and levulinic acid. These are the commonly used. When you see benzoate on this product, it's giving you a flag. You're dealing with a salt. And these, they have found their way. We started with synthetic nicotine. Now we have the salt. And now we see them in e-cigarettes, in heated tobacco products, in pouches, toothpicks, snuff moist, and others to come. So I want you to be more informed about this so you can make the judicious decision about how to control the use of these products. And my colleagues will be expanding on these later on. So this example, for example, these are some of the things in the e-cigarettes. I don't know, Ranti will be expanding on this, but the one to the right will show you the trademark of the company that's producing the 50-50 racemic compounds. Now, the dangers in a study like this that conducted on 16 most common disposable products by this company called puff devices. Look at the concentration of nicotine that was reached. The range was 40 to 52 milligrams per ml of nicotine. Just to show you the amount. The average is 44. And these are disposable. These kids pick them up, smoke them, and throw them away. And these have, the synthetic nicotine. Also, they found their way to nicotine pouches, and I know Ransky will talk more about it. And look at this here. They say, this will give you to quit smoking. This is the manufacturer. It's available on the bench in a pharmacy. Just you walk up, buy it, and it's just going to assist you quitting smoking. It's a cessation tool. Well, how can you do cessation when the concentration of nicotine can be up all the way to 30 milligrams? So you see now how this industry is trying to use this information and how there are all this misleading information, and you'll hear more about this. Even the concentration of nicotine that is reached in the body is quite high as compared to other tobacco products, or even the nicotine replacement therapies. And that's why they have been very successful trying to promote it in order to achieve this projected. So these protonated nicotine, that is the one that has bound to the acid, these are responsible for higher and faster nicotine absorption than the free-base nicotine. Now, the wonder of cigarette, when a smoker uses a cigarette, in the order of seconds, the free nicotine is able to to bind to the receptors in the brain. The absorption starts in the mucosa of the mouth. And that's why it is the best nicotine delivery system that we know of, the fastest. And this slide is showing you this peak that goes up very shortly right after you use it. See this very sharp rise in the nicotine level, and this is after using a product like a cigarette. All the others, the snuff, the replacement therapies, are slower in reaching that level of nicotine, and that's why they're disliked by those who are addicted to nicotine. Now, with the e-cigarette, now it is ability to reach up very closely, not as fast, but fast enough to reach those levels of serum nicotine that will give the user the satisfaction they're seeking. And not only that, there are these multiple variables that will control the amount of nicotine efflux or influx that goes out of these e-cigarettes, depending on the design features of it, depending on the heating element, the liquid itself, the concentration of nicotine in that liquid, as well as the user behavior. So all these variables interplay in getting the amount of nicotine that will satisfy the user. And look at this here with the pouches. And even that, you could see some of these concentration. If you look at the one, is there a pointer here? Is this a pointer?
I think it's this.
Yeah. You see here, in the cigarette level, this is the amount you get in the tobacco. The one with the tobacco cigarette, it's here. But you can see the amount that you can reach with the nicotine pouches now, because of the high level of nicotine that is included in some of these products. And even fast, not only that, but also they can give you this fab because the absorption, you can see just in the order of minutes, you can reach that high level of nicotine, serum nicotine level that will give, because you just put it on your oral mucosa, the absorption will start. So I hope I gave you a picture of what the nicotine is, what synthetic nicotine is, those that are available in the market. But what's about the legal landscape? Unfortunately, the large majority of countries so far have failed to recognize this in their rules and regulations and policies. There are those that do not cover synthetic nicotine as such, those that only certain aspects of the nicotine, synthetic nicotine products, and those that are also, they have it in a broad coverage, and those that are unclear, very ambiguous, and not specific language they are using. And there's a nice study that has been done by Professor Berman and Zettler, just elaborating this, and you can see that the large majority out of the 200 countries they surveyed, they have only 92 of them did not cover the synthetic. So the large majority of countries have failed to recognize this. I'm not going to labor you with all the details, but just I hope I impress on you the fact there is a homework that needs to be done at the global level. And many countries need to come back and revisit their laws to ensure that there is explicit, clear language when it comes to the use of nicotine and synthetic nicotine. So FCTC as such addresses only tobacco. When you come to talk about nicotine, they cannot do that because it just will change the terms of the treaty. So now we have to come back and be creative and how we can go around this legal thing in order to ensure we incorporate reference to synthetic nicotine as well as nicotine. So synthetic nicotine refers to nicotine that's chemically synthesized through laboratory processes rather than extracted from tobacco. The definition includes all forms of nicotine regardless of isomeric composition or production method when synthesized artificially. Other discussions for regulatory purposes, any product containing synthetic nicotine shall be classified and regulated as a tobacco product. These are some of the things, the language that have been proposed. And this includes e-cigarettes, nicotine pouches, gums, lozenges, etc., like I mentioned earlier. And also, manufacturers must disclose detailed information or contents of such products in their marketed products. And at the same time, we have to be cautious about the advertising, promotion, and sponsorship of synthetic nicotine products, which is now may go unobserved and unrecorded. The US FDA defined as any product made or derived from tobacco or containing nicotine from any source that is intended for human consumption, including any component, part, or accessory of a tobacco product. So this is where I think each country may have to come up with a division and to ensure that the language there incorporates such protective and more effective regulatory control measures. I'll conclude here by talking about analog. These are the new things that are coming out. This is just a modification of the molecules of nicotine. I'm not burdening you with the chemistry, but we have come to know about these anabasine, anatabine, and micrones, which I see them here. These are analogs. They're finding their way into the product. They have effects similar to nicotine, and you find them now in the market. And look at this pre-bar disposable. Look at their marketing. They have zero nicotine. They're correct. They're not being dishonest. They don't have nicotine, but they have the analogs. So if we don't have this effective regulation to mark also not only nicotine, but also the brand, and look at this as usual, the marketing tools that are used, this glamorizing, these things that look like, and this is where you have to be careful. So the policy recommendations is to go back and look at any regulatory gaps to ensure that these are amended to incorporate reference to these synthetic nicotine products. The other recommendations that if you decide to do so, and I hope you do, is to extend the coverage of the laws to the full range of synthetic nicotine products. And to be futuristic a bit, the industry, we're always like this cat and mouse game. We have to be ahead in this game. And that's why we need to use the language that will be more incorporative of all the potentially that could be introduced in the market, including the analogs, for example. And also enforce standards of the purity of the synthetic nicotine. As I mentioned to you, what's being synthesized, we're not quite sure what it is sometimes. So they have to disclose this information and make sure that all this information is clear-cut and disclosed to the policymakers, and also to ensure that, and also to avoid the mixing, because this will make it a very difficult game to control and regulate. And also we consider the banning of these, especially the nicotine, because we don't know the effect of it on the long term, how this is going to be used by the industry, as well as restricting the marketing practices of the company. I don't have to tell you about it, all these kind of the misleading information about healthier, purer, odorless, all this is misleading. So in conclusions, companies are marketing an increasingly wide range of these products. We have to be more informed. We have to be more aware of them, because ultimately they are addictive, and if the ambition is to how they're effective, we have to be, we don't know, and we have to be very careful about this. So we urge member states to regulate them, and the knowledge effect on their health effect remains to be in the very early stages of this. So we have to be watching out and learn more about these and these as a consumer products. For those of you who would like to know more about this, the study group on tobacco product accreditation that I have the honor of chairing and have the contribution by outstanding scientists, we have this publication. It's available for you for free. You can download it. You're welcome to use my presentation to promote these notions. I have no objections. And with that, I conclude, and thank you very much for your listening. And I'll be happy to take any questions.
Thank you very much, Dr. Zaatari. Very interesting insights. Let's move to the next speaker. I would like to introduce Dr. Reinsky Talhut. Dr. Talhut has a PhD in physical organic chemistry and master's degree in the philosophy of science. She's a senior scientific advisor at the National Institute for Public Health and the Environment in the Netherlands. She's also the head of WHO Collaborating Center for Tobacco Product Regulation and Control at the same institution. And as a policy advisor for tobacco product regulation, she provides advice to the national government, to the European Union and the WHO. Today, Dr. Talhut will be talking about nicotine pouches and their regulatory considerations. Professor Talhut, thank you very much. It is a pleasure to have you here with us. And I turn the presentation over to you.
Yes, so could I have my slides, please, or is it this? No, that's not mine. Oh, no, I see now it's in the same presentation. Yeah, I did not get that, excuse me. Yeah. Yeah, that would be fine.
Sorry for that.
Thank you very much. So thank you, Dr. Balber, for this kind introduction. And my presentation of today will follow up on what Dr. Zattari just told you about forms of nicotine. And I will focus on one specific product, nicotine pouches. We already saw in a presentation earlier today that prevalence of use is still low in the European Commission, but it's also, in the European Union, but it's also well known that prevalence will increase the longer a product is on the market. So most of what I will present today has also been reported in a TOPREC paper. It has just been told that this is the WHO study group on tobacco product regulation. And I just want to emphasize that this is an important advisory group that provides the Director General with sound evidence-based recommendations to member states, and that those reports are also scheduled on the Conference of the Parties agenda. So this was one of the papers in the last report of TOPREC. Here you also see my co-authors. It was working together with one of my colleagues, with John Hopkins and with WHO. And it's about characteristics, use, harmfulness, and regulation. And for the last part, it's important to understand that not many countries regulate this product yet. For example, in the European Union, nicotine pouches are not within the TPD. So at the moment, we hope, of course, that this may change after a revision. But at the moment, countries need to make their own provisions for that. First of all, some characteristics of the nicotine pouch. It's maybe inspired by snus, which contains tobacco and is often used in Nordic countries and also in the United States, not so much in other countries of Europe. But instead of containing tobacco, it is at least claimed not to contain tobacco, but instead it contains powder containing nicotine. It's often white or off-white, and sometimes it's referred to as white snus. So it's placed under the upper lip, and ingestion occurs via the mucous membrane and saliva in the mouth. So it's an oral type of tobacco product. Ingredients are nicotine, fillers and other additives, stabilizers, and also important sweeteners and flavorings, which give a pleasant taste by themselves, but also serve to mask the harsh taste of nicotine. Typically, a can contains about 20 to 25 pouches, and nicotine dose is typically around 3 to 50 milligrams per gram, which is in the same order of magnitude as the amount of nicotine in snus. And they contain a variety of flavors. I also want to mention that there are also nicotine pouches seen on the market that contain very high levels of nicotine. One example has been found of 150 milligrams per gram. So that's actually quite high. And as you see, this example also has some nice fruit flavors depicted on the can. First of all, an overview of all the different risks of nicotine pouches. I will go in depth on in the next slide on most of these aspects, but this serves as an overview. So they have attractive features, which serve to engage a new target group. They have high nicotine levels, and they undermine tobacco control policies. So regarding attractive features, they contain many flavors and sweeteners. But also they are easy and discreet in use. So they don't have well, maybe the stigmatizing aspect of smoking. And also they can be used in places where you cannot smoke and nobody will notice that you are using them. They're perceived as less harmful than other tobacco products. So for health concerned smokers or other tobacco users, this could be considered or at least marketed as a solution to them. And they're perceived as effective to quit smoking, and there it does not help. We just saw an example in the presentation of Dr. Zattari that sometimes they're even marketed as smoking cessation tools. But there's really no proof for that. Regarding nicotine levels are that high that it makes them harmful to health, especially for the nervous system, and it can give cardiac arrhythmias. It's sufficient nicotine to sustain addiction, even though at most levels it does not give the fast kick like inhaled products. At these high concentrations, such high peaks can be reached. The flavor might also be a little bit more aversive then, but with the modern type of products, maybe they may get as addictive as inhaled products. And yeah, it could also be a gateway product to other types of tobacco products. We've seen that with e-cigarettes, so maybe with this class of products as well. And regarding undermining of tobacco control policies, well, I just mentioned that you can easily use them and very discreetly, so it can be used at places with a smoke-free policy, and people will not notice that, and it will also allow a person who would usually smoke to take this product and, well, still sustain the nicotine addiction. Then regarding marketing, they're heavily and aggressively marketed with many advantages. For example, that they're less harmful, that they don't give any smoke, and that they're tobacco-free. You see an example of that in the right-hand corner of this slide. They're also marketed as having no smell, as mild, slim, and flavored, and as discreet, and that one can use them everywhere. So this, let's say, advantage of not giving smoke and allowing to smoke in a smoke-free place is really emphasized. Regarding packaging, you can see that they have colorful packages, which are also appealing to youth. A new way to engage attention is social media, and that's also an important place to market nicotine pouches. For this purpose, music artists are used, also football players and influencers. Now, here an example from my own country, which is the light, please? Because I don't see it. Now, yeah, anyway, you will see on the left-hand side, on the below side, a young man drink. Okay, that always happens to me. So then I try it and it doesn't. Oh, yeah. So this picture over here, that's, yeah, you won't know the guy, but he's a famous Dutch singer. And you see that when he's enjoying his glass of Vinho Rosado, there's also a can of nicotine pouches waiting, well, maybe to be consumed afterwards. Influencers also serve to market these products. Regarding flavors, such pouches are available in a variety of flavors. You see some examples over here. For example, that they have a mellow taste, a frozen taste, the flavors you love, and also intensity and flavors that last. Most popular, at least at the moment, are menthol and mint. Products with cooling compounds, with descriptors used such as ice and frozen, and also fruity and sweet categories. So you may notice that this is quite similar to e-liquids. They also typically have those flavors, and they're well loved by young people. And also, flavor descriptors can be combined. For example, this is a nice description of a balanced combination of sweet and tart pineapple with creamy coconut and a nutty undertone. Well, that sounds quite delicious, and sometimes if they're also given concept names so that the flavor is not really mentioned, but it's rather implied, for example, by using tropic breeze. So in countries where one cannot use flavor labels on the pack, that would be a good solution for nicotine pouches as well. Then, regarding addictiveness, yeah, we've already seen some information about that. So, when using a nicotine pouch, the plasma concentration can be as high as when smoking a cigarette. With most concentrations, the peak will be not as fast as with smoking. For cigarette, it would be typically 5 minutes, and for nicotine pouches, some 20 to 60 minutes. And we do know that the fast peak, or also called rush or buzz after smoking, is vital to addiction, as it causes strong conditioning between the behavioral act and the resulting reward. And for most of these pouches, the rates are more similar to that of oral nicotine cessation products. But as we've just seen, at high concentrations, this may be different. Not only will the peak height be much higher, but also can the peak be reached faster. So for these new generations, maybe they will be more addictive and maybe be closer to cigarettes. So that's really concerning. Regarding risk assessment, so the most important compounds with toxic effect here is nicotine. And yeah, at a certain moment in the Netherlands, we also saw a rise in these products, and our government wanted to act on that, and they also needed to imply a certain law to regulate it, because as I just mentioned, it's not under the not under the Tobacco Products Directive, and also not implemented in the National Tobacco Act. So the way they wanted to go is to regulate it as a commodity, and commodities can't be toxic. So RIVM was asked to do a risk assessment, and yeah, the risk was assessed of nicotine, taking as a point of department acute reference dose of 0.0008 milligrams per kilogram of body weight. And that can be considered the highest single dose that can be taken without risk. And it's based on a study where a certain dose of nicotine caused an increase in heart rate. The exposure scenario was 1 pouch absorption via oral mucosa. And then it was concluded that for a typical adult, I would say in those days 60 kilogram is a little bit on the light side for a typical adult in Europe, unfortunately. But then this dose will not be exceeded by 1 pouch containing less than 0.035 milligrams per nicotine. So that's a very low amount of nicotine. You will remember that the typical dose is around 2 to 33, and much higher levels have also been noticed. So for a commercial company, it will not really be worth the while to market such a product, because this will not be an attractive product for a person that wants to use it as a nicotine supply, because one just cannot use sufficient pouches per day. So these products, as of then, were prohibited under the Commodities Act. But then, yeah, as we've just seen, industry is very creative, and they come up with nicotine analogs. So in the US, the definition of nicotine is strictly nicotine, and that left open some room for use of components that are strictly speaking not nicotine, but rather an analog. So let me try again. Yeah. So here you see normal nicotine, and here you see 6-methyl nicotine. You will notice that the difference is this group over here, called the methyl group. So it's very similar, but just a slight difference. It's similar to the use of synthetic drugs, where always small modifications are made to make it a new compound that's not regulated via the opium list. And these compounds are sometimes not covered by tobacco laws. I just mentioned the example of the US FDA. In the European Tobacco Product Directive, nicotine is defined a little bit wider as a nicotine alkaloid. So most regulators would consider these analogs to fall under this definition. But on the other hand, many nicotine products, in fact, at the moment only e-liquids are regulated by the TPD. They're not covered at the moment. Also, there's not much known about their toxicity and addictive potential, so this would be a loophole to close. But yeah, at the moment, this solution was not available, so our government asked RIVM again, when these products appeared on the market early this year, to do an other risk assessment, to do the same trick as with nicotine pouches. So these products came on the market, also with the explicit claim that they do not contain nicotine, various levels of 6-methyl nicotine in carefully designed can with several flavors, very similar to, let's say, the classical nicotine pouches. And according to the manufacturer, this compound is synthetic and not of tobacco-extracted nicotine, and the argument was thus it cannot be considered an alkaloid. So they were already trying to find some arguments about the TPD definition. So very limited data were available, so it was decided to follow a read-across approach. So the assumption here was that it is as potent as nicotine, and just a slight correction was made for the slightly higher molecular weight, resulting in an outcome that 38 micrograms of 6-methyl nicotine per pouch would be toxic, as compared to 35 micrograms for nicotine pouches. So a very similar and low amount of this compound is already toxic. Yeah, and again, this was much, much, much lower than the amount of 6-methyl nicotine typically present in pouches, so also not very commercially interesting to remain that product on the market. But developments have been going on. So at the moment there's a ban of nicotine pouches containing these levels, but as of January next year, the sale of nicotine pouches will not be allowed at all, not even with nicotine or 6-methyl nicotine in these low amounts. Then they will fall under the Tobacco and Smoking Products Act, and a total ban will apply to these products. So they will be considered to be on the market as a tobacco product for oral use, and a total sales ban will apply to all these products, and also an advertising and smoking ban will be effective as of that day. And this will not only be for oral nicotine products, but also for inhaled products. So any type of nicotine product will be covered by the Tobacco Act. And I think this is good progress. Well, going back to the reports again, we've seen that many regulatory approaches have been used over the world, so as consumer product, as food, as poison, even as medicine or pharmaceutical product, as their own class, so nicotine pouch, as nicotine-containing product, as tobacco-free product, as tobacco alternative, or as imitation tobacco, and also now as a tobacco product. So many different approaches are followed, and it's not really harmonized. So here are the key findings of the report. I will walk you through them. So we've seen that these pouches have become available on many markets worldwide, and that their sales are growing. That they deliver sufficient nicotine to sustain addiction, that they have many attractive properties, and that the nicotine present in these pouches is at a level harmful to health. There are few data available, as they have only been on the market for a short time, and so a cautionary approach is needed. And they are not often not regulated in the law at the moment, and it's advised that countries make their laws future-proof and resilient, and that they also are careful that they cannot be exploited for legal loopholes, such as the case I just mentioned with the analogs. Now, as said, these documents are also discussed at the COP, and parties were asked to consider the recommendations of TOPREC as follows. So to establish surveillance, not only of the target group, but also of the different products on the market regarding nicotine pouches, to regulate them, at least to prevent marketing to young people. Also to regulate non-therapeutic nicotine products in the same way as other types of products that look very much alike. And at least not to have these products on the market as pharmaceutical product unless they can be proven to be effective as smoking cessation tool. And that's what I had to share for now. Thank you.
Thank you very much for this interesting presentation. And let's bring in the last speaker, who's going to go over this topic. That is Ranti Fayakun. Dr. Fayokun works within the No Tobacco Unit in the Health Promotion Department of the World Health Organization in Geneva, where she supports country implementation of the Articles 9 and 10 of the WHO FCTC. She has close to 20 years' experience working on tobacco product regulation at national, European, and a global level. Dr. Fayokun is a multidisciplinary scientist with a bachelor in biochemistry and a PhD in chemical science. She coordinates the activities of the Global Tobacco Regulators Forum, the WHO Tobacco Laboratory Network, and the WHO Study Group on the Tobacco Product Regulation. Today, she's going to focus on the regulatory factors of electronic cigarettes and heated tobacco products. Dr. Fayokun, such a pleasure to have you here. You have the stage.
Thank you so much for the kind introduction. And it's lovely to see you all today. And thank you for the invitation to present on this very important topic. So you heard from Professor Zaatari, the challenges as well as the science of many of these products. The new challenges also in terms of nicotine analogs being used in these products, the uptake by children, and you also heard from Dr. Talaut the challenges associated with the nicotine pouches, the high nicotine concentrations, and as you said, I'm going to focus mainly on the recommendations, but then in looking at the major challenges and the request put forward to WHO to provide authoritative guidance to address some of the challenges that have been shared by the previous speakers. So I would just start by setting context. I think most of us know what these products are. There are a number of, I don't want to say new, but then we can still regard them as new because there are newer products being put on the market. You heard from Dr. Zaatari earlier that there are now products using analogs and other things being added to these products. So there are some products also that have been on the market for a while, but then they are changing at a very rapid pace given the way the products are being basically, I don't want to use manipulated, but the characteristics of the products are changing, so they're emerging products. So I'll address the first two categories of products, so looking at electronic nicotine delivery systems and electronic non-nicotine delivery systems, which are commonly referred to as electronic cigarettes. And we at WHO tend to refer to them, I know they're not popular terms, we tend to refer to them as such because there are a number of products beyond e-cigarettes. There are e-vapes, there are e-pipes, e-cigarillos, e-shishas, so we try to kind of put them on the, a broader category to kind of take all the other products into consideration. And there are some products, some of these products that contain nicotine. Those are the electronic nicotine delivery systems. And there are some that are not supposed to contain nicotine, although we have seen the latest development with nicotine analogs. But then most of the ones that are not supposed to contain nicotine, most times when they are tested, they're found to contain nicotine. We have other categories of products, as you heard from Dr. Talaut, so nicotine pouches, and then HTPs, but then we're not addressing those today. I am going to just talk about the recommendations for electronic cigarettes. So we gave the recommendations for the two categories of products. When you look on this slide, as in like both the left and the right-hand side, you can see that the difference there is nicotine. And as I mentioned, most of the products, we actually conducted some studies at WHO ourselves to look at the products that are labeled not to contain nicotine, but they were found to contain nicotine. So these are some of the products, different types of products that are on the market, but then there are other products now that have emerged in recent times, and I'm going to show you some of those as well. So on the left-hand side, what I mentioned in terms of the different products, e-shishas, e-pipes, and the other products that are available, and then flavors that are being used in these products, many of them are flavors that appeal to the younger generation, as you can see. And I'm going to give credit to RIVM because I really like this flavor wheel on the right-hand side. It's as a result of research conducted at RIVM, and they look at the yeast liquids on the market in the Netherlands and did this beautiful flavor wheel. I've really advertised it for them because it's almost on every presentation, in every presentation in e-cigarettes that I do. But then the most important thing about this flavor wheel is that there are many of the flavors that are used in electronic cigarettes that appeal to children. So these are some of the products that are on the market, and you can see that they are made to basically appeal to different demographics. So looking at the ones that look like lipstick, targeted at women, the ones that look like toys, and then you can see that on the right-hand side here, this one, it's just so that kids are able to conceal it from their parents because this is, you know, looks like a pen, and this also can be popped out and basically vaped because this is a vape and it doubles up as also a wristwatch, as you can see. So this is just showing, it's just to show how the way, the characteristics of the products and the way a user uses the product can affect the nicotine delivery to the person who is using the product, as well as influence the exposure of the person to the people to nicotine and toxic substances. These are some of the known toxicants that have been found in these products with known health effects, and they are ultrafine particles are generated from these products, which can go deep into the lungs, causing respiratory issues. So I'm also going to show you a slide in terms of how these products are being used, because we conducted some analysis also at WHO looking at GYTS data, so that's global youth tobacco surveillance data, so which prompted us, and I think I also mentioned that we get loads of requests from member states to help address some of the challenges they face in countries. So in December 2023, we put together this call to action, and it basically rhymes with the theme of this symposium, taking strong and decisive action to address and to control these products. So this this call to action on electronic cigarettes was issued in December, as I said, and we also issued a technical note providing the justification and also the scientific basis for those recommendations in the call to action. So this is a problem statement, and I'm not going to go over everything because Dr. Zatari and Dr. Talhout have gone over some of this in terms of the market growing, the targeting of children, aggressively targeting children even as young as 9 at times. And then we found from the analysis that we did, looking at some countries that have national survey data for adolescents from ages of 13 to 15, that the rate of use among that age group exceeds the rate of use in adults. And you can see it very clear on this column chart that adults that are using this product when you compare to the children that are using this products, that more, when it comes to the rate of use, you have younger children, their rates exceeding adult use in many countries. So the presentation is text heavy for you to be able to refer to the text later, and also so that you can see the recommendations that we put in the call to action as a result of taking a holistic approach to the review of evidence. So we also directed it at different countries, because different countries are at like a different level when it comes to the tobacco epidemic, and also they have policy goals, and also based on their tobacco prevalence, they may wish to take a particular or adopt a particular approach to the regulation of this product. So in recognition of this, we basically provided guidance to all countries, not just to a set of countries. So countries that currently ban these products, we provided a recommendation for them to ensure strong implementation of the ban, but then not to lose sight of the monitoring aspect of things, to also put measures in place to ensure monitoring and surveillance, to have a real-time view of what's happening in terms of who is using the products, even though the products are banned, whether the products are still on the market, and also to prohibit things like advertising and promotion of the products, and also to make sure that strong enforcement mechanisms are put in place. I was in a country and they were like, oh, we banned these products, we don't have to do anything about it. So I was like, okay, if I should then start vaping, can you stop me? They were like, oops, we haven't done anything about that. And I was like, okay, if a manufacturer were to just like put adverts everywhere, can you stop it? They were like, oops, we have to address that as well. So it's always good also, even though countries have banned, to also look at other things that they might be able to do. So, and then some countries choose to permit commercialization of these products. And then we provided recommendations to regulate those products to reduce the harm and the appeal of these products. And we have a whole raft of recommendations ranging from banning flavoring agents, not just flavors, because they get around regulations. So all the agents that can be used to flavor or to impart some kind of flavor to the products, including menthol and synthetic menthol analogs. Also promotional features, prohibiting this in terms of the way the products is presented. Features that also allow users to manipulate the products post-sale as well. We also heard, I think it was Professor Zatari that mentioned this in terms of high nicotine concentration. So we provided this recommendation to limit the concentration and the quantity of nicotine to reduce the risk of dependence, setting maximum volume from electronic cartridges, and also regulating the battery power so that they cannot, it limits the influence of the battery power on toxicant and nicotine delivery. There were also recommendations in terms of prohibiting CMR properties, so those are carcinogenic properties, reprotoxic properties, and also mutagenic properties. We looked at also misleading, and I think it was Laurent that also mentioned that in terms of the way they use misleading. They put all sorts of claims, they use harm reduction, reduced risk, so to also protect the public from those misleading and deceptive claims on safety and efficacy, prohibiting the sale of e-cigarettes to children, specifically reducing access. So if countries permit commercialization of these products in the country so that children don't get access to these products, young people don't get access to these products, and then for countries want to apply tobacco control measures, because in some countries these products are regulated as tobacco products, so some countries may wish to apply tobacco control measures to these products. So we made a recommendation to apply the supply and demand measures, reduction measures of the WHO FCTC. Monitoring and surveillance is also very important, even when countries permit commercialization of the products. Strengthening enforcement, you heard from Sarah's presentation earlier today, and also sharing information regarding the harmful effects of products. And then this is the elephant in the room, and every time people talk about whether these products are cessation products or not. And as I said, we take a holistic approach to the evaluation of evidence. We also recognize that some countries want to push it this way, but then we think that this should be done responsibly if they want to do that, and they should control the conditions, because if these products are being claimed to be therapeutic products that can be used to help smokers, then they should be under controlled conditions where not everyone has access to these products. I think it was Dr. Peruga's presentation in terms of what how to look at harm reduction. So if people want to make this available to smokers, it should be just to smokers, and it should be controlled. And that is only after exhausting other proven cessation strategies, and only after considering the risk of uptake, because we're looking at the entire population, and we're seeing in many countries that young people are using these products. And then there should be also information on not just efficacy, but also safety of these products, because there are millions of these products in the market. Even most of them, they don't know what they contain. People don't know what they're inhaling. So for cessation, for us at WHO, products should demonstrate safety and efficacy. So for all countries that basically have these products available on their market, a comprehensive approach to tobacco control should be adopted. So, and this is really critical. So countries should look at them in the context of wider tobacco control, and then not use that as an excuse not to address the major issues around tobacco control. We heard from Amanda's presentation earlier when it comes to them selling and pushing them in product cigarettes in many countries. So to apply raised taxes, ban taps, health warnings, smoke-free areas, and have mass media campaigns. So in terms of the factors underpinning the call to action, we've spoken about flavors. There are thousands of flavors used in these products. So, and to prevent uptake, this basically should be addressed. Also, we spoke about, I don't know if, was that Ghazi? In terms of some of these products that appeal to the younger generation. And what we found looking at the evidence is that many of these products have increased in size. They contain much more nicotine than the earlier ones, and then they are increasingly cheaper, and young people are able to afford these products, and they are accessible. Also, these products contain toxic compounds. There is high nicotine delivery. Some of them allow the user to increase the nicotine uptake as well. And dual use is a real problem, which is very, very common when it comes to the use of these products. And dual use, I think we heard from Amanda earlier also, is at least as dangerous and more likely more dangerous than just using conventional cigarettes alone. So also the device characteristics, there are some products that are customizable. The battery power can be ramped up, and then that affects the nicotine and the yield of the toxicant delivery as well. So we have different products. The way, I think one of my slides said how the way the person uses the product combined with the characteristics of the products, can affect the delivery or an exposure to higher amounts of toxicants and also nicotine. Labeling is an issue. I already mentioned that. And then there is mislabeling, which is a common issue. And then we have this commercial and vested interest in terms of the tobacco industry influencing studies and also sponsoring studies. So we looked at, there was a review of 105 studies analyzing the composition of liquids and emissions, and 30% of the authors had received funding from ENDS and ENNDS interest, and including those related to tobacco and related industries. Again, we are seeing that when it comes to the regulation of these products, while some countries have taken measures to address these products, 88 countries, for example, have measures covering about 2.3 billion people, but you also have countries that don't have like any minimum age at which these products can be bought. 74 countries also, which constitute about 2 million people, have no regulations whatsoever in place. And we also know that some countries have taken measures, including those that have banned these products. So this is my last slide. And then this was extracted from a statement made by the DG, WHO DG, at the last executive board meeting, where he basically just spoke about harm reduction, and he said history basically is repeating itself, but with a different from the same nicotine, but with a different packaging. And the sad part is industry is saying it's harm reduction, and what has harm reduction got to do with children? So to call it harm reduction and deliberately recruit children and use schools as a battleground is dishonest. So I just thought we should end with that. And thank you very much for your attention.
Thank you very much, Dr. Fayokun, very interesting. And now we have a few minutes left, so I would like to open the floor for any questions you have for the speakers, both people here in person and online, that you can write in the chat as well. There, thank you.
Hi, thank you very much. My name is Sophie Brasnor from the Tobacco Control Research Group at the University of Bath. Hi, Randy. My question is for you, Dr. Zaatari. In my research, I have come across evidence that nicotine promotes metastatic progression with cancer, particularly lung cancer. And the tobacco industry, of course, has long claimed that nicotine does not cause cancer and is just addictive, sort of implying that in otherwise it's harmless. And in the UK, I find it really alarming, particularly that we see public health bodies echoing this message. You know, nicotine does not cause cancer, and therefore implying that other than addiction, it's somewhat harmless. And so in light of what you presented today, especially around the diversification of nicotine, do you think it's time we need to rethink the messaging around nicotine and its harms? Thank you.
Thank you for this question. I think at least to what we know today, that nicotine is not carcinogenic, and it has no role in the carcinogenesis. However, to put the label on it as being harmless is very dangerous. And the reason I say this, because we know that if, let's say, I don't want to take guinea pigs or experimental, if just look at humans, you give them a dose of nicotine, even as medicinal or even as use of tobacco, you could readily witness the increase in the heart rate and the blood pressure. And these cardiovascular effects, you know the consequence of them, especially for those who have a compromised health, examples of which somebody who has diabetes, for example. We know also nicotine and these other products have effect on the blood vessels, and they will accelerate the formation of of plaques and things like this that will lead ultimately on the long-term use, among other chemicals, to the what we call atherosclerosis and heart disease. So I think, yes, I don't know about all these other analogs, whether they have a carcinogenic effect, but at least there is no documentation. IARC has not designated nicotine as carcinogenic. It doesn't label it into these different categories of cancer-causing agents. So that's the information. But I agree with you always. We have to be on the lookout for any new information or new products that are put out by the industry.
Thank you, everyone, for your great presentations. My name is Liza Lebedeva, and I'm a consultant with the Tobacco Control Unit of the Regional Office, WHO. I have two questions to Professor Zaatari and also to Reinske-Talhut. So the first question is, where we've seen that we are dealing with highly inventive industry, and you've showed a table with number of countries that address or not address nicotine forms in their legislation. So my question is there out there a good example of definition which covers all forms of nicotine, and also analogs which countries which are considering including this in the legislation can use as an inspiration? Because you also mentioned some recommendations on what to include in the legislation, but are there already examples which countries can use for inspiration?
At least in our group, we didn't come out with a specific text as to what we should state. And that could be, and the reason for this is because, again, we are putting out recommendations and could be sensitivities that can create problems for individual member states. But that's why I made the reference that we have to be somewhat, as much as we can, inclusive, broad, and try to be futuristic. I mean, the examples was given, for example, the USA, when they put the FDA on the definition of nicotine, and then they left out analogs. So you see, so this where, I mean, the definition there could be useful, but you need to add some terminology to analogs or anything that could be put forward by the industry in the future. And this is where I think we cannot come up and adopt, because this may create some political sensitivities, being a WHO, trying to dictate a particular. But I think the spirit of it is there, and that's why we try to share as much information, what people have used, and each country give them the independence to choose the language. But my advice as a scientist and my scientific group is to make sure that whatever language you use, to make sure it is comprehensive, inclusive, and if I want to leave you with one thing today, shift that paradigm from tobacco to nicotine. Not totally, because still tobacco is in the form of cigarettes, the mostly wide used tobacco product. However, we need to be aware that the industry now is shifting into the direction of nicotine for two reasons. It could be more addictive, more attractive, and also evade legislation. So that's why we have to be on the lookout, and we have to be well prepared for this new era in this campaign against tobacco and nicotine control.
So much for your guidance, and yeah, we never know what comes next, so it's good to be futuristic. And another question for Reinske. So congratulations, and really well done to the Netherlands for its very strong action on tobacco and also nicotine products. So with the ban on nicotine pouches starting next year, yes, total ban. So I wonder and whether you can elaborate a bit on it. Do you foresee any challenges in terms of enforcing the ban, and other plans or mechanisms in place to ensure compliance, and especially, for example, in online retail? Thank you.
Yeah, thank you. Thank you for the compliment. I indeed think that it was an important step forward for the Netherlands. And as I said, I do hope that with the revision of the tobacco product directive, such a step will also be considered. Will there be problems? Yes, I'm sure there will be. But first I want to echo what Dr. Satari just said, that it's very important that countries think forward. For example, all those discussions about synthetic nicotine and nicotine analogs, we wouldn't have to have had them, and it wouldn't have taken up so much capacity if we didn't have these definition issues. So that's one. One could put one's time and efforts to a better purpose, maybe. And regarding what could happen in the Netherlands, yeah, of course, one will need to prove whether there's nicotine present or not. Maybe there will be lawsuits saying, yeah, that it's not in line with harmonization, in line with the European directive to implement such ban on nicotine products. I really don't know. We also have seen that with the flavoring ban, so that one could only use certain allowed flavorings, that there was a lawsuit. So I'm sure that it will happen now, but I'm not a juridical expert. But yeah, I think the government is already ready for that. Yeah.
Okay, I think we have time just for one last question. There.
Hi, I'm Alejandro Frino from IDVAPS here in Barcelona. First, congratulations, it's excellent your speech, each one. A question, at lung level, nicotine could be lessive for the alveolo and perhaps makes the first kick to the fibrosis, lung fibrosis. What do you think about this? And second, I think we are backwards in environmental aspect with the tobacco, because now we have the bats, a little thing in the floor, but now I saw complete cigarettes from the head-not-burn tobacco, which has nicotine, which has tobacco, and has a little metal plate that is inside from the ICO-WHO. And the plastics, batteries, and everything you have in one e-cigarette. And the people is throwing that, and I think is go back and very, very bad for the environmental. Thank you.
Regarding, if I understood the question about pulmonary fibrosis, is this about pulmonary fibrosis, right? We don't have enough data yet to see if there is evidence of pulmonary fibrosis. We have, for example, in the use of e-cigarettes, evidence of what we call pulmonary damage. Particularly in the open systems where the users will add substance of abuse or some vitamins to it in addition that will accelerate, and I'm sure this have led some people to have very severe pulmonary disease and die. These are obviously the exception, but we know that the use of tobacco, of any product, will lead to specific pathology that we recognize in the lung. I'm not going to burden you with this, but I would love to, but I know I'm not talking to a pathology audience, but I can tell you that there are several pathologies that we see in the lung that are typically seen in smokers, and we don't see it in non-smokers. So there is a relationship, there is a link. We know this could be accelerating process of enhancing fibrosis, but I refrain from giving a specific. We have done some experiments in animals, and we have demonstrated that by the use of the e-cigarettes, there is an element of increase of inflammatory response in the tissues of the lung by the use of these products. More so, what's even more important to us is that we took also diabetic mice and compare them to non-diabetic mice. And I hope I'm not burdening you with this. I know I'm getting into more science and medicine now. if we take like a diabetic mouse and compare it to a non-diabetic mouse, the degree of inflammation is more exaggerated in the diabetic mouse. So the question is how this translates into humans. That is, while this may have minimal or no effect on a non-diabetic, would it have an exaggerated effect on a diabetic? So these are questions we don't have the answers, but at least we have to be alert and aware, and that's why we're very keen about not rushing to adopt and embrace these new technologies with the notion of harm reduction. We're very cautious, we're very careful, so your question is appropriate. Now, in regard to your second comment, you're absolutely right. 2 years ago, the theme of No Tobacco Day, World Day, that it was on environment. And there was a lot of data that was published on the waste that is coming out to contaminate the environment by the use of these new products, specifically ENs, because they have this kind of metallic devices, they are thrown, and also they're being thrown on beaches, in city communities, etc. They're complicating the problem of waste management. So your point is very well taken, and as I mentioned, 2 to 3 years ago there was a lot of specific data on the magnitude of this problem worldwide.
Okay, thank you. Well, it's a shame to anybody wants to add something? No? Okay. And, well, it's a shame to finish this discussion, but if anybody wants to ask something to the speakers, I encourage you to do it during the break. And, well, so now we finish this second session, and let me thanks again to the speakers and the audience for the questions. Thank you very much.
Thank you, Monse. Thank you, the speakers. It has been very educative. And now it's time for the lunch. But before that, please, I would like that you be in the front of the room, because we are going to take the picture, the family picture. So please join us here in the front, and that is going to be care of the picture, okay? Afternoon session in 3 or 4 minutes. People is coming from lunch, and hopefully we are going to resume the session again. Wait just a bit, sorry for the delay.
So once I present you, I will pass. Well, actually, when I start presenting you, I will pass. Presenting while people. Hi, everyone. Challenging session just after lunch, but let's move forward because we have our agenda, which is really interesting, but also packed. And the next session we have, it's the third session, which will be moderated by Rachel O'Donnell, Senior Research Fellow at University of Stirling and their colleague on many projects. And I'll pass to you to present our panelists.
I think we're on now. That's great. So I have the pleasure of introducing 3 speakers for this next session. First up, we'll have Angela Ciobanu, who's Technical Officer in Tobacco Control at the WHO Regional Office for Europe. She's got a long-standing history of working in non-communicable disease and communication for behavior change as well. And she's been working for the World Health Organization since 2011. We also have Maria Jose Lopez, who's an associate professor and head of the Evaluation and Intervention Methods Service of the Public Health Agency here in Barcelona. And our third speaker is Michelle Kegler, who's come all the way over from the States, and she is going to be speaking about why smoke-free outdoor settings. She's professor in Department of Behavioral, Social and Health Education Services at Rollins School of Public Health at Emory University, and also director of the Emory Prevention Research Centre. So without further ado, given that we've started ever so slightly late, I'm going to pass over to our first speaker, Angela, to take the floor. Thanks, Angela.
Yeah, thank you very much for introduction. I will speak about the smoke-free environments and the implementation of the Article 8 in the WHO European region, and what are the barriers of the implementation and also enforcement of these measures at the regional level based on the reports and the countries that are reporting what is happening there. And first of all, I think that everyone knows and is well established that there's not a level that is not harmful. Even the exposure of to secondhand smoke, there's no level of that less harmful, but no harmful effect. That is all the biggest agency, the global agency, the International Agency for the Research in Cancer. They also group them that they first group of the carcinogens. There's a reports of their from the US that also mentioned that the exposure is very harmful, and it's killing every year around 1.3 million people. And out of these, 47,000 children under the age of 5. And the second-hand smoke exposure is harmful to the entire life course, starting from the pregnancy to the fetus, children, baby children, older adults, everyone have, its exposure is harm to the health. But most vulnerable, of course, those who cannot avoid it, for example, fetus or children that have to stay with the smoking parents around. Smoke-free policies, first of all, they're effective. They're saving lives. In the majority of countries, there was conducted the survey and evaluated the opinion of the people. There is high support of the smoke-free policies. More than 60 in some countries, even more than 80% of population are supporting smoke-free policies. In other countries are reaching even 90%. And smoking bans have a positive economic impact on the business and tourism and everywhere. And it's a question, why? And the last point is also implementation is very cost effective, comparing with the investments of the cost that invest for the enforcement and what you gain out of the implementation of these policies. And is the question why their policies implemented at so low level? Because in the European region, yes, from the 2008 until 2022, we have increased numbers of the countries who adopted comprehensive smoke-free policies. But in 2022, only 18 countries out of 52 are having a comprehensive smoke-free policy that is banning smoking in all public places, in the workplaces and public transport. What are the barriers that impede the countries to implement, and what also the opportunities to strengthen and to adopt the comprehensive policy? First of all, we discussed in the morning about the lack of political will and the stakeholder involvement. Even that everyone at the policy level and political levels knows that it's effective, it's saving lives, there is no safe exposure to the smoke-free. There is somehow there's level of the political will is quite low in some of the countries to adopt a comprehensive smoke-free policies. And there's in the countries who adopted it, they show how to do it. And especially the opportunities to do is, first of all, to build a national coalition and inform the public, to build the strong arguments, and to inform that really this is effective and this is saving lives. Yeah, to raise the public awareness about the harm of the secondhand smoke and build the public support. And of course, we need for this the data. Monitoring is very important, and to bring and to inform the population. Media have a key role here in spreading the word, and many other activities. Another, we discussed in the morning a lot about the tobacco industries, and every time they mentioned that This is just, involvement of them in the smoke-free regulation. It's quite strong. And based on the experience of my personal experience, but also experience from other countries, even that at the level of the Ministry of Health, they're building and designing strong legislation that cover all the products, that cover comprehensively different all the places, and even some extension. One is coming to the parliament and they're discussing there. There's start to make exceptions, and there is a big battle, and the tobacco industry coming to their open discussion in the parliament with the big orchestra of the supporters and trying to downgrade the legislation. Therefore, there's involvement it's at the big level. Of course, there's also opportunities every time to combat and to, but we need for this a strong public health institutions, specialists, again, coalitions, NGOs involvement, and to build the public support on this. And of course, we have to be very vigilant, and especially when the law is reaching the high level on adoption, to limit and to reduce the interference of the tobacco industry. And NGOs everywhere is very important component of this, because they are helping, and the medical association as well. Limited resources, I think, especially now when we have the many wars in the region, we have different economical impact. There's especially the public health institutions have the limited resources on this, and limited not only the financial but also the human resources who are working on this. In this case, we have to engage also as much as possible population, the specialists, the different level of the research institutions, the coalition is very important in order to help to deal with the limited resources. And also another issues, we can use the taxes raised from the taxes, some resources to have to engage some additional people for this, if it's possible. Many times, and I just came from one of the country from North Macedonia, where they in the law, they have a comprehensive approach to the smoke-free, but the law is not clear, how it's written in the law is not clear, is not understood well. And we have everywhere they are smoking. Therefore, it's even they have a good law, if it's not clear and have many loopholes, it can be challenged by the implementation level. And we have a just high-level policy discussion on Thursday, and they're planning to revise the law and to change it. This is just also an example from the Republic of Moldova that is coming to another point why it's also not well implemented. Here I presented the definition of smoking, and you see in the definition that is covering all the type of the tobacco product, but also the related products. And the related products are also the products that is herbal products for smoking, products containing nicotine, including electronic cigarettes. It's covering all type of the products, and it's quite comprehensive. However, they have a case on the enforcement institution. They try to apply the law, and they put the fine on the agency who just found that they are smoking the shisha. And in the court, they nullify the decision of the applying these fines just because they mentioned that the investigating officer did not prove that hookah was not used with tobacco. And in the law, you saw that this practically is covering also the related product, doesn't matter. It's with tobacco or not tobacco. Therefore, if there is a limited knowledge of the law, and the people or who is applying and who is also reading in the court this law have the limited knowledge, is put the barriers of the implementing this law. As a decision, for example, in the case of Moldova, they try now to stipulate in the law also hookahs as a wording with or without tobacco. They found another way. Even they have quite comprehensive definition. In this case, it's also helping to have the guidance and the information how to implement the law at the low level. Comprehensive public education is also very important, and also awareness and media support. In terms of the enforcement of smoke-free measures, as I also mentioned that having the law on the paper, it doesn't mean that it's enforced. And we have also some examples in the region that on the papers, they're looking very well, but in practice is not enforced at all. And one of these examples is in Turkey. I think that everyone, they try, if you go there recently, they are smoking also everywhere. And also it's because the enforcement institution, there's existing one specialized institution who enforced. There was, this institution doesn't exist, and there was divided responsibility to enforce and to monitor to other institutions that practically don't fulfill their obligation to monitor and to enforce these measures. If there's division between different authorities, it's good to have clear responsibilities put on the paper, that everyone knows who is responsible for what, how is the periodicity, how they'll do, and exchange the information. If that is not happening, it's not enforced at all. Also, NGOs, if it's not well involved, not informing the agencies, they're not the right issues, it's difficult to put it in place. Of course, it's good to have the tool-free telephone compliant hotline or the internet web page. In the Turkey also exists previously, but now is not working properly, and probably we didn't, is not implementing it at all. Trainings, guidance materials, designing lawyer is also important to have. It's good to have, at least if not specialized, but to have a good reference if there are some court cases in order to help the public health or the enforcement agency inspections to implement and help to go to all these court cases. Low level of fines and difficulties in applying penalties. This is another barrier of the implementing. And even some countries have high level of fines, but it's difficult to implement because the procedures of the applying is very complicated. And if it's applied, does not finalize the final case that they are paying all these fines. Therefore, it's good to have a range. First of all, it's good to have a range of penalties that, for example, for the second violation will be higher, and or even higher on the third one, and even can lose the license for selling or for doing some practices. And have to be applied not only on the entities, not only individuals, but on all the entities. And have to be the shorter way of the application, from the application when there's signed or put the fine until there is paid as well. Monitoring evaluation really helped to strengthen and improve smoke-free policies, and also to do the periodical evaluation is helpful to understand what is the problem, where it is, and in order to address it, because otherwise it will be difficult to understand how to redress the situation. And as I mentioned also the comprehensiveness, because even a limited number of countries in our region have a comprehensive smoke-free policy that covers also the novel products. I mean electronic cigarettes, heated tobacco, and so on. I also was recently in one of the country. We went in the restaurant, but even the corridor of the just entrance, they're smoking the heated tobacco products as usual. They mentioned this. By the law, it's not prohibited. We can. And therefore, it's important to have comprehensive, and also in terms of the enforcement, because When it's comprehensive, it's easy to enforce that all the type of the products is prohibited to use in the enclosed public places. Here I just put the slide from the last global report on tobacco, and in the European region we have only, in 2022, only 12 countries that have a full ban on the use of the electronic cigarettes in the indoor public places. Now we hope that will be increase the numbers. And the last, my key messages. This is my one of the last slide. In order to have really good implemented good policy on the smoke-free, the law have to be comprehensive and have to be well enforced. And monitoring implementation, it's important. Thank you.
Thank you, Angela. So I think we've just got time for one or two quick questions before we move on to Maria's presentation. If anybody in the audience here in person or online would like to pose a question for Angela.
Yeah. Yes, it's related with the previous table in the morning about compliance. I don't know if WHO or WHO could ask governments or parties about data like not self-reporting data, but data that really can show how is the situation in the compliance of several policies, including smoke-free policies. Do you have these mechanisms, or is it able to implement these kind of mechanisms at the WHO level or other levels?
Yeah, it's a good question, and we ask ourselves many times how to implement, how to do it in the best way. We have a mechanism, but it's not ideal what we are monitoring, because it's used at the global level, it's not on there. And in order to apply to all the countries, of course, the best way is to have the data from the national surveillance that assess the exposure of the people and reporting, how they're reporting the exposure to the secondhand smoke. But the country that has such kind of the data is very limited. Therefore, in the WHO, we usually use through the reporting system the report from the at least minimum of 3 experts at the country level who are reporting about the compliance. It's not ideal, but it's one of the ways to measure.
Do we have any other questions anyone would like to pose? No?
I had one question. Thank you very much, Angela, for presentation. You gave us a few examples of where enforcement does not work properly on smoke-free legislation in Europe. Would you flag a few countries in the European WHO region which you think are doing good, at least in some parts, particularly in enforcement? We know that sometimes what you said, legislation is one thing and the reality might be other.
Okay, because it's difficult to say, it's better to, okay, I don't have information from the countries, especially when you visit, we at WHO usually monitor at the policy level. We look through the policy. And it's difficult, and as I mentioned that some of the countries, they have comprehensive policy, but it's not implemented in the practice. However, many countries, some of the countries that I visited, even they have in the legislation some of the gaps, for example, designating smoking areas in the legislation, but in practices, they don't. One of the best examples that I will present as one of the standard is the Ireland. And why? And I'll explain why. Because they implemented the comprehensive smoke-free policies for the years, and now is self-enforced. At the moment that I visited the countries, they didn't cover through the smoke-free legislation the novel products, such as electronic cigarettes and so on, but I didn't see a person was smoking electronic cigarettes inside. None of them. And when I asked the enforcement inspectors there, they mentioned that it's automatically because they understood that none of the products have to be used inside. Therefore, if you put a comprehensive for the smoke-free policies well in place, it can be automatic, even the legislation that cover. The people already, they're self-enforced. Thank you.
Okay, thank you. So I'm going to move on now to introduce our next speaker, Dr. Maria Jose Lopez, who will be talking to us about the importance of smoke-free outdoor settings.
Okay, so, well, first of all, thank you very much for the invitation. It's a pleasure to be here with many colleagues and actually also with some friends. So, okay, I'm going to talk about smoke-free outdoor settings, and I usually structure my presentations like with an introduction, some data, some results, and I finish with some conclusions or take-home messages. But today, I'm trying to be original. I'm going to spoiler my 5 take-home messages in the first slide. And after that, I'm going to show you for each message some data or some scientific paper, some scientific evidence supporting this message, right? And let's see how it works. So why are we, from a public health point of view, concerned about smoking in outdoor spaces, and therefore why we really want banning smoking in these spaces? First of all, I have here sometimes things like, okay, in outdoor spaces, usually the levels of secondhand smoke are very low, so these are not a real risk for health. And on one hand, as Angela said, no, it's a carcinogen, and therefore there is no safe level of exposure. But also, these levels in some outdoor spaces, like for instance terraces, might be very high. And I will show you some data in a minute. The second reason is that smoking in outdoor spaces goes against the normalization of smoking. No? We know that, for instance, children that usually see smokers, they have more chances of becoming a smoker when in the adulthood. So therefore, you have here another reason. Third one is that the current partial laws that we have in some outdoor spaces do not work. And I will show you some data. So we really need total ban smoking in these places. Fourth, smoking in outdoor spaces, especially in natural spaces like, let's say, beaches, have a significant environmental impact. And last but not least, smoking in outdoor spaces also contributes to health inequality. So it's not only a question of health, but also a question of equity and social justice. So let's see some evidence supporting these messages. The first one, regarding the levels of exposure in some outdoor spaces, is this paper that comes from the tax project that was actually coordinated by Esteban, who is here. And in this project, we measured the levels of environmental nicotine in terraces of hospitality venues from 11 European countries, and what we saw was that in those terraces, the second-hand smoke exposure was equivalent to the exposure in homes with smokers. Actually, I remember that the median nicotine concentration was 0.85 micrograms per cubic meter. That was exactly the same median nicotine concentrations that we found in homes of smokers. And we know that living with a smoker has important health risks. And actually, in some of the terraces where we have covered and we have more than 2 walls, this concentration was 3 times the concentration that we found in homes with smokers. And maybe someone could say, okay, but it's not the same to living with a smoker for a long time that to go to a terrace for a while, no? To take a beer, well, not a beer, I don't want to promote alcohol, to take a coffee, let's say, or to take a water. But something important is that the terraces are also workplaces, no, for hospitality workers. So this exposure is an occupational exposure, no? And then, for sure, we have to ban smoking in these settings to protect these workers also. So the second message, no, that smoking in outdoor settings goes against the normalization. Well, I just found this paper that was published the last year regarding a tobacco control law that was implemented in Colombia. They were banning smoking in several public places and also regulating tobacco advertising and tobacco promotion. And they saw that the smoking prevalence after the law was reduced in those households that were previously more exposed to the social norm by living close to highly dense commercial areas in the city. So somehow the message is the less visibility of tobacco, the better, no? And this idea can be applied also to outdoor spaces. Third, the current partial laws do not work. I wanted to show you this paper that we published this year, just some months ago. For those of you who are not familiar with the Spanish smoking control law, what our law said regarding the terraces of hospitality venues is that smoking is allowed on hospitality terraces if it is an uncovered space or covered with up to 2 side walls. So in the other terraces, you cannot smoke. So what we did was to study more than 100 hospitality terraces in the city of Barcelona. And from these terraces, 44 of them had a smoking ban. So in how many of them do you think that we saw people smoking? No? Saying in other words, what was the percentage of incompliance? Make a guess. Half? All? You must be from Barcelona. So 100% of uncompliance, no? And actually, that's not something new, because we saw exactly the same 6 years ago in the tax project when we were studying terraces from different countries where they have similar laws. So we know that this type of law do not work. We need a total ban in these settings. Fourth, regarding the environmental impact, I was doing a search in PubMed, and there are lots and lots of papers, but I just choose this one, this review that was published this year in the Science of the Total Environment, that it's a very good journal. And just here you have some of the messages of the paper. Every year, trillions of cigarette butts are discarded into the environment. These butts have high resistance to physical and biological degradation, harmful components, and the list was very long of the harmful components released into water from butts, cause both water pollution and toxic effects on different aquatic organisms. And I think that now that we are all the day talking about One Health, no, and that we know that we cannot take care of people if we don't take care of the planet, that's also an important reason to ban smoking in outdoor spaces. And finally, also smoking in outdoor spaces contributes to health inequalities. And we have data on that, also coming from the tax project. I'm going to show you some data that we recorded in children's playgrounds, also coming from different countries, from 11 countries. And here you have some data. No? We were like systematically recording observational signs of tobacco consumption. No? And you can see that, for instance, we found that in around 20% of the playgrounds, we found people smoking, or we found cigarette butts inside the playgrounds in more than half of them. But look at what happened when we stratified this data, but by the socioeconomic level. So you can see in the purple line data in the least deprived neighborhoods, and in the brown line
data in the most deprived neighborhoods. So you can see that always the situation is worse in the most deprived neighborhoods. So for instance, the cigarette ban come to 49 to 64, or people smoking from 22% to 27. And we saw exactly the same in another setting affecting children, like primary school entrances, when if we look at the people smoking in general, we found people smoking in around 40% of these school entrances. But if we stratified this data, and in this case, the most deprived neighborhoods is the dark blue line, we see that in the least deprived neighborhoods, only 32% of these entrances have people smoking, while in more than half of the most deprived neighborhoods, we found people smoking. So those children who already lived in the most deprived neighborhoods and who already have worse health indicators, they are also more exposed to the secondhand smoke. So, okay, so I think these are 5 important reasons to ban smoking in outdoor spaces and to keep moving towards smoke-free outdoor areas, no? And I think that in those outdoor environments where smoking is already regulated, first thing is that we need total bans, not partial, because as we have seen, they do not work. The second one is that in some places, like for instance, school entrances, I think it would be good to establish some perimeter so it's clear where you can smoke or where you cannot smoke. And we will need more clear signposting. And also that, as Angela was saying, no, that the law is not only a paper, so we need, let's say, either promotion programs or campaigns with an equity perspective so the people know this law and then it's easier, no? And we need to monitor and we need enforcement efforts, no? And then is when the law is really effective. And of course, we need to advance in implementing more smoke-free outdoor areas. We need more regulation, banning smoking in as many outdoor settings as possible. And just to finish saying that I have been talking about smoke-free environments, but of course, I mean smoke and aerosol-free environments, so we do not only have to ban smoking, but also to ban to use e-cigarettes or any other tobacco product. And that's all. Thank you very much for your kind attention.
Thank you, Maria. Just time for a couple of quick questions. If anybody has a question they'd like to pose to Maria. Any questions from the audience here or online? Go on, Angela.
Yeah, thank you very much for interesting presentation. You mentioned there about the monitoring that you did, the evaluation that you did, and the number of, there was 44, as I remember, the units of the outdoor spaces where they prohibited the smoking. But in these areas, there's how many had the sign, that the sign, no smoking sign that is prohibited?
No? Yeah, that's a very good question. For instance, in the case of playgrounds, when we were doing the field work, we have to look for the sign because we couldn't find it. And actually there was kind of a sign like this, and then it was like, you cannot throw things, you cannot enter with the dog, you cannot do whatever. And at the end, like, and you cannot smoke, but you need nearly like some glasses to see that. So really the signposting wasn't good. And in the case of terraces, there were no signs. And in the school entrances, there were no signs because it's not really forbidden. In some of them, because the school wants, they have some type of sign. But I remember very clearly the case of the playgrounds where it is forbidden by the Spanish law. But the signposting was clearly, we have room to improve in this sense. Yeah.
I think Esteba have one question.
Thank you very much, Maria Jose, for the talk and for showing us these results. that I also believe that perhaps have prompted part of the current recommendations of the Commission. But well, it is clear that we have to legislate, and I said at the very beginning that legislation is necessary, but wanted to explain the case you mentioned now, that in playgrounds in Spain is forbidden and it's compulsory to be posted. But we also have even, I don't know, well, it's another place where everybody knows that is forbidden to smoke in the open air, that are the hospitals. All the premises outdoors in the hospitals, all the campuses, but the Spanish law bans the use of tobacco products and also e-cigarettes. It is very well signalized in almost all the hospitals, at least in Catalonia, and is always not complied by attendees, by even health professionals, but people attending the hospital, families of patients, etc. They look to one side, to another side, see that there is no police or security from the hospital or white coat around, and people smoke. You can see here, and in our experience, for example, in Catalonia, the Catalan Network for Smoke-Free Hospital has done big efforts to educate in this sense. And I believe that we also need to make behavioral changes in the population, to make these norms be accomplished. It's just a reflection. I don't know whether you want to, from the experience of the field work in the different places and so on.
Yes, well, no, was more or less one of the lines, no, of the last slide, that it's not only the paper of the law, but we have to do more things, no? Either campaigns or explain it, and also the equity perspective, and try to facilitate, no, that, because I guess that in the entrance of a hospital, people is in a very stressful situation, no? Or in those the private neighborhoods, I mean, people has very complicated lives, so the social determinants, and try to facilitate that the compliance of these laws. It's not easy, but we have to do also this part, no? And yeah, we have to advance on that.
Thank you. I wondered if I could be a bit cheeky as facilitator and just pop in one last question before we move on to Michelle. So I'll make it a quick one. So in Scotland, we have the Tobacco and Vapes Bill, which is just going through the early stages of Parliament. And already what we've seen is that there was a proposal to restrict smoking in outdoor hospitality settings that now has been dropped. And so we still have it at the moment for hospitals. That's likely to be introduced. And I think playgrounds as well. But the proposal to restrict smoking in outdoor hospitality areas has gone, which we've heard is because of...
That would be great,
yeah. So you outlined some really neat, key arguments for why this is important at the start of your presentation, and I wondered, is there one or two in particular that you think are particularly persuasive for politicians?
I think the argument of the occupational exposure is, I mean, it's super clear, no? Yeah. We wouldn't allow in any other workplace to be exposed to a carcinogen, yeah. So you have to use that. I think that's very powerful.
Thank you. Great. Okay, moving on, our last speaker of this session, Professor Michelle Kegler, is going to introduce us to smoke and aerosol-free private places with a focus on homes and vehicles. Thank you, Michelle.
Okay. Hello, everybody. So happy to be here. I'm going to talk about smoke-free private places, which of course is a little bit tricky because they're considered private and a little harder to regulate. So overall, I don't need to spend any time on this. Secondhand smoke exposure has decreased greatly in the United States and across the globe, which is really exciting. However, that means that one of the main remaining places where people are being exposed is in private homes. This is especially detrimental for children who are sort of captive in these environments where they're being exposed to secondhand smoke, and what can we as public health folks do about that? So one approach is to try to assist families in creating smoke-free homes. And so our surveillance systems do monitor smoke-free homes in the US. And when there's no one that smokes in the home, most of the households are smoke-free. So very strong norms around smoke-free homes if no one's smoking in the home. However, if there is someone who smokes, it's about 50% are still smoking in the home and exposing non-smokers in their environment to secondhand smoke. And then there's very significant disparities, which actually parallel cigarette smoking, related to socioeconomic status and racial ethnic groups. So our team, about 15 years ago, decided to try to take this on, beginning with qualitative work, understanding sort of the household dynamics of creating smoke-free homes. We developed an intervention called Smoke-Free Homes. Some things are better outside. We used humor. So you can see there's garbage in the home, there's a dog peeing on the couch in the home, and there's cigarettes in the home. And so instead of sort of bashing smokers about going outside, we tried to have a light-hearted approach. This program has now been recognized by our National Cancer Institute as evidence-based in helping households create smoke-free homes. It's a simple intervention. We designed it with scalability in mind. It's theory-based, takes about 6 weeks to deliver. It's a little old-fashioned, but it has a kit of materials that support us building a smoke-free home, including signage and stickers and a window cling, and then 5 steps to create a smoke-free home, 3 mailings and a coaching call. Coaching call is based on the trans-theoretical model stage of change, takes about 15-20 minutes, guides households through creating a smoke-free home, problem solves, asks what are the challenges of doing so, and then tries to come up with solutions, and then create an action plan for that family based on the challenges that they're facing. We wanted it to be easy to deliver in a range of settings, taking a public health argument that even if it wasn't as effective as a more intensive intervention, if it has greater reach, it would have a stronger public health impact. We were lucky to have a very large grant from our National Cancer Institute, and we're able to do 3 randomized controlled trials with 1 grant. And so we were able to do one where I live in the state of Georgia, one in North Carolina, and one with Texas, with increasingly diverse populations involved. And in each case, we showed that the intervention was effective with about a 15-20% absolute difference between intervention and control in households creating a smoke-free home. Participants interacted with the program well. What we were most excited about was it stimulated conversations in the household about the need to smoke outside instead of smoking inside. And about half were posting the signs, signing the pledges, posting the pledges, using the stickers, and then calling the National Quit line was something that we just mentioned, and about 20% were doing that. So because it's considered evidence-based, we're now in the process of adapting it for different communities and different countries. And so we're working with tribal communities or indigenous communities in the US, which still have a very high smoking rate in some nations. We're adapting it for Armenia and the Republic of Georgia. Dynamics are different there because over half of men are still smoking. And so we're getting into a little kind of gender-based decision-making a little more than in the US. Our colleagues here, and the reason I'm invited is because our colleagues here are adapting it for Spain. And then recently we have a colleague in Brazil that's going through the adaptation process. And there is a formal way to culturally adapt interventions, which most of the teams are following as they adapt the intervention. So just a quick minute on how we're adapting it for tribal communities. We did focus groups, and most of the teams that are adapting it are doing qualitative formative research to understand a little bit more about smoking in the home in their particular context, and then making the obvious changes to the materials, which is usually the imagery. Our typical house in the US doesn't really reflect the rest of the world. And even in tribal communities, they didn't like our humor which makes me nervous because I don't know if it'll work without the humor. But anyway, so we went from funny, some things are better outside, to respect our past, protect our future. That's the theme we're using with our native communities, and you can see the imagery changed quite a bit. We're funded to work with some specific tribal communities now, partnering with Great Plains Tribal Leaders Health Board and Intertribal Council of Michigan. So we initially tried to make it sort of generic Native American, but then when we started working with specific nations, they needed to tailor it a little bit more. So we went through the process again and are tailoring it for specific tribal communities. We also have a project now. We're in probably our 7th or 8th year of research collaboration in Armenia and Georgia, and we're working with the CDC in Georgia and the NIH and the CDC in Armenia, and we're adapting it using the same general process in those countries. In that case, though, the national quit lines are going to be the ones delivering the intervention, which has more potential for scalability. And here you can see just some of the preliminary work in adapting it for their communities. One of the challenges we faced is we're getting pretty good at getting research dollars to test the intervention, but in order to have a public health impact, you have to have it integrated into a system of some sort, and that's where we've gotten a little bit stuck. Again, we have a research project here where we braided it with a parenting program for households that are, the families are involved with child protective services, so child maltreatment, just kind of bad family dynamics where they get involved with the court system. And we are integrating our Smoke-Free Homes program into a parenting program there. We braided them and we're implementing it in that setting, which has potential for dissemination. Our approach, though, is household by household by household, which is quite slow. So I thought I should just mention that national smoke-free legislation also seems to increase smoke-free homes or decrease smoking in the home. There's like a spillover effect. So that's another approach. And then there have been a few studies that have shown just community education is effective in increasing the rates of smoke-free homes. We did that recently in a community randomized trial where we formed multi-sectoral community coalitions that did community education around secondhand smoke exposure in Armenia and Georgia. Our public health sector, though, in our CDC is not so much focused on household by household program-specific things, but trying to do more policy-related work in this space. And so far, California is doing a good job of this. The rest of the country, not so much. All of the legislation related to smoke-free multi-unit housing is in California. So 85 municipalities have successfully passed city or county ordinances banning smoking in private units of apartment buildings, basically, whether it's rental or owned. So that's exciting, but it really takes a political will to go there. Another big success that we've had in the US is our federal agency, Department of Housing and Urban Development, mandated that all conventional public housing be smoke-free. This was around 2017, implemented in 2018, and this was a really big deal. So this was, again, a policy that promoted smoke-free homes. It did, and the public health folks weren't too happy about that, but it did exclude vaping and e-cigarettes to get it through. There is a lot of work encouraging voluntary smoke-free multi-unit housing. We're running this for the state of Georgia, where we're trying to work with organizations and companies that own apartment buildings and have them create smoke-free policies at the building or the property level. And so we're doing a recognition program so that those that have completely smoke-free properties, including outdoors, get a gold designation, and then we put them on this interactive map, so if people want smoke-free housing, they can find it. We're also doing a marketing campaign related to that. And then, as has been talked about with the previous speakers, compliance and enforcement is an issue with all of these efforts to create smoke-free policies. And so different public health groups across the country are trying to provide support for cessation and enforcement of these policies at the property level, and we're doing that as well. Some of you might have noticed that our Surgeon General just came out with a new report about 2 weeks ago. This was on health disparities related to tobacco, and I just pulled a quote related to the smoke-free homes section. And so they said, future efforts should employ a three-pronged approach, including the voluntary adoption of rules for a smoke-free home at the household level, smoke-free policies in multi-unit housing, and then comprehensive smoke-free legislation. So that's kind of what our government is saying are the three ways to promote smoke-free housing at present. I was asked to talk a little bit about smoke-free vehicles, and there is some international momentum in banning smoking in private vehicles when a child is present. I'm wondering if we could use that same, I don't know the politics behind creating political will for that, but if it's protecting children, which it must be, because it's specific to children, I wonder if we could harness that for smoke-free homes in some way. Not sure about that. And it's a little bit slower. Well, I guess it's kind of slow globally, but there's 12 states in the US that have passed similar legislation at the state level. There is also some evidence of a spillover effect where when smoke-free homes are created, some folks actually then also make their vehicles smoke-free as well. So some of the smoke-free homes interventions might assist with this. And we're testing an explicit smoke-free homes vehicle education campaign right now to see if that helps with any of this. And I just want to close with a few sort of reflection and discussion points. I won't take the time to go through all of this, but in terms of the program that we've generated, I think it really, in order to have a public health impact, we need systems to implement it. Because sometimes it's hard to find families that admit to still smoking in the home. And it's pockets of populations, at least in our country, where people are still smoking in the home. So you need to have an end to certain population groups in order to do that. And then there is public health energy around smoke-free multi-unit housing. And then I think an area that's interesting to think about is how to handle vaping and aerosol and e-cigarettes in the private setting. Should the messaging just be no tobacco use in the home at all, ever, or should we start with combustible products, get those out of the home, and then add e-cigarettes? I think is worth debating. So that's all I wanted to cover.
Thank you, Michelle.
Oh, I wanted to acknowledge most of our funding was from the National Cancer Institute, and then I have a really fantastic core team.
Thanks a lot. So we've got a good couple of minutes if anybody has a question that they would like to ask.
Excellent. That was really, really interesting. Thank you. So really interested in all of your intervention work, really interested in all of your education work and information work. And I guess I'd like to just ask you a little bit more about legislation, oddly enough. And so I wondered about enforcement of that legislation. And is that essential, or is legislation in and of itself almost enough in altering norms, social norms around SHS exposure in the home?
Legislation in this area seems like a really big deal. So I don't think we want to get hung up in thinking, oh, there's so many enforcement and compliance challenges, let's not do it. I think when the planning for implementation is done well, and we've done some qualitative work on enforcement and compliance and setting up policies and implementing policies in a way that they roll out effectively, I think when done well and supported by the public health community, we can see higher compliance, and then we can make the enforcement compassionate. It is harder, and we've struggled with that too, because when you pass a policy in housing, it ends in eviction if people don't obey the policy. And of course, as public health people, we understand that housing is a critically important public health need. And so we're trying to experiment with sort of, making the enforcement process other than just, referring, because now people get referred to cessation, but then they don't quit. And, it's just, it's hard. But I think if you build in a careful enforcement process, and we're going to try sticking our program into that enforcement process where people have to get referred, to a smoke-free homes program where they get more intensive support. But I say, let's not give up on policy.
Any other questions? I think we...
A quick one. Thank you, everyone, for very interesting presentations. Michelle, one for you. It's great to see that smoke-free homes, this project initiative, gathers interest also outside the US. So, and the question is related to this. So, how do you ensure that adaptation of the materials to local context maintain core effectiveness of the intervention? So, thank you.
Yeah, and I'm kind of struggling personally with how much, how carefully we should be involved and make sure that that's done, or whether we just put our program out there and people do with it what they will. We're kind of at a sweet spot now where we have an agreement that we sign with whoever's going to adapt it, and the agreement includes the core elements of it. And then we offer, for the most part, we're offering training on the coaching. If it catches on further than that, we are, thinking about automating and posting training for how to do the coaching and make it a little more scalable. But as of now, you have to contact us for the materials, which allows us to gain, to ensure that it's done well. But I don't know about doing that for a long time. And I don't know if it'll ever, really catch on. Right now it's small enough that we get to know the teams that are doing it.
Okay, so I think we have one online question too.
We have a question from Raquel Fernandez. She's asking, have you in the US addressed the problem of secondhand smoke on homes when the smoke comes from other homes, especially in multi-housing buildings? And she says we have a huge problem in Spain.
Yeah, so that's where most of the public health people are working, where they try to they try to get the property owner to adopt a policy that makes the entire building smoke-free. And that's been somewhat successful. It is, Sean asked me this about disparities earlier. New multi-unit housing is largely smoke-free because people don't want the damage and the stink and the turnover costs related to smoking in particular units. Renovated housing is tending to be smoke-free, but it's the older housing that's cheaper where people are still allowed to smoke, and then that's where lower income people work and where the disparities are getting exacerbated, I would say. So it's a challenge in lower income places, but yeah, I mean, all the state health departments get complaints about neighbors breathing secondhand smoke coming from the unit next to them, which is an argument for a policy to create the whole building to be smoke-free. In other countries, I've learned, like in Armenia and Georgia, it's hard to identify who owns the building because people own I don't know how it is in Spain, but people own their flats. And so it's not clear who has the authority to create a policy for that building or that property. So maybe others have figured that out, but just as that kind of an outsider to this system, I know that we have similar condominiums where people own their units, and then there's like a homeowners association, and they can decide to make the entire building smoke-free.
Great, thank you. So that brings us to the end of our third session. Just like to close by giving another round of applause of thanks to our speakers. Thank you.
So we move to the fourth session today about quitting tobacco and nicotine products. As you've seen, we pick up different topics on tobacco control during the symposium today. We usually have it like monographic one topic, but this year we wanted to make it covering different areas of tobacco control. And the next session is about cessation, and it will be moderated by Elisaveta Lebedev from the Tobacco Control Unit at the European Regional Office for WHO.
Thank you so much, Alona, and thank you everyone for staying with us for this session. So it will focus on another essential component of the comprehensive tobacco control on helping tobacco users quit. So we know that 60% globally, over 60% of the world's 1.25 billion tobacco users want to quit, with many of them saying that they regret they have even started doing this. Yet two-thirds of these people lack access to effective cessation due to various reasons, including health system challenges such as resource constraints. So in our region, in the European region, we have 179 million tobacco users, and only 11 countries out of 53 currently provide best practice level support for treatment of tobacco dependence. So it is clear that more should be done, more must be done to support communities and governments to provide this essential support to people wanting to overcome this addiction. So in this in mind, we will be focusing on two key topics in this session. First is the latest technical guidance on tobacco cessation, and the second topic is how implementation science can improve the coverage, reach, and quality of cessation programs. And we have excellent panel of experts with us, and as before, we will do the presentations first and then have a Q&A session. So our first speaker is Dr. Don Bafu, a medical officer for tobacco cessation in WHO No Tobacco Unit. And Dr. Fu has over 15 years of international and in-country experience in tobacco cessation and treatment of tobacco dependence. And he leads WHO's technical work in this area, and also notably he coordinated the development of the newly published WHO clinical treatment guideline, which will be the focus of his presentation. So Donbo, the floor is yours.
Great. Thank you, Lisa, for your nice. Okay, good afternoon, everyone. So it's my pleasure to be invited to attend this symposium. Just want to say I'm really happy to come back because I think a couple years ago I attended this symposium, and it's very nice to be back again. I was asked to give a presentation on WHO clinical treatment guideline for tobacco cessation in adults. In other words, I'd like to share with you what are WHO recommended tobacco cessation interventions for adult tobacco users. So my presentation will cover three major things. First, we'll introduce what are the WHO standard guideline development process and methods, which really can help to understand why this is a little bit different or have unique components. And then second, what's the objective of this guideline. Lastly, mainly focus on, give you a summary of the guideline recommendations. So on the 2nd of July this year, WHO released its first ever clinical treatment guideline for tobacco cessation in adults. You probably never, many people never believe this is just the first one because we heard lots of work done by WHO, but until this year, we were able to have the first clinical treatment guideline. The guideline was developed following WHO standard process and methods as described in WHO Handbook for Guideline Development. And our department is a health promotion department, oversaw the guideline development process, and together with a dedicated WHO steering group and methodologist, and also a guideline development group. So I would also like to take this opportunity to thank WHO experts and also external experts who made a great contribution to this guideline development. For example, Angela from Euro served as a member of the WHO steering group, and Corel and her team helped us as a systematic review team. So thank you very much for helping WHO to accomplish this great guideline. And of course, as a WHO guideline, the whole guideline development process was closely monitored by WHO guideline review committees. The committee is really to make sure the WHO regulations, standards, and values are applied into the guideline. So that's the process. Then the objective of this guideline is really to provide a comprehensive set of global technical guidance for WHO member states to provide support to 1.25 billion adult tobacco users to quit by using evidence-based behavior interventions and also pharmacological treatments as a comprehensive tobacco control approach at the country level. So the guideline contains totally 12 recommendations for 7 categories of interventions, which are behavior support delivered in clinical and community settings, digital tobacco cessation interventions, pharmacological interventions, interventions for smokeless tobacco use cessation, combination of behavior and pharmacological treatments, traditional, complementary, and alternative therapies. And the last one is a system-level interventions and policies. So I'm going to go over the recommendation for each of the 7 categories. Let's start with the first category. Here, have to make sure the behavior support is defined as a support other than medications aimed at helping people stop their tobacco use by improving their knowledge, skills, and strategies. So in our guideline, the behavior support includes behavior brief intervention and also intensive behavior support, which consists of, we see here is more like the features, multiple sessions of individual, group, or telephone counseling. That's the behavior support which we mean. And there are 2 recommendations you can find in this guideline for this category. First, the WHO recommends brief advice, covering like between 30 seconds and 3 minutes per encounter, be consistently provided by all healthcare professionals as a routine practice to all tobacco users. Doesn't matter the person is ready to quit or not, is interested in quit or not. We need to provide this advice to all of them, accessing any healthcare settings. So this is a strong recommendation based on the moderate certainty of evidence. The second recommendation is WHO recommends more intensive behavior support be offered to all tobacco users who are interested in quitting. So here's the difference. The intensive behavior support is offered to those who are interested in quitting. The options for behavior support can be individual face-to-face counseling, or group face-to-face counseling, or telephone counseling. And we emphasize multiple behavior support options should be provided. So this is also a strong recommendation based on the high certainty of evidence for individual counseling and the moderate certainty of evidence for group counseling and telephone counseling. For the second category, in terms of digital tobacco cessation interventions, here also need to emphasize, here the digital tobacco cessation intervention is defined as the interventions provided through digital technologies can involve the following 4 modalities, which are text messaging, internet-based interventions, smartphone applications, and artificial intelligence-based software interventions. So the recommendation which we made is really focused on these 4 modalities. So WHO recommends digital tobacco cessation modalities, which we just mentioned, the 4 modalities, individually or combined, can be made available for tobacco users interested in quitting either as an adjunct to other proven tobacco cessation support or as a self-management tool. So this is a conditional recommendation, mainly because the certainty of evidence for some are still low or very low. So it's based on the moderate certainty of evidence only for text messaging. And then for the other three modalities, we have low or very low certainty of evidence. Okay, for pharmaco interventions, we also have two recommendations. First, the WHO recommends varenicline, nicotine replacement therapy, we call NRT, bupropion, and cytosine as pharmacological treatment options for tobacco users who smoke and are interested in quitting. Among them, varenicline, NRT, and bupropion are recommended as a first-line options. For those tobacco users who are interested in using NRT to quit, WHO recommend them to use combination NRT over the NRT monotherapy. So this is a strong recommendation based on the high certainty or moderate certainty of evidence. The second recommendation is on the combination of different medication. WHO recommends bupropion in combination with NRT or varenicline should be offered to tobacco users interested in quitting when there's inadequate response to the first-line options, which we just mentioned. This is also a conditional recommendation based on the moderate certainty or low certainty of evidence. For the smokeless tobacco use cessation, we also have two recommendations. The first one, WHO recommends the previously mentioned intensive behavior support, which include individual face-to-face counseling, group face-to-face counseling, or telephone counseling, should be provided for smokeless tobacco users who are interested in quitting as well. This is a strong recommendation based on the moderate certainty of evidence. WHO recommends varenicline or NRT to be used as pharmacological option for smokeless tobacco users who are interested in quitting. This is also a strong recommendation based on moderate certainty of evidence or low certainty of evidence. In terms of combination of behavior and pharmacological treatments, WHO recommends we should combine pharmacotherapy and behavior intervention to support tobacco's interest in quitting. So this is a strong recommendation based on high certainty of evidence. In other words, if we really concern the success of quitting, this is a recommendation we need to implement. For the traditional, complementary, and the alternative therapies for tobacco cessation, no recommendation has been made by the guideline development group. They provided a statement. The statement is evidence is insufficient to make a recommendation for or against traditional, complementary, and alternative therapies for tobacco cessation. If these therapies are utilized by tobacco users interested in quitting, we suggest we need to ensure they are offered as a comprehensive approach to support tobacco cessation. In other words, they shouldn't be offered standalone as a standalone intervention for tobacco cessation. They should be offered together with other proven behavior support or pharmacotherapy. That is a statement for traditional, complementary, and alternative therapies. And the last category is the system-level interventions and policies. These are really for policymakers and service managers for them to promote proven tobacco cessation interventions. WHO made 3 recommendations for this category. First, WHO recommends all healthcare facilities should include tobacco use status and the use of tobacco cessation intervention in their medical records, including electronic health records, to facilitate the provider interaction with tobacco using patients and to increase adoption and maintenance of evidence-based tobacco cessation interventions. This is a strong recommendation based on the moderate certainty of evidence. Second recommendation WHO made is we should train all healthcare providers on delivery of evidence-based cessation interventions, together with ongoing prompting and feedback in their routine medical practices at all levels healthcare setting. This is also a strong recommendation based on moderate certainty of evidence. The final recommendation, WHO recommends that evidence-based tobacco cessation interventions be provided at no or reduced cost to all tobacco users interested in quitting. No cost is strongly preferred over reduced cost. So this is also a strong recommendation based on the moderate certainty of evidence. So I want to stop here and looking forward to any question about our recommended cessation intervention. We also took a few hard copies of this guideline. So if you are interested, feel free to pick one. Thank you so much.
Thank you so much, Donbo, for outlining the recommendations. And colleagues, it's vital that we continue to encourage providers and policymakers and stakeholders to adopt, adapt, and implement these recommendations. So our next speaker is Cristina Martinez, whom many of you know well. So Christine is a senior researcher, expert in tobacco control. She is also acting head of the tobacco control unit here at ICO and assistant professor at the University of Barcelona. And Cristina, her work focuses on evaluating tobacco control policies in healthcare services with a particular emphasis on smoking cessation. So Cristina will be talking today about implementation science in the context of tobacco cessation. So please.
So thank you very much, Lisa, and thank you very much, Domo, because you have introduced the WHO guidelines in smoking cessation. I want a copy. One copy is for me, okay? So you bring the topic of the guideline, and this serves me as a foundation to talk about the topic I want to explain today, that is how implementation science serves and helps to transfer smoking cessation into practice. This is where implementation really excels. It provides a structured, evidence-based framework to close the persistent gap between what we know and what we do. What implementation science provides is a focus on how to improve the implementation, but it can be applied not only in smoking cessation, it can be applied to other applications through the tobacco control. But today my focus is going to be in the role of enhancing smoking cessation services within healthcare services. Over the few minutes, I will walk through the core principles of implementation science, trying to illustrate how to empower and transform the ideas into lasting, impactful change. So this is more or less the questions that I'm going to address. I'm going to try to answer the questions of what is implementation science, what is implementation science and how can it improve smoking cessation services. I will also highlight key strategies in primary care and hospitals, and also how strategies can expand and sustain these efforts in the time. So after my summary and the main remarks, we will open the floor for your questions, comments, and hopefully for your insights in your experience implementing implementation science in the field, or probably no. So let's start. So efficacy studies and effectiveness studies evaluate what it works, while systematic reviews and meta-analysis summarize the evidence and tell us what interventions are more recommended. These findings are all synthesized in guidelines like this one that we have today here, the WHO released it the day of my birthday, by the way. Okay, this is something significant. So this guideline will help us to move and transfer what we know into the practice. But currently, we know that according to the guidelines, what we know, and already Dombo has mentioned, is that behavioral therapy, pharmacological support, and also follow-up to prevent relapse has a strong evidence. This kind of combined intervention can be delivered using the 5 A's models. Of course, we know that this is the reality, and even the WHO has recommended not only the guidelines, but also that all health professionals incorporate these guidelines into practice. Like this, we will introduce one of the policies included in Empower, that is offer. However, the reality is quite different and clearly different from what expected, because as you can see in this slide, according to a review conducted among primary care physicians in 17 countries, we found that the average implementation of the 5 A's is less than optimum. In the case of receiving access, 36% of patients received access, and only 22 were arranged a follow-up. This is the case for primary care. In the case of hospitals, in a study that we conducted here in Barcelona years ago, we asked patients about the level of receipt of smoking cessation during their hospitalization. And we saw that 60% of hospitalized patients who were smokers were asked about their smoking consumption, and only 5% received the 5 A components of the 5 A model. So this is, as I have mentioned, far from optimal. So the barriers of implementation of smoking cessation in healthcare services have been studied, and one of the main is the lack of training of health professionals. 75% of health professionals, when they finish their degree, either nursing, pharmacy, medicine, and so on, 75% say that they have not received any kind of smoking cessation training during their degree. This is one of the main constraints, but we have other constraints, like, for instance, the lack of time. Health professionals, they don't have time to provide smoking cessation during their consultations, the lack of protocols during their, in the organizations that they are working, and also the exclusion of these activities or roles in their portfolio service. So in order to reduce the gap between what we know and what we do, implementation science is a kind of solution, not only for smoking cessation, but for other kind of evidence-based practices. We know that there is a gap between 17 years gaps between research and application, and only 14% of original research has been translated to patient benefit. So implementation science, which studies the methods to promote the adoption, the implementation, and the sustainability of evidence-based practice, could help in the process of transferring knowledge to practice. The foundation of implementation science is that it continues the pipeline of research that starts in the discovering of the science, in the preclinical studies, but continues to other phases that reach also the patient and the community. Here at T3 and T4 is when really implementation science makes sense, and because are the tougher part of the transferring knowledge to practice. This science, it originated years ago in the 80s and 90s and was formalized by the combination of different interdisciplinary fields, including public health, health service research, and behavioral science. And it combines different knowledge and methodologies to improve the uptake of practices in the real world. In order to explain implementation science, it is necessary to explain some of their concepts that are quite distinct from the other sciences. So here we have several concepts. We are going to start with the intervention, that can be called also the thing according to Geoffrey Curran. And here the thing is our guidelines, the WHO guidelines, that contains not only the 5 A's model, but also the behavioral approach and the pharmacological approach. So this is the intervention, the thing that we want to implement. Then we have the determinants that act as barriers and facilitators to successfully implement, and often are categorized across different levels, individual or contextual. Next, we can focus on the strategies, implementation strategies that are the how. These are the tools and processes we use to integrate the intervention to real-world settings, tailored to address specific barriers and contexts. And then we have implementation outcomes, like adoption, fidelity, and acceptability. These outcomes are different from health outcomes, and these outcomes belong about the results that the implementation strategies have provoked after their implementation or after their application. So we were saying that implementation strategies are the how. These are the tools and processes that are not chosen randomly. They are chosen carefully selected based on the needs and the barriers identified in each context. During the assessment phase, we discover what are the main barriers and facilitators that can be unique to each context and each group of individuals. And like this, we are able to set from a variety of strategies which one fits better to our project. We were saying that there are several implementation strategies. In fact, according to the study ERIC, they have been identified over 73 different implementation strategies that have been categorized in 9 domains. We have here several of them, including, for instance, training. That is one of the most used in the literature. But not only, we have also evaluation and iterative strategies that include audits or monitoring tools. We have also adaptation and tailored context strategies, also support to clinicians, like creating grow floors and resources to remember the fact that they need to do this kind of intervention. Or we have also even financial strategies. These implementation strategies produce outcomes that, as I have mentioned before, are different from health outcomes and provide the information about how successful the implementation strategies have been. These implementation outcomes have been classified in also 9 different categories. According to Proto framework, we have acceptability, adoption, appropriateness, feasibility, fidelity, penetration, sustainability, and cost. As you can see here in this slide, acceptability and adoption belong better to the initial part of a project when you are measuring the initial use. Fidelity, it belongs better to the center part of the intervention when the implementation of something has been taking place, and we want to know how well has been delivered according to the intended. And other outcomes that are in the last part of the ladder, like sustainability, cost, focus more on the long-term delivery. But in addition to these concepts, we need to also to highlight that in implementation science there are several models, theories, and frameworks. Indeed, they have been identified over 140 models in the literature. Not all belong to implementation science. They belong to several sciences, like behavioral sciences, like health policy science, and so on. But Nielsen categorized them in 5 different categories. Those that are important for process models that guide the implementation process, determinant frameworks that identify the factors influencing implementation, classical theories that explore behaviors and phenomena, implementation theories to provide implementation-specific explanations, and evaluation frameworks that help us to evaluate the outcomes and its impact. So how can we use, now that we have defined the concepts and theories, or more or less say that there are theories and models and frameworks, how can we use implementation science for improving smoking cessation? Well, I have said before that implementation science offers a structured approach to bridge the evidence-based gap, and it can be used for identifying first barriers and facilitators, also to analyze contextual, individual, or organizational factors that hinder the adoption. In addition, it can be used for adapting existing programs that have been tested in previous studies to our reality in a more effectiveness layout. It can also be used to design and tailor strategies according to the context, and also to measure implementation outcomes that I have defined before. So let's start with the first part, that is, I'm going to condense the 2 first purposes in just one comment. So How can we use implementation science for identifying barriers and analyzing the context? There are many models in the literature that can help us, but I'm going to highlight the two that have been highly used. The Consolidated Framework for Implementation Research, also called CIFR, and the Theoretical Domains Framework, TDF. These two models have been used to identify barriers and facilitators, not only in smoking cessation, but they can help us to understand better some of the elements that include, that describe the situation of the intervention, how the intervention is, how the outer setting is, how the inner setting is, and what are the characteristics of the individuals in the case of the consolidated framework. Also, it helps us to understand the process of planning and executing. We have also another model that is the TDF that focuses more at the behavioral change level. It contains 14 domains and includes knowledge, skills, social and professional role, environmental context, and others. This one has been mainly used for addressing behavioral barriers in healthcare providers and patients. Both of them help us to identify the determinants of successful implementation and inform us how to tailor strategies to overcome the barriers and leveraging the facilitators. In the literature, we can find some papers, some literature that have used these models before, not many, so we still need more research that can use this approach, theory-oriented, analysis-driven research approach, in order to understand better the context and then select the better strategies according to the situation. This is important because bear in mind that every group of individuals are different and every context is different. Another way that we can use implementation science in smoking cessation or in trying to improve the level of implementation of smoking cessation is by adapting existing programs to our reality. Adapting a smoking cessation intervention ensures that something that has been tested before and has demonstrated that its efficacy can be transferred to another context, saving time and money. We have different adaptation models in the literature. For instance, we have FRAME, DAP, IAM-ADAPT. And for instance, this is the case of one of the projects that we are using IAM-ADAPT for adapting this smoke-free homes project that Emory has developed in our context. This is not an example of a smoking cessation, but it's an example of how to adapt an intervention that has been proven efficacy in other contexts, even in a trial, and then transfer it in an effectiveness way in a different context. We also can design and tailor strategies and measuring implementation outcomes by using implementation science. In fact, there are two reviews in the literature that review what strategies are more successful in order to implement a smoking cessation. The first one is in primary care, and the second one is in hospitals. The first one, it was released in 2023, and it says that financial strategies, changing the infrastructure and recording systems, improve the training, and engage consumers, increase the adoption of a smoking status, recording the smoking status of patients, and also increasing the level of advice that health providers provide to smokers. This means that the two A's are more implemented after undertaking these two strategies. In the case of hospitals, another review released in 2022 says that strategies that are predominantly focused on the staff, on training staff, and 7 implementation strategies groups, like, strategies predominantly focused on staff training. This is what normally is done in the literature. But they have classified even up to 7 implementation strategy groups that go from brief external-led training to internal-led system changes that is more intense. So they have seen that they have, there is limited adoption and sustainability when we have brief external-led training versus when we have internal-led system changes that increase the feasibility and the penetration. These internal-led system changes include stakeholder engagement. That means that they select a champion. They have frontline staff trained and also with the responsibility of implementing interventions. They create monitoring and reinforcement activities like auditing and reporting data about how they are doing with the intervention. Planning and organization systems, electronic streamlined workflows, and also, of course, training that doesn't go is isolated. It goes in combination with the other strategies. This can be said that it's a system-level approach at the organizational level that assures the assessment, treatment, and referral of the patient who is a smoker at the hospital care. So we can say that the implementation strategies that are efficacy at the healthcare services are training, of course, but also planning and organizing, changing the system design or changing the system of care, and also giving monitoring and feedback. By using these strategies, we increase the adoption, we enhance the acceptability of both the staff and the patients, but it is true that without resources and with a high workload, we threaten the feasibility. Also, it's important that these strategies are not one-day effort. Instead of one-day effort, what is recommended is a long-term support of structures that improve the sustainability and the penetration. That means to create a system-level approach. This system-level approach is what the latest guidelines of WHO has included. In fact, is what Dombo has already included before in his presentation. And this is something that really highlights the importance of how to embed this smoking cessation at the organizational levels. From the best of my knowledge, the two international projects that include these health system level interventions are the Ottawa model and the Global Network for Tobacco-Free Health Care Services. One has been mainly used in primary care, but also in hospitals, and it was created in the 90s in Canada and has been spread international. The other, it started with an European project, but now it has become more international. It stands in 8 different standards, and also it has a kind of movement, global movement, in which different organizations give the support between one and the others. We have said that implementing strategies, we can see after implementing strategies what are the implementation outcomes, but in these projects, not only they have implemented the implementation outcomes, they have implemented, in the case of the Ottawa model, the implementation the results outcomes. The results outcomes in terms of health of the patients. We can see in this figure how comparing hospitals that have implemented fully the intervention, the smoking cessation intervention, embedded in the of the hospital, they have reduced the level of mortality for all the causes of the patients and also the readmission of the hospital rates. But of course, these kind of policies at the hospital level cannot be alone. They need to be supported by the national and regional health policy, asking hospitals and health systems for accreditations, standards about professional standards, even provide hospitals like some kind of regulations, and also provide them like the possibility of training materials, campaigns, or even the reimbursement of some smoking cessation help, or even free of cost, why not? Okay? So, in conclusion, we can say that implementation science bridges the gap between what we know and what we do by identifying the barriers and facilitators, by tailoring adapting solutions, by implementing strategies that really are fit to the determinants that we have selected, by improving the implementation outcomes, and in the long run, the ultimate goal, the ultimate result is going to be promote the better health and outcomes. Of course, implementation science is not magic, but it produces wonderful results, And I think that is something that it can improve smoking cessation services in our context. Thank you very much for your attention.
Thank you so much, Christina, for these valuable insights of how implementation science can transform tobacco cessation efforts, how to bridge this gap between evidence and practice, address barriers, and tailor strategies. So, colleagues, we have around 8 minutes if we want to be on schedule. I invite your comments, questions, or reflections for our speakers. Yes, Esteve. Thank you.
Thank you very much for both of you. Thank you, Dongbo and Christina. Very nice talks, very illustrative. I have, I don't know whether it's a crazy question for Dongbo. Do you know which was the reaction of governments, scientific societies, and some sectors implicated in smoking and theoretically implicated in smoking cessation, such as vaping associations and so on? Because one of the first things I did when the report was released was to do Control F in the PDF, searching for electronic cigarettes. And well, it was not a surprise, but there was no term in the retrieve from the search. So reactions from these three kind of bodies, if available, or your impressions?
Okay, great, thank you. I think according to my limited understanding about reaction, for the governments, we receive very positive response. Probably you remember the Article 14 guideline of the WHO FCTC recommend the national clinical treatment guideline is one of the basic infrastructure to promote tobacco cessation at country level. But according to our understanding, is only 60% of them have some sort of national treatment guideline, and the majority of them have not been updated for a long time. So we receive quite a lot of requests from country, say we want to adapt or update our guideline based on WHO newly released clinical treatment guideline. So this is the work which we are planning to do in the early next year. And also for individuals, we already supported several countries to adapt their guideline based on our newly released guideline. I think this to me is very positive. And then for the one you mentioned, the vaping, or those who believe e-cigarettes is a way to help tobacco quit, we received some kind of comments that, oh, finally WHO doing something, but that's not enough. To me, there's a positive way, say at least WHO formally have some recommended proven intervention to help tobacco use quit. And they probably said, okay, you didn't include e-cigarettes as a solution, but that's already we discussed, right? This is very complicated, and the potential benefits and the harms of using e-cigarettes is in another category of literature or evidence, which is not our guide. It's not within the scope of our guideline. But we are also trying to say we will closely monitor the evidence. At some point, probably we'll decide to develop a similar guideline to address how to stop using these nicotine products, but really very much depending on the availability of evidence. That's our answer. Another group is, you mentioned which group? Scientific science. Yeah, for this one, in this guideline, we identified a list of priority research, what we call needed research needs. So we have a list of priority lists to say in which area, in which topic we need more research. I think this also, we got quite positive response, say many of the research team willing to come to see which gap they would like to support to fill. Give one example linking to the nicotine cessation. many research groups, they would like to see if there any research can help identify some effective interventions to help the e-cigarette users to stop using these products. And we see, give one example, the US Choose Initiative, I think they published RTC to report the text message intervention can help young people who using e-cigarette to stop quit these products. Just give one example. And we have some research on whether using the quit line can help e-cigarette user to quit or not. I think there's some preliminary research. And then there are ongoing research. For example, I know the cytosine, that somebody is doing research to test whether cytosine can be used to help in the vapors to stop using these products or not. And also, Christina mentioned the implementation science. I think we all agree the challenge is, according to the RCT, we know the interventions works very well, but at the end, if you look the reality or in the real world, the number of people actually use the intervention is very limited, I would say, compared to we have 1.25 billion tobacco users. Then we have to think about what things we can do to help increase, we call adoption or the reach of this intervention. I think this intervention also is something we receive a quite positive response. Many research groups say they are in this process to help. Yeah, that's just in general quite positive, and also we also believe from outside it is something we could do much earlier, but we was only able to do it by July this year. Thank you.
Hello, Coral Gartner from the University of Queensland. This is probably a question for both speakers, Christina and Dongbo, about funding the smoking cessation services so that it gets implemented. So I'm thinking in Australia, so the recommendation that the services are all offered for free, and in Australia we still charge the patients for pharmacotherapy. It's subsidised, but they still have to pay a co-payment. And yet we have like the most expensive cigarettes in the world because of the tax that's taken in. Is there any opportunity to advocate for funding through like earmarking tobacco tax? I'm just thinking some countries would be quite concerned about the cost of providing this cessation support.
Yeah, I think this, according to the recommendation, is very clear. If we provide free services to tobacco users who is going to quit, so you can see the adoption or the use of the services is much higher, and also they are more likely to quit successfully. But in reality, as we all know, many countries, for many reasons, they're not able to provide free services or even reduce the cost. From our side, in terms of helping the country, we try to see are there other opportunity for policy change we would promote. For example, you know, in WHO we're promoting this kind of we call universal health coverage. They have this kind of beneficial package, or just a UHC package. In this policy change, if we include cessation inside, the cost will be covered. That's one way we are doing. Second, since we are thinking about, for example, in many countries, if the medication included into their national essential drug list, the cost or the way of supply will be much easier. So this is another policy which we are promoting as well. You could see in the last few years, WHO trying to add several proven medication to WHO model list essential medicine, basically to set an example, say, country, please follow, including this essential medicine into your national essential drug list. These are the two things which you are thinking about. But of course, each country have a different way to cover the cessation service cost. For example, some country will have like a special health program to cover. some use insurance, national or other private insurance. We're also trying to encourage them to do that. So that's what we are doing.
Thank you for the question. I'm going to talk not only about the medication, because medication has a cost. Of course, there are some countries, like is the case of Spain, that the treatment has been included in the list of treatments that are subsidized by the government. I mean, depending on your regime, you pay a bit or more, depending on your situation, okay? But this is the pharmacological aid. Then we have also the behavioral aid or the approach. I think that the smoking cessation is not only providing a smoking cessation aid, pharmacological aid, is also including the service in the patient journey. For instance, we are in a hospital that is only for cancer patients. This should be something embedded in the patient journey. It doesn't matter what kind of cancer this person has, or even it has not any cancer. So smoking cessation, in my point of view, is not only providing the intervention, it's also how to try to embed this intervention in the approach of this patient with a health provider. Whenever they go to the primary care, whenever they go to the hospital for only for a check or examination, or for the need of a treatment, whatever the treatment is, even not tobacco related. So this is the real challenge. The challenge is not the medication. Of course, in a hospital like this, where we are treating patients with cancer and they need chemo and radio and other kind of approaches that are very expensive, the amount of nicotine replacement therapy that you are spending, it's very low, so it cannot be compared. But the important thing is not the drug, it's the approach that you are giving to the patient. Because even we know all that something that we have not spoken, but being in front of a health professional, being hospitalized in a hospital is an opportunity to change and start to think about your behavior. And this is better when when you are surrounded by other tobacco control policies, when you are in a smoke-free society and there are smoke-free grounds, or they are in the hospital, or there are other policies that work together. So the cost of the pharmacological aid is something that is important, but the most important challenge is not to pay the medication, it's to pay the health providers, train them to include these reminders, to include these workflow systems that make possible the intervention. But this is something that several hospitals, for instance, in the United States, the Joint Commission have required hospitals to have some standards. They need to comply with some standards in some cases. For instance, if you are treating cardiovascular patients or respiratory patients, all these patients need to be assessed, assessed, or connect to another service when they are discharged. So for me, the real challenge is not the medication, it's the provision of the intervention.
Yes, and one final question, if I may, because we've been talking about adult tobacco users, and that the guidelines, they focus on adults over 18 years old. And in our region, we have 4 million children aged 13, 15 years old who use tobacco. So, Don Bo, any insights on this? What interventions are effective for tobacco users under 18?
Okay, yeah. Now we have been asked by country as well. Say, how about people younger than 18 years old? Just want to say this is the first ever WHO clinical treatment guideline. So the steering group at that time had to decide how can we finish this job within the period of time, and also based on the resources we have. So at the end we decide, okay, for the first guideline we will focus on helping those 1.25 billion adult tobacco users to stop using tobacco. So that's the scope we decide. Although in the guideline we didn't make a specific recommendation for those who are younger than 18 years old to quit, but all the recommended behavior interventions, either brief-wise, the intensive behavior support, the digital tobacco cessation interventions. All of these behavior interventions are also applied to people younger than 18 years old to stop using tobacco. So I would just say the behavior interventions are applied to people younger than 18 years to stop as well.
Thank you so much. So on this note, I think it's time to wrap up this session. So my appreciation to our speakers, Dongbo, Christina, a round of applause, please. And also to you for your attention and very good questions. Thank you, everyone.
So the last but not the least session before closing, in tobacco control, like in any other sphere, we need to prepare the team of people who will move forward the tobacco control. And we need to count on those young researchers and young specialists working on tobacco control. And it's our pleasure to count with so many young researchers in different stages of their career from different places in Europe. And this session will be moderated by a lecturer and researcher at the Alcalá de Henares University, Chisca Sureda, who also kind of did a travel in her research career from PhD training here at the Tobacco Control Unit and then moving to Madrid to continue tobacco control there and building her team there. So Chisca, it's a pleasure to have you.
Thank you, Elena. It's always a pleasure to come back here at home. So good afternoon, everybody. First of all, I would like to thank to the Catalan Institute of Oncology and the World Health Organization, and especially to Cristina Martinez for inviting me and for organizing that event. The different sessions during the day, we have been of a very high level, and we have all learned a lot and enjoyed listening to great experts in tobacco control. But I think we have now one of the most exciting sessions today. So we have here 5 people, 5 young researchers at the early stage of their careers that have energy and motivation to generate evidence to tobacco to control the tobacco epidemic and translate their results into practice. I'm sure they are very engaged in fighting the strategies of the tobacco control industry to hook newer smokers, especially among new generations. And I really believe that we especially need their voices because it is precisely young people who can best understand the new generations and the industry strategies aimed at them. I'm sure they can come up with the best strategies to prevent young people from starting to smoke, vape, or strategies to make it easier for those people who have already started to quit. So I'm looking forward to listening to your voices this afternoon, as I'm sure the rest of the audience do as well. So I will introduce the speakers today. So Roberto Valiente from the University of Alcalá. He's a geographer, expert in geographic information technologies, and researcher in health geographics and spatial epidemiology. Roberto is currently assistant professor in the University of Alcalá. Prior than that, Roberto had a postdoc research role in the University of Edinburgh, a School of Geoscience, for 3 years, working with the Spectrum Consortium in several projects, analyzing retail transactions data on tobacco and alcohol sales across the UK. His current research is focused on the study of commercial determinants of health from a spatial perspective, particularly those related with tobacco and alcohol issues. In this commitment, Roberto analyzed the availability, accessibility, and visibility of these unhealth commodities in the space and its relation with population consumption and socioeconomic and health contexts and problems. Rebecca Howell from the University of Stirling is an early career research at the Institute for Social Marketing and Health at this university. She works across the field of commercial determinants of health with a focus on alcohol and tobacco-centered projects. Her recent work involves looking at how nicotine replacement therapies can be used to create smoke-free homes for the benefit of children's health. Rebecca also works extensively with public and patient involvement and has a keen interest in how co-production with lay advisors can benefit research. Akaya Teshima from the University of Barcelona. She is a predoctoral researcher. She's completing her doctoral studies in the Tobacco Control Unit under the supervision of Professor Fernandez and Dr. Martinez. She has an undergraduate degree in nursing and a master's degree in public health from the Imperial College of London. Her main research interest is measuring the burden of smoking and evaluating tobacco control policies to contribute to reducing the burden of smoking at population level. Nerea Mourinho from the University Hospital of La Coruña. Nerea is a nurse with extensive experience in the UK. She completed a PhD in epidemiology and public health at the University of Santiago de Compostela. Her doctoral thesis explored the effects of pre- and postnatal exposure to secondhand smoke on adolescents' body composition and cardiometabolic health. Since September 2024, she is assistant professor at the University of La Coruña, and she does research on secondhand smoke and the use of psychoactive substance. Sophie Brusnell from the University of Bath. Sophie is a research associate in the Tobacco Control Research Group at the University of Bath. She previously studied human biology and forensic science and worked in the health and social care public sector, including a secondment at the UK Department of Health and Social Care. In 2023, Sophie completed her PhD on tobacco industry approaches to harm reduction science and whether these approaches help or harm the public health. Sophie has acquired extensive knowledge in head tobacco products and tobacco industry science. So to start the debate, I would like to ask you, all of you, so you feel free to answer if you feel comfortable. So you all have different backgrounds, and according to your CV, you have been using different methodologies to conduct your research. Some of you are more familiar with qualitative data, some other of you quantitative, even systematic geographic systems. Which are the benefits and difficulties when using different approaches, and how to fit the different areas of research methodologies to complement each other? So maybe, Sophie, do you want to start?
Hi, thank you for having me. So my thesis was mixed methods to some extent, but I came from a mainly quantitative STEM background, and the vast majority of TCRG, my research group, are more on the qualitative social sciences side. So I found that transition quite hard. Quantitative research can be quite, what is the word I'm looking for? Sort of square and restrictive, and there is sort of one right answer, and then to enter this world of qualitative research where every answer is both right and wrong was really hard to adjust to. But I found that mixing methods worked really well when you wanted to understand both what and why. And it doesn't always work that, you know, the what might be quantitative and the why might be qualitative. Sometimes it was the other way around. But I found that you can only really get a complete picture by including both areas of research.
Thank you.
Hello to everyone. In my case, I have always done quantitative research, but my research team is doing also qualitative. And I think it's very important to combine both. For one hand, to be able to collect data on smoking prevalence, on second-hand tobacco smoke exposure, or even third-hand tobacco smoke exposure prevalence rates, and also about cessation rates. On the other hand, I also think it's important to do qualitative research to know the characteristics of the users, to know their motivations to try to quit smoking, their difficulties they can find, and also their opinions from those who tried to quit but they didn't manage to do it. So I think that's very important, but I also think it's important to standardize the way data is collected, because we have done some systematic reviews about which questions are used when asking about consumption or secondhand tobacco smoke exposure, and we found that there are huge differences through different studies. So I think it's important to try to homogenize, to include always the verbatim questions, because sometimes we cannot find them. And also, this is important, no, for efficient comparison between across studies, across countries, to track changes in the consumption or cessation or secondhand tobacco smoke exposure. And also, I think it's very important to always use the same time frame, for instance, and when using analytical techniques, to also try to use the same, or for instance, the cotining, which is used to measure exposure or consumption, it should be always come from the same biospecimen, because it can be measured in urine, blood, in serum, hair, saliva. Cut points are different, and also the limit of detection from the analytical techniques are different. They have been progressed over the time, and now the limit of detection is getting really low, so it can even detect non-significant exposures or consumptions. So I think it's important to homogenize the data collection for effective comparison.
Right. Okay, yeah.
I would like to add to Nevier's point regarding the standardized indicator for comparisons. I think it's very important to establish platforms for sharing databases and research findings to all researchers from various backgrounds. For example, the researcher from economic background, maybe they want to know the differences of the price of tobacco affect smoking initiation or quit ratios. Then we could collaborate from epidemiologist and economic background. Also, maybe behavior science could be useful. But from my research experience, most important things to have are accurate and comparison, available data set for sharing is very important. This is my point.
Maybe, Robert, do you want to give your insights using the systematic information systems to tobacco control research?
Yeah, thank you.
Maybe you can explain your experience.
Thank you very much. So, I'm happy for inviting me to be part of this roundtable. So it's a pleasure for me to be here and learn from all of you. From my point of view, I will identify myself more a quantitative person, but also I'm a geographer, and everything occurs in a space. So when I say everything is about quantitative data are come from a particular region, but also ideas and feelings that can be assessed through qualitative techniques also occurs in a space, has specific characteristics and is under different connection or relationship with other things that also has place in the same location. So that's what I investigate using the geographic information systems. So, and from my point of view, both types of different techniques can complement each other. And yeah, I think depending on the research question, so we can use one method or another. But all the methods I think are important, and having different types of methodologies, quantitative, qualitative, and etc. So I think is the best tools that we have for achieve a tobacco end game. So using them in combination and using mixed methods, I think is the most, I think is the way to progress, so we can complement each other and learn from each other as well.
Thank you. And Rebecca, if you want to add some points to this question.
Yes. I'm going to toe the party line and say mixed methods is probably the best way to adequately reflect a landscape of tobacco consumption and cessation. My work is possibly a bit more qualitative. I largely do interviews with participants of smoke-free home studies at the end of a study, and I think this gives a lot of richness to research. You can really get to know the people that are attempting to quit smoking, to reduce their smoking, to move their smoking outside. And I think understanding their motivators, their barriers, it helps you design the next study better.
Right. So some of you are interested in health inequalities in tobacco use and secondhand smoke exposure. So how health inequality should be addressed in research studies, and which group do you think are particularly vulnerable to tobacco industry? And maybe, Rebecca, you can start this time because you have experience in the study of health inequalities in smoke-free homes. So
I think sort of globally we see health inequalities, but at a local level we do as well. Certainly in Scotland, where I do my research, lower socioeconomic groups, there was high prevalence of smoking, and I think it's definitely something that I think we need to bear in mind when we're looking at smoke-free generations and aiming for that 5% or lower globally and within each country. I think we need to look quite critically within certain areas as well to make sure that that 5% is reflective throughout a country rather than just overall.
Right. Nerea, would you like to continue?
Yeah, sure. Well, I would like to mention a recent publication I found regarding initial perceptions on the endgame goals in some countries such as Finland, Canada, New Zealand, Scotland. They found out that there was a limited progress in the reduction of ethnicity-based and socioeconomic disparities in each country. So I think we should focus on some specific at-risk groups, such as those with low income, low level of education, or marginalized communities, because as my colleague said, they used to have a higher prevalence of smoking and significant disparities in the health consequences. So I think we should get their engagement with representatives of these at-risk communities, to integrate them in the design, in the implementation of policies, to make sure that they are culturally tailored to them and adopted in the right way, and also, as it was mentioned earlier, to provide financial support or free nicotine replacement therapy, or behavioral support, some digital techniques, and also not only focusing on smoking consumption, also on secondhand tobacco smoke exposure to protect public health and vulnerable groups such as pregnant women and children.
Thank you. Do you want to add something, Roberto, about your studies? You have a study, health availability and accessibility differs according to socioeconomic difference in an area. So I don't know if you want to add some point to how to address that inequalities in terms of availability and accessibility to tobacco.
Yes, thank you. So first of all, I'm just trying to address this question from a more general point of view. And I think on tobacco as a social behavior, as I mean, it's also happening in a place from a geography perspective. So you can find smoking cultures differ across different territories. So tobacco is rooted in a place in a different way, and tobacco has a different value for these communities. And of course, inequalities exist, as my colleagues mentioned, and I always think that when looking at these inequalities, what is behind that inequalities is that tobacco has a different value for that specific communities. And with value, I mean, for example, economical value, because tobacco is a financial product, commercial product, and it's also related with economy at some point as well, but also has a value because tobacco is used as a tool to cope with life for specific socioeconomic deprived neighborhoods. So these kind of values also differ in the territories and communities. So, and yeah, so when we look in a specific studies, as Chisca mentioned, so for example, in the city of Madrid, you can find that tobacco as a commercial product is present in the space in different ways. The first way is about in tobacco production, so tobacco harvesting is located in specific areas. Also, tobacco manufacturers were producing the cigarettes and the new tobacco products we talked about before, like e-cigarettes, etc. Is also rooted in particular areas, industrial areas. Also, tobacco is also present in the space by shops that sell tobacco, so we call tobacco availability, and specific neighborhoods are most affected to this tobacco availability in their area, and there are some factors influencing this tobacco availability in the space. And also tobacco is present in the space through customers, so that we have also second-hand smoke exposure, so we are exposed to smokers in the street, so we can see them. It's also another way to be exposed to tobacco. And also, of course, tobacco advertising, which is banned in some places, but not in others. So again, we have inequalities in the legal landscape across territories, and these are other factors that can be analyzed geographically. So that's my general point of view from geography as well.
I think even in the access, when you want to buy tobacco, in some neighborhoods are more easy than in others. So
Yeah.
the example of the chinos, if you want to explain to the audience, because maybe they are not familiar with that.
Yeah, so in terms of the legal framework of the stores that can sell tobacco, so here in Spain, for example, the tobacco sales are restricted to estancos, which are tobacconists, and that tobacconists depend from the government, and the location of these tobacconists are guided by license. It's a license system, and the location of the tobacconist and also all the sales that they have, so is related to the government, so depends from the government. But in this landscape, so there are also some stores that can sell illegally tobacco that we call, for example, the convenience stores as well. And these convenience stores illegally selling tobacco also appear in certain areas of our cities, like more deprived areas. So it's also a process occurring behind that as well. And yeah, I think...
Great. And Sophie, I'm particularly worried about new tobacco products promoted in social media addressed to new generations. I think it's a big challenge because it's very difficult to regulate. So I don't know if you have think about how can evidence that problem and how can we report that in our studies?
Yeah, thank you.
Even how can we regulate it?
How can we regulate it is a hard one. So for those of you that were present at the COP this year, it was a topic of conversation. And of course, the issue is that social media is transnational. And so how can you regulate something that crosses multiple jurisdictions when those jurisdictions can't agree on how to do that? But we have seen local level and regional level regulation that works to some extent. So in the UK, and I'm ashamed to admit this, but I find it entertaining sometimes to look up the various heated tobacco and vape companies in the UK and watch their Instagram, Facebook, Twitter and TikTok accounts go up and then go down and come back and then disappear again. So to some extent it must be working because they are trying to enforce in the UK the ban on advertising e-cigarettes and tobacco products on social media. But using the UK as an example here, there are still flaws in the system. So, for example, we've talked about this a lot today, particularly in the nicotine talk, making sure that the regulation around advertising and promotion is all-encompassing is one of the biggest loopholes that exists. So take heated tobacco products where the regulation might cover the tobacco stick but not cover the device. And in the UK, our own government has said to, for example, Philip Morris, you can't advertise on social media, it falls under a tobacco product, please stop doing it, we will take action. And Philip Morris said, we've spoke to our lawyers, we think we're fine. And the government did nothing. It's continued. I'm currently compiling a list of it to put to the consultation. So yes, tightening existing regulation to make sure all these new innovations are covered is probably the first step on the way. How do we regulate transnational social media? That's probably something for COP rather than for me.
I don't know if some of the other speakers want to add something to Sophie's opinion.
Yeah, I would like to highlight a recent report from the Spanish Association Against Cancer, which mentioned that during a period of 6 years, over 50 million Spanish young people were exposed to tobacco-related content from top influencers from different sectors, including lifestyle sector. So I think it's these alarming statistics underscore the importance of regulating the marketing of tobacco through social media, because many young people, minors, are using social media, and also through movies. I can see, I have recently noticed a lot of movies where actors, actresses are smoking, so I think they should clearly labeled sponsor content. I think influencers should mention if they work with tobacco brands, and also I think it's a good example there is a good example from India, which they are requiring health warnings before, during, and after tobacco scenes. And I also think it's important to mention that in most cases, when actresses and actors are smoking, they are fake cigarettes. So, yeah.
Yeah, Kaya.
As we all know, it's very difficult to regulate on advertisement on social platform. So I would like to introduce my experience from my, it's not personal, but my additional work. I participate in Cancer Prevention Awareness Initiative as a youth ambassador at European Cancer League, and I've met many young, passionate individuals from various backgrounds who were deeply committed to public health in cancer prevention. And then I think I learned from them improving media literacy for youth as a consumer for tobacco industry nowadays, like implement educational programs both in schools and online to help young people understand the impact of advertisements and the marketing strategy from tobacco industry. For example, they introduced me, there is one good movie, it's called Thank You for Smoking. It's from Elon Musk, and that is very good for youth to understand, oh, how the tobacco industry manipulate us. And then they are young, they are easily to be influenced, but they are not stupid. So this kind of implementation that would be effective rather than regulation. Of course, regulation is very important, but it's very difficult. So these kind of awareness initiatives could work, I think.
Thank you. Now I would like to ask you more general questions that you are free to answer, all of you. I would like to know which challenges we will have to address in tobacco control research in the next 5 years. So everyone can start.
Well, I think considering all the aspects which were mentioned during the day, I think it's very important to implement and to do actually, to keep doing research, not only on tobacco consumption and second-hand or third-hand tobacco smoke, but also about the long-term health effects from e-cigarettes, because I can see that a lot of young people mistakenly believe that they are a safe alternative to traditional tobacco. And I also think it's very important to implement smoke-free private homes, public housing, and car policies. We have examples from other countries, European countries, some of them have already implemented the smoke-free car policies. We have a good example from United States and also Canada about the implementation of smoke-free policies in public housing. And in private homes, as it was said, it will be more difficult because of the individual rights, but I think that providing educational campaigns about the effects that not only health adverse effects, also financial and environmental impacts. So I think it would be important to highlight this on research as well. And another important aspect I would like to mention, considering the example from some organizations and hospitals in the United States, is the non-smoking hiring policy. I think it's important the fact that they are testing some employers to see if they have quitted or if they have enrolled to some cessation programs, otherwise they have to pay a fee. So I think that's another important thing. And then about the increasing the age for the purchase, I think that's very important as well, following the examples from New Zealand and now from UK, which will come into force by next year, not only with traditional cigarettes, also with vapors. So I think especially we should focus on the long-term health effects from e-cigarettes.
Yeah, Rebecca.
So I think the challenge that I see is also an opportunity. Is it on? Oh, sorry about that. As you said in your introduction, I'm very interested in public engagement, and a lot of my qualitative research involves talking to people about how they find interventions. And I think as an early careers researcher, public and patient engagement, PPI, is very normal to me. And I think one of the challenges that I face is bringing it to more established researchers and hopefully being able to show them the value of engaging with people that are affected by policies. And I think with tobacco control, that is smokers, people trying to quit, but it's also the general public. I think these policy interventions do affect us all in terms of secondhand smoke, in terms of people that we live with, and just out in public spaces. And I think, another challenge is making sure that our new policies that we introduce don't create new health inequalities. And I think engaging with the public can help us understand where those tensions might be and hopefully help us avoid them too.
Thank you. Yeah.
It might not come as a surprise as here representing TCRG to talk about industry science and the influence on science for profit. I think over the next 5 years especially, we'd love to see more progress towards protecting science, because I think we can, as independent researchers, can continue to conduct the excellent, valuable research that we do on the products and on the practices of the industry, but that is an uphill battle against the flood of industry science that will try to skew the database and impede any public health policies that look to undo the epidemic that they have caused. And so I think any research that strives to improve practice within research itself is also very valuable, particularly in the next 5 years.
Thank you. Maybe in relation to your point of view, I think it's important to advocate in tobacco control researchers to transform our results in actions. We cannot stop after publishing our data. We need to go next step. So how to go from research to practice and how to minimize the gap between evidence and practice?
Yeah, thank you. So this comes from some experience I had recently. I'm hoping that some people in the room may have seen my recent work on Philip Morris Japan and exposing their secret covert science that they were conducting in the region around harm reduction and heated tobacco. And what was essential to that being so impactful was disseminating it to be able to influence practice. And I would say the biggest thing that we can do as researchers to help that is firstly be clear and concise. We are academics, we love to ramble and to talk about our research in such great depth, but often for lay people, even for policymakers, that's too much detail. So having really concise abstracts and conclusions that can then be utilized in press and lay audience media is super helpful. And then the second thing that's also helpful is to actively engage with groups and people who can actually access the public. The public cannot often access our academic papers, even when they're open access. By access, I really mean, can they understand the paper? And so we're very lucky in our group to work with Vital Strategies as our comms team. We also have our own in-house comms team, but also we work really hard to maintain relationships with journalists around the globe. If they reach out to us and we can't help them, we'll still keep them as a contact, because you never know, down the line you might publish a paper that's really pertinent to that region from where they live, and so it might be worth reaching back out to them to see if they would be interested in disseminating your research. Yeah.
Thank you, Sophie. Roberto?
Yeah, thank you. So just to add what Sophie was saying, so I fully agree with her. So just to add what Sophie said and bring some connections with the first question, I think we have like a lot of methodologies that we can use to display and convey our results in a fancy way that and concise way as well. For example, we can use technologies like, so we can use already infographics, videos, cinema. We can use also interactive mapping platforms that can reach a broad audience very quickly. So we can use these technologies as well just to widespread our results to the lay audience.
Thank you, Roberto. Akaya, would you like to add something? Don't worry. So I have here in front of me 5 young researchers well committed to tobacco control, but we need much more people like you. So can our society involve young people in research, and particularly in tobacco control research? What can we do?
I'll go to schools. is number one. It's something I do. I find that not only are you educating them on something, so usually I'm going to give a talk about e-cigarettes or heated tobacco or nicotine pouches, but by doing that, I'll often get emails then from those students saying, can I come do my internship with you guys? Can I come do my work experience with you guys? So I think this speaks to Becky's point about community engagement is really essential to getting the next generation of tobacco control researchers, not to be confused with the next generation of nicotine users.
Other opinions? Nerea.
So as they said, I think it's very important to instill in the importance of investigation from early ages when they are at the school, doing some maybe easy essays or basic research about topics they consider important or relevant to create inquiring minds. And also I think there are some key aspects when doing and continuing research, which are to feel passionate about a specific topic, to understand that they need to be patient because sometimes things cannot get as quick as we would like to, but hard work always have its rewards, and also to feel motivated. I think that's very important. To understand it takes sacrifice as well, and also I think it's very important to have the person, for instance, directors support. I think that's really, really important to make sure they achieve their goals. And there will be challenging moments, but if you have your director support, as I luckily had, it will help to finish the PhD studies, for instance. Yeah.
Yeah, just in line of my colleagues, just to add one thing that we need to review to keep young people in research is simply work conditions. I think they're very important because doing the PhD is not easy, as they mentioned. And yeah, there are a lot of difficult moments, and not all of us are similarly equipped to cope with these difficulties in terms of family issues, health issues, psychological issues. So I think it's very important to be aware of these inequalities as well within our capabilities. And I think improving work conditions can be a good way to foster young people to be involved in tobacco control research and research in general. And yeah, and so I also agree with all my colleagues.
I think this is a key issue, especially the situation we have in Spain. So people who have conducted the PhD here, I don't know in other countries, but it's not easy to start and continue in the research career, and then to have an established position. You have to fight it. So I have a last question related with the topic of the symposium today. Then I think we have 5-10 minutes to the audience if have questions for our speakers. So it's related with one of the questions I made before, relation the challenges in 5 years. But now, in 5 years, if we look back, which actions would you like to say that have been taken in tobacco control? Yeah, so if you look back in 5 years, which actions would you like to say that have been taken?
I'd love for the tobacco and vapes bill to be passed in the UK. Very selfish, but that's, yep.
I would say try to control the message, because I feel that we as researchers, we are always one step back on the tobacco industry. So I think it's very difficult for us to chasing them because they are like releasing new tobacco products, and it's very difficult for us to keep evidence update. So, but at least I think we can trying to address conflicting messages related with tobacco use, and I think also that will help for the society to be well informed and not have this the information. I think that would be a good point to address in 5 years.
Great. Akaya?
So I would like to add what Roberto said now. So I would like to advise, well, like of the back in the day, strength timely monitoring and surveillance of product-specific usage. As Robert says, in last 5 years, the emergence of new tobacco products occurred. So, like product-specific usage is a key to monitor and address the policy actions. So, those kind of surveillance could be strengths.
Nerea?
Yeah, and I think it's. I think now there is more awareness about the health adverse effects from secondhand tobacco smoke exposure. So, as I said before, I think it's very important to implement smoke-free policies in this aspect, and also to keep increasing the tobacco taxation, because I think is one of the most effective policies, as it was seen that by decreasing the price by 10%, by increasing, the price by 10%, consumption decreases by 3-5%. So I think that's very important. And then also, as I said before, increasing the age from which the tobacco can be purchased as well. I think it's very important.
And Rebecca?
I think I'd like to add to Sophie's wish that the tobacco and vape bill goes through. I would like to see the smoke-free generation go through as well, because I think they work hand in hand, and I think without that commitment to raise purchasing age, the bill, there could be some issues there. And I think just generally with those commitments and general commitments globally, just the support for nicotine cessation as well. I think more money needs to be invested, and it would be great to say in 5 years' time that all worked perfectly.
So thank you. Now we have 5 minutes left, if the audience want to do some questions.
Thank you all for sharing your experience. Could you, each of you, briefly share one of the recent instances when you were interacting with anyone outside of the bubble and that you felt inspired and motivated or proud of the work that you do? Any sort of specific example, whoever, if nothing comes to your mind, you can just pass the microphone to another one.
This comes from the Philip Morris Japan thing. I got sent by quite a few family and friends, like the Guardian coverage or coverage in various news outlets around the world, not realizing that it was me. So they were like, you should see this, it's really interesting, you'd love this is your work, like it would be just like, up your alley. And I was like, yeah, it's because it's mine. So, but it was really just, I felt the impact. It was fantastic.
So I guess similar, people send me stuff now. They see my work in public and they can attribute it to at least my field. And that feels really nice. I used to be an art librarian and everyone used to say, oh, that's such a cool job. But now I feel like I'm doing something that's actually a lot more meaningful, and it's nice to have just people in my broader sphere recognise that too.
Yeah, I think it's nice when you can see that people, when you talk with some students or friends that they didn't know about, for instance, in my case, the effects from secondhand tobacco smoke exposure. So when they see on the news or some publications and they are interested and they ask, what did you find? And it's nice when you can share this knowledge to people who didn't know about it and you feel they are interested.
Thank you. I think it's so glad to have a group of enthusiastic young researchers with us. You know, I always have one question in my mind linking to this region, the WHO European region. You know, the prevalence of smoking among the females is the highest compared to other WHO regions. So I always have a question. So why the female? Why we have such large number of female smokers? And second, as a cessation person working in cessation areas, how could we help them stop using tobacco or cigarettes? So I'd like to ask any of you, do you have any interest? Do you have interest in finding out the answer, or do you have any suggestion to find out the answer? Thank you.
Easy questions.
Do you want to answer?
Anybody wants to respond before I pass?
So in terms of the difference in the prevalence between different sexes in Europe, I think that responds to like a theory that explains how historically the prevalence evolved through time, and particularly in Europe, in the middle of the 20th century, the prevalence was so high for men and very low for women. And then in the 70s, 80s, it depends on the country, so associated with a more heavy marketing campaign to targeting women related with empowerment, and so the prevalence of smoking in women increase, and the prevalence for men tend to decrease. And I think now at the moment, so both of them are very similar, but probably slightly higher on women. But I think it depends on the country. Yeah, I don't know if any.
Yeah, I think so. AIM right now, what PMI says in its private documents forecasting profits, they know where they can make money. And it's selling to women. It's selling in countries where women will associate tobacco with power, especially Asian countries. Women are getting access to education, and they're selling the same message they sold in the States in the 70s. You've gone a long way, baby. So that's number one. Number two, the interviews that I've done is that there are a lot of young women who are starting to smoke in Spain, especially around 14 or 15, for exactly the same reasons that people started smoking in the 50s and 60s. Be cool, look older, and hook up. But the young women now also are doing it for weight control and performance. They use nicotine to study and get good grades and compete. And then when they're about 18 or 19, they realize they're addicted, and it interferes with their lives. So we have a lot of messy stuff going on right now, especially in Spain. A couple of the doctors I've spoken with look at the hormonal reasons and the way our brains work differently than men's brains that make it more difficult to quit. I can hook you up.
Question, we touched a bit upon it in your discussion. So there is a saying, he who frames the debate wins the war. So it's not enough to generate sound evidence now. We need to communicate effectively about it. Yes, correct? And then you mentioned, Sophie, that we need to be concise, to the point, and you, Roberta, told about different mechanisms to use. But any insights on how to make research resonate most strongly, specifically with policymakers, in the times when they have so much on their agenda? I mean, this perma crisis, which Angela mentioned, emergencies, wars, everything, climate change, everything. So how do we keep tobacco control up? Any thoughts?
I think it was maybe Becky I was speaking to about this earlier, and to you, Lilia, I think as well. Something we're trying to do a lot when presenting or giving talks from our group is when you're in a room of people who might not agree, particularly on products like e-cigarettes, like heated tobacco and nicotine pouches, often you can bring those people together by taking the perspective of the industry and saying, okay, well, we can't agree whether the products are good or bad, but we can agree that the industry selling them are majoritarily bad. And that tends to bring people together even when they have huge disagreements on the products themselves. And the more people that we have together, the better chance we have of influencing policy against the tobacco industry and in favor of public health. Am I making sense?
Yeah, Rebecca.
So I think on that, you have to remind the public that it's still a problem and get public buy-in. I think I talk to a lot of people with my alcohol hat on, and when you talk about tobacco, they're like, oh, we solved that problem. And I think that's a massive barrier that, especially in the UK, people think that rates are low and that we solved it, and we haven't. So, yeah, it's keeping people engaged in that.
So I think we run out of time. So if you agree, we can close the session here. Thank you, all of you, for that great session.
Much, Chisca Sureda, for this table. We are going to do the closing of the symposium. I would like to ask the authorities that come to the table, please. We have Esteban Fernandez, we have Dr. Gullón, and also Dr. Capellà from the IDBEL institution. And thank you for all of you that you are still here, like surviving, you know, that this long day. Okay. No. So I have with me the same people that we did the opening of this symposium. So we are very lucky because the two main authorities of public health have been here all the day. That means how sensible are with the topic. And we also have another representative from our institution here from the IDBEL, and we have also our colleague Angela, that together we have prepared the symposium. So we want to do the final remarks of the symposium. First, I start very briefly by saying thank you for all attendees, those that you are here and those that they are online. And thank you, I think that we need to acknowledge the team of the Tobacco Control Unit to organize this symposium. And please, I will ask you an applause for them. So it's a great team, and it's a great opportunity to work with them. This is only an example of everyday effort that we do in the team. And in the case of the symposium, I think that we have organized this symposium together with WHO with a lot of enthusiasm in order to gather all the topics that we have seen today, including the review of after 20 years of the FCTC, how we are doing. Also, it has been very interesting, all the illustration of the new emerging products that are not emerging, are on the market. So we need to change the name. It's not an emerging thing. It's something that it's a reality. And we are facing this reality, and we need to do something. We also have reviewed how to regulate the smoke-free policies in places that are not regulated. And we have seen that there are solutions like smoking cessation that sometimes are not very well implemented. And we can use implementation science, that it's something that helps in the implementation, not only to smoking cessation, but also to other policies. And finally, it has been very nice to see how we have people and young researchers that are going to continue with these efforts that we have been working for years. Many of us have been working 20 years in this topic, and others even more. So imagine how long trajectory it has, tobacco control right now, and how much it has changed in the last years. I want to say that thank you for your attendance, and I hope that you have safe travels, and see you soon in the next soon in 2 years, in fact, in the 8th ICO-Symposium, hopefully here again in our institution. So, and I give the floor now to our authorities, Dr. Fernandez and Dr. Guillaume. Probably Dr. Fernandez.
Thank you very much, Cristina, and thank you very much to all the colleagues in the final table, in the closing table. But of course, first of all, thank you, as Cristina said, to survivors, to the symposium. It's great to see that almost 5 p.m. More than half of the attendees still remain here, and I believe that one of the big things of the symposium is to attract the attention and to be able to concentrate here during 6 or 7 hours, people wanting to share experiences, learning and sharing. So I believe it has been a terrific symposium. If I should write a tweet or something in the new network, in Blue Sky, I had written this. And I believe that the goals of the symposium have been accomplished. Cristina was making the list, but in summary, we have had interesting tables in the different topics with great presentations, very well moderated, and also with an excellent lunch. Also target to facilitate people interaction and so on. So I believe that it is quite complete. It has been very complete. In this moment we are at the crossroad with new paths towards tobacco control after many years of the FCTC, national legislation, supranational legislation or indications from the Commission in the case of Europe, and we are moving towards tobacco endgame. So we have seen diverse aspects of tobacco control, including the fresh vision of young researchers that are engaged in tobacco control research at this point, and that they will be contributing during the next 5, 10 or 15 years. In fact, one of the questions I had is, if you had a permanent position and 300,000 euros per year during the next 5 years, which would be your next study? But I didn't make this question. But my suggestion is to all of them to think about it. So I believe, I believe things, but it doesn't matter. What I want to express now is the full commitment of the Secretariat of Public Health from the Department of Health here in Catalonia to advance control in our country, in Spain, and of course trying to have incidents also in Europe and worldwide. We are doing our best. We are collaborating with the nation's government to promote new legislation and to make tobacco control something not restricted to one single day, to the first 30, the World No Tobacco Day, 31st of May, okay? But we want to expand this through the whole year. It's a moment in which we need more legislation, strong legislation to be enforced, to be implemented at the different levels, at the national level, the regional level, and also the municipalities have to contribute, but also to change the minds or to change the behavior of people, not smoking or smoking, but the behavior towards the fact of smoking and no smoking. We are at a good point. All our experience, I believe, has brought us to a point in which we can have new gains for tobacco control. So it has been a pleasure to be here participating from early in the morning, and I took with me several messages to be applied. Thank you.
Thank you very much, Esteba. It's our pleasure to have you here again at your home and with your team also. And yes, we invite also to speak to Gabriel Capella. Dr. Capella is the director of the institution IDIVEL, that also many of our research goes to DIVEL, and he knows how active we are sometimes in applying grants and continue with our group, that many of our team is not only from Mexico, half of them, they belong to this institution, IDIVEL.
And thanks. So first, I want to apologize for early this morning that Dr. Joan Brunet was not joining us. This weekend, he lost his father that was ill, and he could not make it. So here you can imagine that I am now under two hats, one hat from ICO and the other hat from the IDIVEL. And this is probably the same that looks as me, as I have two brands. So my personal interest is in hereditary gastrointestinal cancer, so I am very much into prevention. And one of the key things in this campus has been that from the very early inception of the Catalan Institute of Oncology, cancer control and prevention was a mainstay here. So whatever is built here in this field of epidemiology, cancer control and prevention is built on the shoulder of some giants that came here some 20 years ago. Early in that step, Dr. Esteve Fernandez now is sitting close to me and has this special political role, has been crucial to make tobacco control happen in our institution, but I have to say that with a strong endorsement from the institution. From a very much more personal tone, if I may, I always tend to explain seeing him walking in the outdoors of our facilities, and all in a sudden he finds somebody that is hiding and smoking, somebody that probably is coming out of either the radiotherapy facilities or because this is a huge building, we have a huge social facility here. So there are people that tend to smoke. He's among the few of us that he would come in a positive and assertive manner and talk to them and saying, you should not be smoking here. And I have seen some of them, and sometimes I do not. So this is a small token of his commitment with tobacco control. Having said that, what's important here is that, and with my hat on the IDIBEL and research, the foundation of any policy must be made on knowledge, and this means research. And this is what is happening here. This is our research institute is linked to healthcare providers, a monographic cancer center, the Catalan Institute of Oncology, a tertiary care center on the other side of the highway, that is the University Hospital of Bellvitge. And we are a community of 1,400 people. Out of these, half of us are dedicated to cancer. And we have identified two main programs in this area. What we call the OncoBel, that would be what is not the EpiBel, that is the epidemiology of cancer. So for us, it's an identity mark to have a research program on cancer epidemiology that may include etiology, but also cancer control and prevention. We are proud of this, and we are very proud of hosting this symposium because it attests to this commitment. And I would say just 3 more words. So in 2021, if I am not wrong, Europe's Beating Cancer Plan was launched, and there this attractive idea of a smoke-free generation was launched. It is, I would say, moving somehow that so many of you are committed to achieve this, which I see as a very difficult endeavor. So I just would like to encourage you on doing this. The second concept is here is that I have seen in the program is the implementation science. I tend to find it easy to understand what it means and difficult to explain what it is. So I have mixed feelings of this. But clearly the idea of learning while doing and then drawing lessons from this and trying then to inform whatever the decision is made by the policymaker is a good idea. And I think, I consider that probably this is what is underlying the idea of the implementation science. I would say that just do it and provide the best evidence for policymakers now, Esteban, to go and make the right decisions and push forward the best strategies to mitigate and eventually end with this pandemic that is the tobacco smoking. So again, my congratulations on the symposium and my best endorsement to generate the knowledge that would translate into an effective policy that would somehow control this pandemic. Thanks.
Thank you, Dr. Capella. We really appreciate your words and also the fact that we know that prevention is an important part of the debate, and also later on, if you want, I can explain you what I have said about implementation science. It was very brief. Okay, so the last person, and the next person I want to make the final remarks is Angela Giovano from WHO, who has been with me and the rest of the team designing this program. Hopefully that will be interesting for you, because it's not easy to think about the topics of a broad topic as tobacco. Tobacco has a lot of, like subtopics, and we were thinking, okay, what we should introduce in this symposium. So Angela was very determined in order to think about the topics and also the speakers.
Yeah, thank you, Cristina. And also, as the closing remarks, I also will start. I'll focus on 3 things, but I'll start with thanks, because first of all, thanks to our hosts for accommodating all of us here, for bringing all of us here, for treating us well during the entire day, and for having quite good lunches also in the between. Thank you. I also would like to thank my WHO colleagues who came here, who presented wonderful, interesting information and share the experience. Thank you, all of you. Thank you, my colleagues from all the NGO, the key NGOs. But all of you that came here shared, and I was very encouraged and very happy to hear the speeches of the young researchers. And we as a WHO, we also try to promote it. And the next year we'll have a small project, just small project in 2 countries, piloting how to help the researchers in the countries where they have data to do more, to generate the evidence, what they have. Therefore, I was very encouraged by your experience and your words. Thanks for coming here. The second point I would like to mention about the changes and the support. We as a WHO, we try to provide support to every single country. Great that you will continue to be and you are stayed forward to strengthen the tobacco control measures. Yes, because it's not just a harm to do the wrong things, but a harm to do nothing. Therefore, it's great that you are moving forward. Thank you. And we as a WHO will support every single country with what we can. And we'll stay committed. Not we as a regional, because we have the country offices in some countries and the colleagues from the headquarters. And also, but the changes coming from each of the person. Therefore, you as a person, don't be just neutral. Participate in everything you can. Because if we, as a person, will do some changes, as a person, in the family, in the bigger, will make a change. And the third point that I want to focus, because we are close to their Christmas and to the New Year, and I would like to wish you all the best and happy Christmas and New Year in your family, with your close friends, and so on. All the best to you, and thanks.
Thank you, Angela, for your words and also for your support. And I want Dr. Pedro Gullón, General Director of Public Health of the Ministry of Health here in Spain, to do the closing.
Buona tarda, good afternoon to all of you. I would like to start by thanking all the organizers of the event, starting by WHO and also the Catalan Institute of Oncology, and especially Cristina for everything. It has been a real pleasure to be with you all day. It's not so common, as said Cristina, that I'm able to stay all day in one event. I had to leave for a couple of hours for some meetings, but it was amazing to be here, and it shows the commitment that the Spanish government has now on tobacco control. Here we have seen the gaps in research, the gaps in action, the gaps in implementation, in evaluation, and even we have talked about the future by having a table of early career researchers. That's amazing. That's amazing. And I think we have to be very proud, all of us, from different perspectives, to be able to have this gathering and have this symposium, because it makes, so it's a lot of effort to organize this, and sometimes you don't see if that makes a difference, but it makes a difference. I said in the beginning, in the morning, that all the alliances that we can create through this kind of symposiums are really important, while we have to do the policy and implement this policy and evaluate these policies. I want to say a couple of things about the next steps in Spain, although some things have been spoken throughout the symposium. But I think we have a great opportunity to get new things done. For example, we have the advances on new legislation in this kind of new products. I don't like to talk about new products because they're not new, but about the new products that is coming, helping the first quarter of 2025. Now it's in public hearings, so everyone can make amendments to this legislation. But also in next year we'll have a new law on smoke-free spaces, where we can see how can we advance on smoke-free places, as some of the speakers have said, and especially I like very much the presentation of María José López on the things that we can advance on that issue. Also, we have made advances on taxation. That is something that did not happen in Spain in quite a lot of years, and the Ministry of Finance decided a couple of weeks ago to advance on taxation policies, and we're very happy on that. And also, we have made advances in how to change narratives on tobacco control, and that's something that is not easy. And maybe at the end, I will talk about a little bit about that. But at the same time that we have made great advances, or we are making it right now, there are some things that also have been maybe challenges that we had, or even step backs in tobacco control. And we talked about that this morning. The legislation that passed on the waste of tobacco products, where the industry now has the ability to organize that. And that's a fight that we had between different ministries, because the government has these kind of things, and we lost that fight. We are still trying to fight it, but some things that happen, some things you lose also in the fights. But you have to be really aware of that, and we have to be very active in pursuing these things, because we don't want that to happen. And just to finish in these closing remarks, I want to say something about making policies. I read an article in Science last weekend that talked about that it's not only that politicians do not care about science, because that happens. It's also that researchers didn't know anything about policy, and that's a big issue. And I have both hats, because I'm now a decision maker, but before being that, I was an academic, and I worked in the University of Alcalá with Chisca and the team over there. And I've learned throughout this year that a couple of things that are so important to understand how to make policies. First of all, evidence is not enough. Evidence is not enough. Even if we do it very clear, very funny perspective of showing, evidence is not enough. And the second thing is that not everything is about convincing policymakers. Political will is not enough. Evidence is not enough, and political will is not enough. We are moving with different things, standards, or different things that can happen when we are doing policies. For example, and I think that's the whole perspective on this. Politics and policies are about power. Every time they are about power. They are not about evidence, or just not about evidence, and not only about political will. We need power. We need the power to do these policies. We need this power to implement these policies. For example, and I've been very keen to tell you that we need a critical society against tobacco. We need a critical society against tobacco, and we need to create these alliances. And for that, I said from the beginning that this is very important. This is a very important event, and all of the events that we can have over here are really important in creating a critical society against tobacco. Because it's not only political will, it's not only about evidence, it's about creating power. And that's important, and we know the strategies of the industry. I was showing some pictures to some of you before that there's a big bus that is coming through out the ministry and the parliament in Spain with the vaping industry calling us Ministry of Tobacco or Ministry of Death, just because we are going to regulate vaping. And we want to do that, and we want to be able to do that, but we need also to create these kind of different narratives that can fight the narratives that the industry is having. And the only way of doing that is with a critical society and with the alliances of research, policymakers, and civil society. And we have to make all our efforts in that, because that's the way that we can advance in tobacco control policies in the next years. So taking the message of this symposium, that is how to take decisive actions to move for tobacco control, I think that the most decisive action that we can do is to create these alliances to move forward in tobacco control in the future. Thank you very much.
So with these final remarks, so as I was mentioning before, safe trip homes, and see you for the next 8th Eco Symposium in 2026. Seats, oh my goodness. Thank you very much. Bye-bye.